Dear Professor Sarin, Chair of the Steering Committee of the Apostle, and all AARC members, speakers, thank you for putting the AARC consensus meeting during the Apostle 2021 annual meeting. Alcoholic liver disease is a problem worldwide. The agenda of this meeting is to present the progress as well as to develop a consensus in the management of alcohol-induced Aclf. It is such a good opportunity for all delegates of the Apostle 2021 to have the opportunity to attend this meeting as well as can access to on-demand meeting as well. Thank you all members, especially Professor Ashok Chowdhury, to put together this excellent program during the Apostle 2021. I wish the meeting fruitful and useful to everyone. Thank you.
Thank you, Professor Tanwande, our President Acsl, for sparing time during just after the inaugural ceremony, and I enjoyed the beautiful song that the opening ceremony had. People dancing and also looked very, very vibrant. And that is the spirit with which we will also continue this session. I am grateful to you for allowing us a day to run it concurrently. The topic of alcohol and Aclf is very, very hot, and there are boundaries of Aclf, and we have to see beyond the boundaries. And therefore, to look beyond the boundaries, we have people from different continents, Europe, North America, as well as Asia in this meeting. I have to thank each of the speakers and each of the chairpersons for sparing time. For the matter of records, we have put reporters for every session who will be recording and reporting the correct documents. And if we can develop some evidence-based consensus, it will be useful. And then it will become part of the publication with consent of all the speakers and the data. I would like to thank Ashok, our colleague, who has done immense work, and his team, and I hope they will continue to enrich the field of Acl. With these few words, I want to once again thank the organizing committee of Acsl Bangkok and Thailand for allowing us, and we start the day. Our first presentation is by Professor DJ Kim, who is going to speak on alcoholic hepatitis leading to acute decompensation, Aclf or ESLD, and this will be chaired by three very eminent people, Dr. Jidong Jia, then Dr. Lin, C.Y. Lin, and Dr. Sudhanshu from Kathmandu. So over to Professor Jha if he has joined this session. Professor Jidong Jha, if you have joined. If not, I put on to the other chairpersons, Professor Lin and Professor Sudhanshu.
Okay, so thank you to invite me to chair this section. So it's quite happy that we have the time to gather together to discuss for the Aclf. So now let me to introduce the first speaker, Professor Kim. Actually, he will give us the talk about alcoholic hepatitis leading to the Aclf and ESLD. So it's quite important opening lecture. So we welcome Professor Kim.
Okay, please share my pre-recorded video, please. Dear colleagues, I will briefly talk about alcoholic hepatitis leading to acute decompensation, acute on chronic liver failure, or end-stage liver disease. In patients with alcoholic steatohepatitis, alcoholic hepatitis characterized by jaundice and liver failure may occur. Patients surviving acute alcoholic hepatitis will progress to cirrhosis. In addition, cirrhotic individuals may develop acute alcoholic hepatitis or acute on chronic liver failure with high mortality rates. However, the evolution of alcohol-related liver disease into cirrhosis does not always include distinct episodes of alcoholic hepatitis. Alcoholic hepatitis per se is a clinical syndrome. Since liver biopsy cannot distinguish between alcoholic steatohepatitis and non-alcoholic steatohepatitis, the consensus statement was developed to improve consistency in diagnosis of alcoholic hepatitis. The proposed clinical diagnostic criteria for alcoholic hepatitis are the recent onset of jaundice, elevated serum AST arising on the background of heavy alcohol use, and exclusion of other causes of liver disease. In a recent NIAAA-sponsored consensus meeting, it was proposed that definite alcoholic hepatitis as clinically diagnosed and biopsy-proven, probable AH clinically diagnosed without confounding factors, possible AH clinical diagnosed but with potential confounding factors. The presence of liver decompensation does not exclude the diagnosis of alcoholic hepatitis. However, the clinical features of this syndrome can also result from sepsis, ischemic hepatitis, DILI, gallstone migration, etc. European and American guidelines and guidance and Acsl AASLD joint meeting agreed to the clinical diagnosis of alcoholic hepatitis. Although Acsl clinical practice guidelines did not adopt NIAAA subtypes of alcoholic hepatitis, Acsl AASLD joint meeting adopted it. Different prognostic models have been developed which aim to identify patients at high risk of early deaths using baseline and dynamic variables. It is recommended that available prognostic scores should be used to identify severe forms of alcoholic hepatitis at risk of early mortality, including DF score, MELD score, and REAL score. Recently, the combination of MELD and the REAL model was suggested as an effective predictive algorithm of short-term mortality. Patients with severe alcoholic hepatitis have mortality of up to 30 to 40% at 28 days. However, defining severe alcoholic hepatitis is not consistent. 2018 Acsl guidelines use MDF32 over Glasgow score 9. 2019 AASLD guidelines use MDF32 over MELD 20. Notwithstanding the difference, after Acsl AASLD joint meeting, consensus is evolving toward using MELD score for mortality stratification. Alcoholic hepatitis is often accompanied by a wide variety of extrahepatic manifestations, including neurologic, cardiovascular manifestations, acute kidney injury, and coagulation abnormalities. Most notably, evidence points to a causal link between alcohol consumption and infectious diseases such as bacteremia, SBP, pneumonia, and UTI. At the given time point, these different organs could be found in different stages, as non-detectable, transitory, subclinical, clinical, and finally advanced and irreversible stage. Acute decompensation of cirrhosis is defined by the development of ascites, hepatic encephalopathy, and or varicose bleeding. The first of episode of acute decompensation signals the transition from compensated to decompensated cirrhosis, as well as The course of decompensated cirrhosis is characterized by repeated episodes of acute decompensation. During acute decompensation, patients are extremely prone to developing bacterial infections, to the point that infections have been proposed as the fourth major complication of the disease. Recently, the systemic inflammation hypothesis is proposed as a new paradigm of acute decompensation and acute on chronic liver failure. Mechanisms of acute decompensation and Aclf underpin the link between systemic inflammation and multi-organ dysfunction or failure. This cartoon depicts the relationship among disease spectrum of alcoholic liver disease, acute decompensation or Aclf events, systemic inflammation, and infection or organ failure. This is Aclf defined by AARC, and this is Aclf defined by Eclf. In the Canonic study, active excessive alcohol consumption was recognized as the second most frequent precipitating event of Aclf, up to 25% after bacterial infection. In the AARC data, alcohol consumption is most frequent acute hepatic insult, up to 50%, responsible for Aclf. The difference between European and Asian study is consequential due to the differences in Aclf definitions. Worldwide, alcohol was more common than viral hepatitis as the reported underlying chronic liver disease in Aclf and non-Aclf. The most common etiology of Aclf was alcohol, irrespective of different definitions, as well as alcohol hepatitis over underlying alcoholic cirrhosis is a prototype of Aclf. This is the Canonic study. This is an AARC study. This is a Korean Aclf study. This is a study from United States. Although alcoholic hepatitis over underlying alcoholic cirrhosis is a prototype of Aclf, and severe alcoholic hepatitis can present as Aclf with multi-organ failure, severe alcoholic hepatitis is not always the cause of Aclf in patients with alcoholic liver disease. A study from biopsy-proven Erasmus cohort with an independent validation cohort from the Canonic study showed that Aclf is frequent during the course of severe alcoholic hepatitis and is associated with high mortality. Then, should the diagnosis of Aclf be used in the clinical assessment of severe alcoholic hepatitis? In addition, is alcohol-induced Aclf a specific form of alcoholic liver disease or merely a clinical progression of severe alcoholic hepatitis? These issues need to be further investigated. Of note, any of the guidance, or joint meeting do not incorporate Aclf grades into the diagnosis and severity evaluation of alcoholic hepatitis. This topic will be further addressed in session 5. Alcoholic hepatitis is emerging as a major acute insult or precipitating event in the Asian region. The epidemiology of acute insult has changed significantly in past years. In recent AARC data, alcohol has now emerged as the most common etiology for acute insult as well as for underlying chronic liver disease, in contrast to previous data of HBV predominance. In addition, it should be emphasized that acute decompensation of cirrhosis is a different entity than Aclf in AARC recommendations, and patients with known previous decompensation with jaundice, hepatic encephalopathy, and ascites should be excluded in defining Aclf by AARC recommendations. In summary, alcoholic hepatitis is recognized as a frequent acute insult or precipitating events responsible for Aclf. Grade of evidence A, strength of recommendation not applicable. Alcoholic liver disease is common as the reported underlying chronic liver disease in Aclf and non-Aclf. Grade of evidence A, strength of recommendation not applicable. Alcoholic hepatitis is a systemic inflammatory disease not limited to the liver. Grade of evidence A, strength of recommendation not applicable. The question, should the grade of Aclf be used in severity assessment of alcoholic hepatitis, needs to be further investigated. Thank you for your attention.
The chairperson, Professor Jha, has joined and others.
Yes, thank you. Finally, I could. Thank you.
Comments on the last slide of Professor DJ Kim was very important, which he showed. So, any comments from Dr. Lin or Dr. Jha or Dr. Sudhamshu?
No, I have no further comments. I
I
just attend last 5 minutes. Thank you. Good morning, everyone. Regarding the last point, that inclusion of Aclf in defining severity of alcoholic hepatitis, it needs some clarification, and then maybe we need to incorporate in future. As purely alcoholic hepatitis without cirrhosis, they usually recover, and the mortality in our setting is less, where alcoholic hepatitis is very common. So this inclusion of Aclf in case of severity of alcoholic hepatitis, this should be addressed in future. Thank you.
Yes, I think this is a very important point in the current definition of alcoholic hepatitis, severe alcoholic hepatitis. The acute portal hypertension part, that is development of ascites, is not included. I think if we, do you have consensus statements, Professor Kim? Do you have consensus statement?
Yes,
The 4 statements, are they consensus statements?
can you see my
opinion
slide?
is, can you show one more time, Izumi? The last statement of Professor Kim. Yes. So alcoholic hepatitis is recognized as a frequent acute insult or precipitating event. I think this is very nice. Alcoholic liver disease is common as the reported underlying. This is perfect. Alcoholic hepatitis is a systemic inflammatory disease. And should the grade of Aclf be added in severity assessment of alcoholic hepatitis? So I think, in my opinion, all these are very, very acceptable things. And for the 4th is the only thing where we can have a little debate. So maybe any one of the panel or chairs, in my opinion, it should be part of severity assessment in the alcoholic hepatitis. So maybe we should have a revised definition based on the current thinking, Dr. Kim,
Yeah.
where this consensus will say, I would say we should include the grade of Aclf into severity of alcoholic hepatitis. Okay? Is
Yes,
that all right?
yes, I agree to your opinion, but we have a few well-organized study to prove that
Yes.
if we add on Aclf grade or diagnosis to the current guideline, whether it can added value or not is not confirmed. So my suggestion is after the last session, Professor Mayawar will deal with these issues, severe alcoholic hepatitis with or without Aclf. After her presentation, we will go over it again. It may be.
Very nice.
Yes.
We agree. Any other comment from Dr. Lin, or if not, we move to the
No more comment. It's okay.
Okay. Thank you very much, Professor Kim. Very good presentation, very educative. May we move to...
Can we, sir?
Yes, Dr. Diana. Yes, please.
Can we put the first statement and the third statement together, like alcoholic hepatitis, comma, a systemic inflammatory disease? So it makes the statement compact.
Okay. I think it's a good point. When writing, we can edit it. Thank you.
It becomes only two statements
Yes.
for the first.
Okay. Very nice. May I invite the chairpersons for the next session, Professor Kadir Dokpachi, Professor Diana, and Professor Tanaka, please.
Now, I'm co-chairing together with Professor Diana Alcantara Payawal and Professor Asushi Tanaka. The speaker is Dr. Ashok Chowdhury. He is very, very important for the Aclf for AARC. Now, he's going to speak about Aclf again, defining the entity, spectrum, and relevance from a puzzle perspective. Yes, please, Professor Chowdhury.
So good day, everybody, especially to the Acsl and all the team. So here we're going to cover a totally new area. So there is a limited data. I have nothing to disclose. So just want to say the definition. Everyone is very much aware of that. That it is the definition is an acute hepatic insult leading to a liver failure in a time frame. However, there is a little bit of discrepancy in the definition, both east as well as the west. But the final entity is there is an entity of liver failure with or without extrahepatic organ failure. I want to highlight that liver failure is at the core. Extrahepatic failure may or may not be, and are having a high short-term mortality. And this happens because of an acute insult in underlying chronic liver disease, which leads to the liver failure, that is jaundice, coagulopathy, then ascites or hepatic encephalopathy. And the good part is that there's significant amount of reversal disease seen as per the Aclf Acsl definition, which makes it unique. So now, when there is a significant recovery, so in response to an acute insult, how the liver behaves. So we just want to see how this is behaving. So you can see this is a slide that a compensated cirrhotic. He got an acute hepatic insult. He landed with Aclf or acute decompensation. If those having prior decompensation, they shows an worsening of decompensation called as acute decompensation. If it's already a persistent or end-stage liver disease, they get an acute insult. So there occurs only the progress of the further disease course. However, the Western cohort consider any of these groups all should be Aclf. So that is why the confusion is we need to address, and for which the Aclf Acsl group is working in to include both compensated and decompensated to define how it can happen. And what is the beauty? So to that we have done a large-based analysis of about 4,000 patients of Aclf and the so-called definition of acute decompensation. You can see the long-term survival is close to 40 to 50% in both the groups. And when you go for the survival in short term, it is a acute decompensation has a better, Aclf has a poor. But when you go to survival beyond 2 years, after 24 months, when the acute insult is reversed, the acute decompensation component has a poorer survival, whereas Aclf has a good recovery. And this suggests that Aclf of Acsl is a unique entity where the liver regenerates over the time, maybe Aclf reversal, and this leads to a long-term survival is much better than the acute decompensation group. So this was suggested as our hypothesis initially, that when a patient of Aclf is there who get an acute insult, it shows a recovery. If it is more severe damage and we get a worsening of the disease, which may be require transplant or multiple or death. Whereas this decompensated cirrhosis, which is considered as the Aclf in Western groups, you can see they get repeated insults each time, and over the each time there is a progressive decline in hepatic result and leads to worsening progressively. So there is a chance of recovery in a case of Aclf, whereas in a decompensated cirrhosis there is a poor chance for recovery with each insult because result goes down. So each complication has shown to be its own impact, and this is a study from Korean group. Dr. Kim is also here, and they have some long-term survival if they have a prior decompensation, because the Aclf is considered all the patients of liver failure. So that's why if there is no decompensation previously, has a mortality of less. If acute decompensation is more than 1 year, survival is poor. If more than 1 year, then more than 1 year, the survival is poor. If it is less than 1 year, survival is better. So similarly, as we see that 50% patients in Aclf cohort can recover, you can see this is the treatment we have given to alcoholic hepatitis, you can no survival. Reactivation, they respond to treatments, 2 log reduction, they survive in nearly 2/3. Autoimmune hepatitis flare, they respond. We assess the MELD, they respond. Wilson's, they respond. However, over the time, can have a recidivism, can be a default on hepatitis B, they may have a relapse, and or they develop a Wilson's disease flare, or in any of the disease they develop a delay. So these are the groups which are still not addressed by the Acsl, whether should be considered in Aclf definition or no. If they have recovered completely and in long term, they develop another insult. So because their presentation is like Aclf, whether this Aclf again a concept is existing or no, this is what we need to debate today. So as you see, this is an Aclf patient because of severe alcoholic hepatitis who recovered, because we see in data that transplant survival is close to 50%, but they may have recidivism. They get an acute insult because of DLE, acute viral hepatitis, or any hepatotropic insults. They have those having other etiologies, and they present as a Aclf-like presentations. So, as we suggest, if these patients, as per the current definition of the first time presented with Aclf as bilirubin, INR, ascites, as we defined before, and over the time they get normal or they develop ascites result and get an acute insult, and this leading to similar presentation before. So, what it should be called? So when you go for the data for all liver failure patients from the 6,200 patients from the Acsl group, you can see those having prior decompensation, they have a poor survival, and then those have a index presentation as decompensation more than 1 year or less than 1 year. When you compare, the 1 month mortality is higher, those having a insult within less than 1 year. So it shows that if a liver get repeated insult in a short time frame, they are going to have a poor outcome because the chance of liver recovery or the hepatic result is less. And this is irrespective of the Aclf or AD, it is all liver cirrhosis patients who got an acute insult. However, this is not translated into 1 year survival. Close to survival, 0.052 is the p-value. Then we have analyzed data from, this is usually the data from IL-based only, but however, we request everyone to get the data for this spectrum of ALD. We got 1980 patients of ethanol liver disease. Of this, 26% are the first time presented as a Aclf, which are not analyzed. Those remain abstinence is around 57% as a cirrhotic. You can see in a cirrhotic, recidivism in our cohort is happened in nearly 16% of patients. in response to one recidivism, how they behave. About 17% will come later to definition, but as we suggest the term, they behave like Aclf again in 17%. Acute decompensation as per the established definition in nearly half of the patients, and the liver disease worsened again in another 7%, and another quarter is just the disease remains the same. So just to highlight, in a cirrhosis patient, if had a recidivism, about half of the patients have a acute decompensation, which still not defined as jaundice, ascites, hepatic encephalopathy, bleed, or sepsis. Bilirubin is less than 3. Whereas when you refine to the Acsl definition, 17% are fitting to the definition of Aclf again. So when you go for these patients to have a survival, you can see if the duration of index presentation is more than 1 year, about 27% have a poor survival if it is because of the Aclf in relation to AD. So Aclf patients, if presenting after 1 year of index presentation with an acute recidivism related illness, survival is poor. So that's it is different from the AD. Similarly, if this presentation of duration of illness, if it is 1 month, because we Aclf taken definition as 1 month, and the definition taken 3 months for the AD. So when you analyze for the 1 month, there is a little bit of mortality higher in patients of Aclf again, which needs further value because p-value is 0.06. And in 1 to 3 months also, this value remains same. So here, Aclf again, we need to debate today whether the acute initial duration should be 1 month or 3 months. So that is one food for thought for discussion. So these are 2 questions I have raised here. Then here we have shown how these groups behave. You can see those develop Aclf again, they have a bilirubin is high, but it is small sample size, but they have a bilirubin is less than the Aclf at the index time, and this group have a relatively lower MED score. These patients are relatively have a comparison in relation to Aclf before and the current. If we compare with acute decompensation to the current Aclf, this group have a higher age group, and this group have a lower higher platelets, and they have a INR is on the higher value, and this shows that the mortality is yes, but it is less. So this is also another concept. So when you go for the survival analysis for the 1 year, the Aclf as well as the Aclf again, the mortality nearly behaves the same. So here we just want to highlight the Aclf again is an entity which is nearly similar to the Aclf as far as survival is concerned, bilirubin, CTP, MELD, liver disease scores are concerned. However, the short-term mortality is a high than the acute decompensation. So it's a different entity from the acute decompensation. So here, as we discussed that this should be a debate whether what we should suggest. So from our side, we suggested that this bilirubin should be normal, or it should be bilirubin less than 3, or it should be less than half. This is the debate to be considered today, and the definition of the final part should the bilirubin value. So this is what we suggest from the Aclf again for the definitions. And so finally, to getting a consensus, we need to debate today what should be the timing of recovery from the index presentation. Alcoholic hepatitis, Aclf recovered, then develop another recidivism or any other acute incident leading to the liver failure akin to Aclf again. So this period should be, recovery should be 3 months, 6 months, 1 year. We need to data, and hopefully in consensus we can get some idea. Then which criteria should be considered? Is the parent Aclf definition with 1 month bilirubin value, or the AD definition should be considered, or we should consider this bilirubin should be reduction by 50% from the baseline, or normalized to the full, depend upon a recovery scale. And what are the presentations at index? Many patients of alcoholics present only with jaundice, then in subsequently long period follow-up they develop jaundice and ascites also, whether they should be considered or not. And obviously the current presentation should be as per the Aclf definition we suggested, but we need to debate. Okay. So I request everybody's input on this consensus statement which is proposed, suggested by me, and it is open for debate for the House. I request the House to get input or feedback. Am I audible? The panelists, please, I request some input.
Hello.
Yeah, please.
Yeah, I'm Dr. Ashish. Can you hear me?
Yeah, you are very much audible, sir.
Yeah. So I just wanted to make a comment that when we already have a definition of ACLF, why do you want to have a new definition of ACLF again? Since you have already shown that the survival of the both are same, and also it will be very difficult for this diagnosis to be made, because sometimes the patient would not give a prior history of having decompensated. They may have come from some other region and all. So why we to a new confusion? Which way the condition is fitting and also the survival is same in both the conditions? Dr. Ashok?
Yes, sir. Suggestions are very, yeah. Please.
We ask the chair people to first comment, please. Dr. Kadir, Dr. Diana, Dr. Tanaka, please, on the consensus statements.
Can I give my comment? Thank you for your statement, Ashok. I do agree with the first, but my issue here is: did you define alcohol, the safe limits of alcohol in these cases? Because they have said that if you have a fatty liver and even drink a light alcohol, then that puts you already in a risk to develop alcohol liver related diseases. So my issue here is, can we define first the limits of alcohol that you have included in the study? Or are you saying all of these patients just drink alone and do not have the syndrome of muffled?
Yeah, that is a very nice suggestion, because we see nearly one third have having no postnatal liver disease, so we need to address that also.
So I think we need to make a distinction, because when you put the statement ACLF due to ethanol have a long-term survival, I think this has great impact on the on taking care of patients with such, because if you they might have a wrong notation that patients who drink alcohol have better survival than those on other chronic liver diseases. So maybe just a rewording of the first statement.
Yes, I think it's a very important point. I agree with you, Diana. This needs to be reworded. It gives slightly different message. I would like you to all comment upon the point of discussion is that person who has been drinking alcohol and had ACLF at jaundice and ascites or HE, if he stops drinking for 3 months or 6 months, then he starts drinking again.
This is the risk.
Suppose his bilirubin remains above 5 already, it never comes down. His bilirubin was 20 and it comes down to, let's say, 6. Now he starts drinking and it goes up. We will continue to say that yes, this guy has gone worse. But suppose his bilirubin has come below 5, it is 3 or 4, and then he starts drinking. He gets it again above 5. What will you call it, and how should we analyze? It's a disease continuum. It's not off and on. So how do we label this? This is the key issue, and the data what Dr. Ashok has presented shows that this is more difficult to diagnose. So I want comments of the chairpersons as well as other members.
So can I comment on this?
Yes.
Hello?
Yes,
So
please.
I had a point that in the data which Ashok had shown, Ashok, did we see that how many patients in the group had come down to this definition? Because to say again, we have to first show that the patient had reversal of the syndrome. That is my first point. Second point is, did we have histological biopsies, histological tissue of these patients in the two groups to tell us whether the disease, the way, because if you're defining it ACLF again, then should we be treating it and managing these patients same way? That also comes. So therefore, it's important. How many of these patients had liver biopsy? How many underwent corticosteroid treatment? Their responses, infections, and all those complications which we see in ACLF, alcohol related, has to be compared also.
Dr. Ashok,
Yeah.
can I make a point here?
Yeah.
Yeah, this is Dr. Duseja. I think the point I was thinking, prospectively, if a patient comes today and he recovers, he's ACLF today, alcohol, he recovers and has another decompensation which is also fitting into ACLF, and we are trying to call it as ACLF again, is very well acceptable. But then suppose the patient who has come today, index patient, who is ACLF today, and he gives us an history that 1 year back also he has had decompensation, and he has all the data which was nothing but ACLF fitting into a Acsl definition. That time also he had left alcohol. He had recovered 1 year, and 1 year later today is index patient presentation with you. So by the Acsl definition, his past decompensation, we may not be able to include him as ACLF today. So tomorrow we want to include him, but not today. So what I'm saying is, with this ACLF again, we would also have to take into consideration the past decompensation. If that is amounting to ACLF, and today the patient is coming, and that time also we have to call him as ACLF again. So I think our thinking about that the past decompensation should not be there in a Acsl ACLF, I think we will have to discuss on that issue also.
Yeah. Totally agree, Professor Duseja. The reason this kind of presentation generally with jaundice and ascites, recovering and again coming is less common in patients who have hepatitis B or C or even NASH, but it is common in autoimmune as well as alcohol. So I think we need to reassess it. We need to have more data on this, the point which other colleagues, Dr. Ashish, Dr. Rakhi and others have said. So I would say, as far as consensus is concerned, we need to reword it, as Dr. Diana also said. But we need to think positively, and I think one of the statements can be that there is a need to assess the data and its relevance based on prior treatment, prior histology, and whether recidivism in reference to alcohol makes it again ACLF. Suppose he has recovered and he was normal, bilirubin was let's say less than 1.5 or 1, and he drinks and again gets ACLF, I think this can be more clear. But if we never got normal, what should we do? So to me, it remains open, and I think the definition needs more data and more publications on this. If that is acceptable, Dr. Diana, Dr. Tanaka, and Dr. Kadir.
Yes, Professor Starin. First of all, thanks for the Ashok because of his excellent presentation. And I would like to point out that there is still a lack of the definition for the ACLF, not only for alcohol, also alcohol, because I think we need all the study groups has to come together, and we have to make a consensus for the definition of ACLF. Maybe you remember Professor Richard Moore attended to AARC meetings in New Delhi, I think 4 years ago, and we discussed about that. I think we need a kind of summit for the making exact definition of the ACLF in the future. Thank you.
Yes, Professor, this is Atsushi Tanaka from Tokyo, Japan. So I greatly appreciate Ashok's presentation, and I totally agree with Professor Dogmechi's remark. So we need to go together more data and make a better consensus for the definition of ACLF. Yeah, that's my opinion.
From my end, I think before we start anything, we should be clear on definition of terms, because everybody will be basing their analysis on the definition of ACLF on our end. So I guess we need to convene together again and come up with it. So I thank Dr. Ashok for this good presentation.
Okay, thank you all. So the field is wide open and we need more data, and we will word the consensus very carefully. Thank you, Dr. Ashok, and I would like now to invite Professor Yang, Professor Duseja, and Professor Yu to chair the next session, where we have Dr. Zabo from the US. It must be midnight for her to talk on risk profiling for alcohol ACLF, considering underlying etiology, comorbidity, and genetic susceptibility. I hand over to the chair, Professor Yang.
Thank you, interesting Professor Sarin. My name is Jim Moyang from Seoul, and the co-chair is Ajay Duseja from Chandri, and the co-chair is Chen Yu is China. So I introduce again the next speaker, Professor Zabo. She is now work at Harvard University, USA, and as you all know, she is famous in the world for alcoholic hepatitis and the liver failure field. Please, Professor Zabo, please. Are you ready?
So Professor Sarin and Professor Yang, can you hear me?
Yes.
Yeah, you can hear.
Perfect, thank you. So I apologize, it sounds like my previous presentation didn't make it, although I submitted it yesterday. So let me start out with thanking you for the opportunity to present here. And so I was asked to talk about risk profiling for alcohol, ACLF, underlying etiology, comorbidity, and genetic susceptibility. These are my disclosures that really don't have any direct relevance to this presentation. So as this audience very well knows, ACLF is defined as a secondary insult on a liver that has developed advanced fibrosis or cirrhosis on the basis of various etiologies. And during ACLF, then there is a major kind of decompensation and inflammation component that results in multi-organ failure and very often severe and morbid outcome in these patients. Now, ACLF can occur at various stages of cirrhosis. It can be triggered in compensated, decompensated, or even further decompensated livers. And it has been shown that the insult that triggers the Aclf very often is alcoholic hepatitis, but viral hepatitis, drug-induced liver injury, and indirect events such as infection and sepsis and GI hemorrhage are also very often causes for inducing the Aclf. In the decompensated cirrhosis, this event can also result in the Aclf that then can goes on to liver failure, and very often with extrahepatic manifestation with acute kidney injury, circulatory failure, and pulmonary failure, very often leading to multi-organ dysfunction and death. The mortality, 28-day mortality being about only 15%, greater than 15%. So when we look at the various studies that evaluated the triggers for Aclf, alcohol use and active alcohol use in the past 3 months has been identified as a very common and in some of the studies the leading cause. So, for example, in the canonic study, it was 24.5% of the cases, whereas in this other study it was only 6.1. And I need to point out also that in larger percent of patients, actually, the cause may not be very easily identifiable. However, definitely there is a major concern about alcohol as a trigger in the setting of various types of chronic liver injuries. So if we just look at the alcoholic liver disease, very often these patients over time in the black line develop fatty liver and steatohepatitis and cirrhosis. Over time, that could be very quiet. But as we well know, the acute alcoholic hepatitis episodes kind of compound on these otherwise quiet kind of progression of disease and result in acute mortality events. Sometimes patients present with this acute alcoholic hepatitis, they can recover, and then the same patient a few months later, if they continue to use alcohol, could come back with another episode. The triggers for these episodes are really not very well understood. And in fact, we know when these patients develop alcohol-induced cirrhosis and come back with another bout of acute alcoholic hepatitis, that at that point, very likely these patients actually meet the criteria for Aclf, because now this acute event is in a setting of an existing cirrhosis. So I think the point I'm trying to make is that while I think it's very clear that alcohol and heavy alcohol use, particularly alcohol binge, can be a trigger for developing Aclf in the setting of various types of chronic cirrhosis based on viral hepatitis, autoimmune disease, NASH, or alcohol, then not necessarily every alcoholic hepatitis event is an Aclf event. In fact, in the early phase of alcohol-induced liver damage, such as in steatosis or in early steatosis with moderate alcoholic inflammatory components, binge alcohol drinking can induce the classical syndrome of severe alcoholic hepatitis in the absence of an underlying cirrhosis. And in these patients, we find similar to what would be in Aclf, increased bilirubin, increased pro-inflammatory cytokines, multi-organ dysfunction, increased mortality. At the same time, some patients who do have cirrhosis on the basis of alcohol use then could be yet again triggered to have a classic alcohol-induced Aclf with all the outcomes that have been nicely described in the previous 2 talks. So I think it's important to look at, when we look at the risk profiling for alcohol, Aclf, understanding underlying etiologies. And in fact, both in alcoholic hepatitis and Aclf, there are common elements that include hepatocyte damage, whether it's from alcohol or the underlying etiology of cirrhosis, for example, chronic viral hepatitis. In both of these cases, there is change in gut permeability and the microbiome. Alcohol itself can cause both of these, but we know that portal hypertension that develops on the basis of any kind of other liver etiology for cirrhosis presents with increased gut permeability and microbiome changes. And on the top of that, all of this is compounded by innate immune activation and more importantly, impaired regeneration that has been shown to be linked to both alcohol use and also to the cirrhotic liver. So I think the concept of inflammation ACLF is well described, and this includes activation of innate immune recognition pathways such as toll-like receptors and inflammasomes, various danger signals that could be coming from just simply the endogenous danger signals from damaged hepatocytes, and also pathogen-associated danger signals that most likely are derived from the gut as a result of increased gut leakiness. All of these leading to immune cell activation, production of chemokines, cytokines, where the role of various immune cells, macrophages, Kupffer cells, and neutrophils play a major role. And indeed, if we just look at the liver very simply, then these danger signals result in recruitment of these inflammatory cells to the liver, particularly to the space of this cell, but these cells actually can penetrate into the liver parenchyma to result in cytokine induced damage, and also in systemic levels of increase of these cytokines in ACLF. So as described before, the impaired gut-liver axis in cirrhosis and in alcoholic liver disease is not a new concept. This has been around for quite a while, and this is really just the loss of the barrier function in the gut that relates to delivery of various pathogen molecules to the liver to induce pro-inflammatory cytokine induction, and essentially a disbalance in between the gut and liver hemostasis. We know that even in healthy individuals, binge drinking, that is, in this case, was 50 grams of alcohol in one setting, results in bacterial translocation as measured by serum LPS levels or bacterial DNA. And this is also true in cirrhosis and to a greater extent in alcoholic liver disease. So these various danger signals that we are talking about could be either coming from pathogens, either from infection or from the gut microbiome, as simply as that. And also could be steroid danger signals coming from damaged cells in various forms of these molecules. And it has been very well described that these damage-associated sterile inflammatory molecules, also called DAMs, can come either from damaged hepatocytes, from activated cells such as the immune cells or stressed cells, and then they come in various forms, and I'm not going to read all of these, but as you can imagine, there are multiple types of those. But all of these, in general, result in activation of immune cells, migration and recruitment of immune cells to the liver, and release of further pro-inflammatory mediators that are triggered by these precipitants of ACLF, whether these are drugs, hypotension, hypoxia, metabolic stress, or alcohol. So if we look in patients with alcoholic hepatitis, and this patient population was not selected in between pure alcoholic hepatitis or ACLF, but compared to normal controls, it's very clear that there is a major, massive increase in serum endotoxin, bacterial DNA levels, soluble CD14 that shows an immune reaction to all of these signals, and also in cytokeratin 18 that is one of the markers of hepatocyte damage in alcoholic hepatitis. And when we look at patients with ACLF, then we can see that the organ failure and the number of organs that are involved in acute liver failure correlates with the levels of the steroid danger signals, such as HMGB1 or the receptor rage or soluble rage for these steroid danger signals. Now, these various pathogen-associated or damage-associated molecules then are being sensed by the evolutionarily conserved receptor complexes of TLRs or the intracellular node-like receptors that lead to the inflammasome activation that contributes to the cleavage and biologically active IL-1 beta production. So what we know is that IL-1 beta, in fact, is important in sustaining inflammation, both in alcoholic liver disease and very likely in ACLS as well, because it can upregulate various cytokines and result in more accelerated production of all these pro-inflammatory cytokines. It's important to note, though, that IL-1 beta also has the sensitization to hepatocyte death induced by TNF. It impairs liver regeneration and promotes fibrosis. All of these are very important components in the prognostication and the risk factors for survival in ACLF. The cytokine storm that is induced during ACLF and also during alcoholic hepatitis contributes to the various aspects of the multi-organ failure that we see in these patients through these various mechanisms. And in fact, it has been shown that in SIRS, that is associated with, again, the early phase of ACLF and early phase of alcoholic hepatitis can be very critical. And as some of the studies showed, the kind of golden window, if you will, for intervention in the first 7 days, then can bypass. And when it happens, then these patients, whether they are ACLS of alcohol, can then go into this sort of immune tolerance and exhaustion phase with delayed adaptive immune responses that typically leads to very poor clinical outcomes. So in summary, when we look at the toll-like receptor and node-like receptor pathways, those are all involved in inflammation in both alcoholic liver disease and ACLF. Both gut-derived and steroid danger signals contribute, and these inflammatory cytokines then mediate many of the clinical symptoms of ACLF. So when we look at the risk profiling for ACLF in alcohol-induced ACLF, then I think bacterial infections also are a major component in the risk and the determinations of the outcome of these patients. So one of the components that I think we have to remind ourselves is that both cirrhosis and alcohol have common elements when it comes to the immune functions. And namely, both of them result in a kind of subclinical immunosuppression. And multiple studies showed that there is a reduction in the neutrophil functions, for example, to fulfill their host defense activities with reduced chemotaxis, reduced phagocytic activity. This also is true for monocytes and macrophages, while these same cells can produce high levels of kind of non-specific inflammatory activation with pro-inflammatory cytokines. The lymphocyte population is also abnormal. Typically, T cells have a reduced function that induced by alcohol, particularly when it comes to antigen-specific T cell responses. And these all contribute to an immune dysfunction. So we have to remind ourselves that this sustained low-grade stimulation and inflammation goes along with an altered response to the normal phagocytic activity and essentially defense against infections, making this patient population very susceptible to infections. So interestingly, these studies also looked at another risk factor for the length of hospitalization and hospital charges in ACLF, and found that that depending on the underlying reason for the liver cirrhosis, then patients may have different length of hospitalization, and also the cost associated with that goes hand in hand. And it's interesting that in alcohol-induced alcohol-related cirrhosis that then is the basis for ACLF, the hospitalization number of days was interestingly lower than that is induced by NASH cirrhosis. In another study, they looked at the etiology-based trends based on for the intra-hospital mortality, and it was found again that patients with viral hepatitis seem to have a little higher likelihood of intra-hospital mortality, but certainly patients with the alcoholic liver disease background also had very high rate of mortality, somewhat less in patients with NASH background. I think when we talk about risk profiling of alcohol and Aclf, we definitely need to think about genetic susceptibility. So it turns out that certain genes are common when it comes to the risk factors for non-alcoholic fatty liver disease, alcoholic hepatitis, or even for some of the viral hepatitis and Hep CV. Particularly PNPLA3 has been identified as the steatosis gene. The TM6SF2 predisposes patients for fibrosis, and the MBOT7 for fibrosis gene. These are typically associated with the underlying disease and the development of cirrhosis, but nonetheless play a role in the kind of likelihood of getting to the point of cirrhosis and therefore being susceptible for Aclf. Specifically, some studies actually looked at the genetic correlations with Aclf. And I'm not going to have time to get into all of these details, but I wanted to point out that it's very interesting and potentially it's informative that some genes that are involved in regulation of inflammation in particular have been identified as Aclf-associated genes. So for example, microRNA 146 is a microRNA that is a key regulator of inflammation. And perhaps it's not that surprising then that studies found that single nucleotide polymorphism in the microRNA 146 gene actually correlated with severity and outcomes in Aclf. Toll-like receptor 3 is another key element in recognition of danger signals with double-stranded RNA and immune responses. And interestingly, that has also been identified in an Aclf-associated gene. Finally, I also wanted to point out that there is evidence for IL-1 family members and genes potentially being risk factors for Aclf. So studies found that polymorphism in the IL-1 beta and the IL-1 receptor antagonist gene actually can correlate with survival in Aclf. And in fact, Aclf family members, particularly the certain genotypes of IL-1 beta and IL-1 receptor antagonist, correlated with the grade severity of Aclf and also with survival of patients who presented with Aclf. So to summarize, some of the key takeaways are that both the toll-like receptor and nod-like receptor sensors are involved in inflammation and Aclf. Both gut-derived and stereo danger signals accumulate with increasing complexity of Aclf and contribute to the disease. The pro-inflammatory cytokines can amplify inflammation and hepatocyte damage, and these inflammatory cytokines actually mediate many of the clinical symptoms of Aclf. So comorbidity, genetic factors, and underlying etiologies all kind of play into the complex picture of severity and outcomes of Aclf. So for the consensus statement, I would suggest that we consider that not all acute alcoholic hepatitis is Aclf. The clinical presentation of alcoholic hepatitis in the setting of cirrhosis, however, very often meets the criteria for Aclf. And the pro-inflammatory cytokines amplify inflammation and hepatocyte damage in Aclf, and the inflammatory cytokines mediate many of the clinical symptoms that we see in these patients with Aclf. Thank you very much for your attention.
Thank you for nice presentation, Professor Stavo. And is there any comment or question from audience?
Yeah, can I make a comment here?
Absolutely.
Yeah, very nice talk, Professor Szabo. And the only thing, recently we had analyzed the AARC data and which we published this year. And this was on the metabolic risk factors, as comorbidities in Aclf. And what we had shown in more than 1,000 patients ARC data was that if somebody is overweight or obese or has dyslipidemia, his chance and has alcohol ACLF, he's more likely to have number one, severe liver disease. We looked at the ARC score, MELD score, and the other severity. And also the 30-day mortality was higher if somebody was overweight and obese. So metabolic risk factors we thought were very, very important comorbidities which were determining the severity and mortality in patients with alcohol-related ACLF. There is also canonic data where they had shown that if you are overweight or obese, that is also putting you at a higher risk of developing ACLF. So your risk of developing ACLF is high, your risk of severity is high, and your risk of mortality is high if you're overweight or obese or have other metabolic risk factors. Your comments, and I personally feel we must include that in the consensus statements.
I totally agree with you, and in fact, I did not go into the obesity component because I realized that in the program there are some talks that will cover the metabolic syndrome and the metabolic component. So that's why I kind of avoided that. But absolutely, that's totally true. And in fact, the genetic predisposition with the PNPLA3 kind of speaks to that too. I think the data now, in addition to what your group nicely showed, clearly indicates that even the development of the cirrhosis in the setting of obesity and binge drinking, even not even necessarily constant alcohol use, is a major risk factor for a progressive and accelerated disease development. Previous data from the diabetes literature has also shown that people who have diabetes are more prone to have a more severe outcome in any kind of sepsis setting, right? Because diabetes kind of is associated with similarly increased low-grade inflammation, not necessarily to the extent that you see in ACLF, but kind of a reprogramming of the immune response, for example, in a way that there is some inflammation, but there is a defect in the host response against infections. So I think all of these nicely come together, and certainly your study was very elegant.
May I ask a question?
Of course.
You mentioned about gut-liver axis and the absorption of endotoxins. So if we target leaky gut, can we prevent or mitigate some of the sequelae of ACLF, especially alcohol-induced ACLF?
I would say yes. The only challenge is that it's not that easy to mitigate the leaky gut, and I think again I don't think we have good enough studies on this. But because portal hypertension itself contributes to microbial changes in the microbiome and also in gut permeability, I think it's a compound effect when patients with cirrhosis then have alcohol use, and now you have the effects of the alcohol on the top of the portal hypertension, and both of those contribute to inflammation in the gut, particularly in the small bowel and the proximal small bowel, where a lot of these normally the proximal small bowel has very few bacteria, whereas in patients with cirrhosis and or alcohol use, that kind of changes and provides an environment where bacterial components can enter the circulation and essentially trigger the inflammation.
Thank you, Dr. Zabo, for a very elegant presentation. And I think in the interest of time, I would like to say the consensus statement which you have very kindly developed may be worked out with the other chairpersons very soon, and then maybe we can include them as final. And definitely gut microbiome part is very important, and I think Professor Bajaj is waiting for his turn. It's midnight for him. So thank you very much, Yonge, and with this I would like to say invite the next session, people. Thank you.
Thank you.
And
Thanks, everyone. Have a
thanks.
good night.
I'd like to invite Jacob, George, Dr. Dhiman, and Dr. Wasim Jafri for the next session, which is by Professor Jas Bajaj. Is Dr. Bajaj is still awake? And
Yes.
yes, I'm awake. Okay.
Yogi and I are in the same time zone.
Oh, you're at the same time zone? I didn't
Yes.
realize. Okay.
Yes.
Okay, so please, the chairpersons may kindly take over. Yeah.
Hi, good morning, good afternoon, good evening, wherever you are, and it's a pleasure to be amongst you this morning in Karachi, at least. Having had a wonderful session since morning, and do I have Professor George Jacob and Damon already joined or joining? Yes, thank you very much. And we have a great speaker for this session, and already we have heard, from all the speakers that have so many highlighted the alcohol-induced or alcohol contributing to ACLF. Gut microbiome and the impact of gut. Everything that goes into the gut certainly has got an impact all over the body, no matter what we are discussing. And hence, liver receives all what we do with our gut, and it has got a great impact in the microbiome that really is creating every kind of problem for us these days. So, and for this session, of course, one of the best speakers in the world who has contributed enormously to this concept of gut microbiome in general, particularly, and for the liver ailments. So let's not spend more time now and try to get onto it and hear what Dr. Bajaj has to tell us about the gut microbiome in alcohol ACLF, impact, outcome, and guidance for therapy. My other co-speakers may like to share a little comment before he starts, and please.
Yeah, Professor Wasim, just to interrupt in between, we have the reporter is Dr. Amna. I think Dr. Amna is here. Okay, so she is the reporter for this session. So I request please keep the note of all the proceedings, and you are the person to decide us. So please, Amna, be there. Okay. So next to chairperson, please.
You're muted, Radha Dhiman.
Yeah. Okay.
Yes,
Okay.
start, yeah.
Yeah, it's Jacob George ringing from or tuning in from Sydney. Welcome everyone to this session, and I think there is no other expert to talk about the gut microbiota in this disease than Jas Bajaj. He's published extensively, including in Nature, so it is a great pleasure to have him join us and give this keynote speech.
Okay. Can you see this screen? I'll start. I'm sharing, and I will. Okay. Well, thank you all. So what I'm going to talk about is there's a lot to discuss and there's a lot to unpack, and we want to make sure that we are finished on time. But there is something here that I think would be of interest to almost everyone here. So let's talk about the bacteria, microbiome, and virome in advanced liver disease, alcoholic hepatitis, and ACLF. Because, as Dr. Yabo correctly pointed out, there's a big overlap between where advanced liver disease ends, where alcoholic hepatitis starts, and where ACLF is. So I'm kind of putting them all as a continuum in which people can go freely from back to before and after. Let's talk about what the changes in the microbiome and composition are in advanced liver disease, how we can use them for predicting outcomes, and what are the future directions. So let's talk about cirrhosis, alcohol, and gut microbiota. And before we think that the gut microbiota is one unique thing that is stable, we have to remember that many aspects go into deciding what your gut microbiota is at this moment in time. It is quite labile. If you think about what can affect it: antibiotics, medicine, diet, organ failures, the genes that you have, that includes the ethnicity, that includes a lot of the social cultural practices, antibiotics, comorbid conditions, liver disease etiology, the stage of liver disease, and of course, active alcohol. So lest we confuse the microbiota for every person as being one unique thing, this is something that we want to make sure that is actually, that we realize that it's not 100% stable between people. In this nice review headed by Dr. Sareen in 2019, it tells you, breaks down the gut microbiome in people with alcoholic hepatitis, not just the microbiome, not what just the microbiome, composition, but also the effect on the metabolites. So many things that are produced by the microbiome, many things are produced that make the host make other things, and was already talked about elegantly in the prior speeches, and I'm not going to go over that in detail. So where this actually becomes an issue is severe alcoholic hepatitis, of course, in the setting of Aclf as well as in alcohol-related liver disease. And this is where I think the crying need currently is for treating patients who are steroid ineligible. And this is something where potentially microbial inflammation can be of benefit in these situations. So as far as cirrhosis is concerned, it's very easy for us to conceptualize what is quote unquote good bacteria and what is quote unquote bad bacteria. Of course, given the situations that I previously described to you, one bacteria may be good in someone else compared to the other, but by and large, typically bacteria belonging to the families Lactobacillus and Ruminococcaceae are usually bacteria that produce short chain fatty acids, make secondary bile acids, are usually actually good. So if those bacteria are on the top, and in the bottom are bacteria such as Enterobacteriaceae, which include all the gram-negative rods such as E. coli, Klebsiella, etc., we come up with a ratio. So what we want to find out is whether this ratio can differentiate between people who are healthy versus unhealthy. So good bacteria on the top, bad bacteria in the bottom, a high ratio means everything is okay. So healthy controls had the best dysbiosis ratio, whereas infected inpatients, which are decompensated outpatients and infected inpatients, had a lower ratio. Moreover, this was stable over time. It worsens with the development of the first episode of encephalopathy and was worse in those who were actually hospitalized later. Moreover, this got better after the patients got a liver transplant. This was done using 16S sequencing, which we know, let me see why it's not going any further. And there are some other tend also to actually do this with metagenomics, which goes much deeper. So what are the challenges with Aclf as well as in microbiota changes? We know one of the most important complications and precipitating factors, regardless of Aclf in the setting of acute alcoholic hepatitis or not, is bacterial infections. Not only is bacterial infections important, which depend on the immune dysfunction, alterations of the microbiota and the genetic factors, this is also very important to see what multi-drug resistance can happen. In this nice study done in which many people in Asia, this was the European study, but there was also the larger study done, a global network which had many Asian centers as well, which tells you that the multi-drug resistant organisms are even worse. So what we want to make sure is not only do we find out what bacteria are important, but what their resistance patterns is to actually make this better. So this is the other study I was talking about, is the cirrhosis leading to bacterial infection leading to mortality, including with multi-drug resistant organisms, and this can be very high. In this global study, it was 34%. In certain parts of the world, it was even higher, as you can see in this red bar. So not only do we need to know the microbiota to see who develops Aclf, how they're going to do this, but also to figure out who has infection and who possibly has multi-drug resistant organism infection. So can we predict on admission the groups who will develop organ failures, die or be transferred to hospice, in whom care will be futile, and to find out whether fungi and viruses, in addition to the bacteria, have anything to do with us actually predicting this. So this is all important for us to do on admission, because as we know, the diagnostic criteria for ACLF currently are usually when the patient is already very sick. And by that time, the horse may have already left the barn. What we want to do is to try and predict it and to see if microbiota composition or function can add to it. So again, like the microbiota, ACLF is also a rapidly changing condition. We know from day to day, the same patient is not the same. On the left-hand side, you can see the course of ACLF. It varies for patient from 0, 1, 2, and etc., etc. And again, the course here is very variable, but once someone has reached ACLF3, according to the Eclf criteria, it is pretty bad. And to reiterate, microbiota are unstable and a part of it, ACLF is unstable and a part of it. So we want to take all these findings in the context of your particular patient and not generalize it. What about hepatic encephalopathy in the inpatient setting, which often complicates alcohol-related hepatitis as well as other decompensated cirrhosis? In this study from Taiwan, the patients who were admitted with acute episodes of encephalopathy had a higher relative abundance of things such as Veillonella parvula, which is an oral bug, Prevotella, which is another oral bug, Enterococcus, which we know is not very good for you, and lower allistites, which produce secondary bile acids. And this was compared to healthy controls, compensated cirrhosis, and decompensated patients. And this was able to differentiate who came back alive and who did not come back at all. So this was important for us to know that the microbiota, at least in encephalopathy setting, was important. What about in predicting organ failures, 30-day mortality in single center studies? In our study that we had done in 2014, we divided patients who were admitted as well as healthy controls. You can see the controls here are in the red. This is the microbiota of this group of patients. And things that are clustered closer together means the microbes are related. Things that are clustered far apart, the microbes are a little different from each other. Anything in the red dots are healthy controls. Anything in the blue in between are the patients who were admitted with cirrhosis but did not die or develop organ failure. And anything in the green tells you that these people actually died or had organ failure. Mind you, this is on admission, apart from the controls who were not admitted, of course. These are people who are admitted. And while they were admitted, we were doing everything in our power to save them, to give them all the therapies they need. But these people still died, and their microbes were still different on admission compared to those who didn't. And this was then further replicated in another study from China, in which they not only did the admission microbes, but collect the microbes every day. And you can see in the red circles on your right-hand side are the microbes of the patients who ultimately ended up dying, compared to the blue triangles are the microbes of the patients who ended up surviving. And you can see there is still clustering, even though those people were treated and microbes were taken every day. So significantly higher endotoxin, lower lacnospiracy and veillonellacea, and lower dysbiosis on admission predicted in our large study, and lower lacnospiracy, remember the same bug, which produces short chain fatty acids, had independent prediction of mortality in these patients. So what it tells us here is the microbe change happens very early, is relatively durable, and maybe, I would say, unfixable at the change when their patients are hospitalized. So you want to shift the arena a little bit towards the outpatient or the decompensation patient side. What about circulating microbiota? In this nice study again from China, circulating bacterial DNA in patients with hepatitis B ACLF could also predict outcomes. And what was it here? You see survivors are in the red and deceased are in the green. So enterobacteriaceae, again, this is the bottom part of the ratio, which includes gram-negative raws such as Klebsiella and E. coli, are higher in people who died, and this is in their blood. This is circulating microbiota. And this was independently predicted with age and gender, and the other ACLF score, which was the Chinese Society ACLF score. Regardless of how you classify ACLF, it is quite clear once you develop ACLF, the bacteria are pretty bad, and some bacteria can actually predict who develops this in the future. So these are all single center studies. What about multi-center studies? In an Acsl consortium, we took 181 patients, and we actually did the analysis of alive, dead, and hospice, ACF development, ICU, and no ICU. Again, these are admission microbial analysis. And you can see Enterococcus was higher in people who died, and so were many proteobacteria, which includes all the Enterobacteriaceae and the gram-negative rods. What about in ICU? Lacnospiraceae, remember this good bug that was also shown in the single center studies? Well, we confirmed that in the multi-center study as well on admission. And ACLF, again, all these relatively bad bugs were higher on presentation. And mind you, these were independent of clinical parameters. So that was 16S study. 16S only goes to the level of the genus. In this study done from a single center in Spain, they took healthy, compensated, decompensated in patients with ACLF. And again, the gene richness or the rate goes down, which means these patients are often on antibiotics, these things get killed. And these are not on admission, remember. These are when the patients are all over the place, whenever they got the patient, the diet was not controlled, but still it proves a concept that people who die versus are alive, even with metagenomics, show similar changes with survival. So microbiome, regardless of what you have, whether it's acute decompensation or ACLF, whether it's because of alcohol or not, may be very important at baseline to figure out what happens to these patients at the end. What about the non-bacterial components? Let's talk about the microbiota, which is the actual the fungi in alcoholic hepatitis. These 9 sets of studies from Dr. Schnabel's lab showed that exotoxin of Candida, which is Candida lysine, enhances ethanol-induced toxicity in mice, and then is associated with severity of liver disease and mortality in patients with alcoholic hepatitis. Then they went one step further, and it's not just the microbiota itself, it's the actual exposure to it, the antigen with this ASCA. For those of us who work in inflammatory bowel disease, this is something that is present. They've used a lot in inflammatory bowel disease as a measure of exposure to this bug or this fungus. And you can see the survival probability in those who had high versus low was very different in people who had this, even within alcoholic hepatitis. So it's not just the bacteria, it may just also be the fungi that do this as well. Can we then extrapolate this? Can we also do this in cirrhosis? Because these two stories go hand in hand. You never know who has cirrhosis, who doesn't have cirrhosis once they come with ACLF, because things get very muddled. And you don't know which person in cirrhosis is going to develop alcohol-related hepatitis later, and who has which of alcoholic hepatitis develops ACLF. So then I said at the beginning of the talk, I'm trying to take both of these, all three of these interchangeably, because one may lead to the other, and so on and so forth. In this study, across Acsl, 2,700 patients were taken, and 134, which is 10% of the people who developed infection, had actually had a fungal infection. Importantly, most of these patients had prior bacterial infections. Very few of them had a fungal infection without a bacterial infection before, which means they were exposed to antibiotics. And you can see the mortality rate was significantly higher, 57 to 64% in fungemia and peritoneal. But even things such as esophageal candidiasis was a marker of a poor prognosis. And this is a little higher, actually way higher, than simple bacterial infection without fungal infection on top of it. So what happens to the diversity of these patients? The fungal diversity is on the left-hand side. The low diversity is usually considered bad. These are controls, these are outpatients, and these are inpatients. You can see the diversity goes down, which mirrors the bacterial diversity. And why is that? It is because the fungi are saprophytes, and simply they rely on a lot of the bacteria for their food. So when the bacterial diversity collapses, the fungal diversity also collapses, and this also again is correlated with each other. What are the determinants of this? Is if use of antibiotics. So rifaximin as spontaneous bacterial peritonitis prophylaxis, culture negative and positive bacteria, they all show a reduction in this. So why it is important is because any exposure to antibiotics, whether it is an outpatient or inpatient, predispose people to develop fungal infections, as we know. And what fungi are replaced? They're replaced by Candida. And we know that is the #1 reason for actual fungal infections, invasive fungal infections in patients with cirrhosis and in ACLF as well. Another virus that we talk about, now we talk about fungi, we talk about viruses. Let's talk about COVID. COVID-19 and microbiota can affect outcomes in cirrhosis. And of course, things get very muddled when someone is admitted with COVID, has bad microbiota. In this nice study, just published in Gut from Hong Kong, Dr. Young's et al. Group found out that people without COVID, people with COVID without antibiotics, and with antibiotics had very different microbiota. And this is just at the phylum ratio, that it is very different from each other when they were discharged negative. So does that mean the microbiota caused the COVID? Absolutely not. It just says microbiota, again, like many other things, may be a permissive factor in this situation. What about virome? Not just COVID, but just virome in alcoholic hepatitis compared to alcohol use disorder and cirrhosis and controls. In this, another study from Dr. Schnabel's group, they took bacteriophages right here. And you can see in alcoholic hepatitis, the proportion of bacteriophages was much higher than alcohol use disorder than controls. And again, the Shannon diversity went down, the inverse sensitivity went down. This is basically the diversity going down, going higher in, it's the reverse. We look at the controls, the diversity is lower, but alcoholic hepatitis, the diversity of the virome is much, much higher in this case. We wanted to do the same thing, similar things in cirrhosis, and we found that, not surprisingly, in metagenomics, the bacterial species went down, but just the phages. We focused most of the phages because when you do metagenomics, unlike the dark matter analysis, you can come up with phages when most of the phages can be detected with usual metagenomics. The only major change was when people were in advanced cirrhosis, which means they were on rifaximin. Here I want you to concentrate on the correlation network on the up right here. Anything in the the blue are positive, red are negative, and these are controls. This is the correlation between phages and bacteria. If you look at the controls, you look how dense the correlation is between phages and bacteria. Look at the compensated cirrhosis, it goes down. And this is cirrhosis on lactulose and cirrhosis on lactulose and rifaximin. It is completely collapsed. It completely collapses. So it's not just the bacteria, it's also the phages that go down as cirrhosis progresses. What about people who are ultimately hospitalized, many of them with ACLF? This is people who are hospitalized on top, and you can see how dense the network is around streptococcus. And streptococcus is important because it produces urea. It's a urease producing organism and produces ammonia and causes changes as well. These are patients who are not hospitalized, and you can see how dense the correlation network is. And these are people who are hospitalized, in which things collapse. So again, it's not just the bacteria, it could also be the fungi and the viruses that can actually make changes when it comes to prediction of ACLF and the course of ACLF. Now, how do we operationalize this knowledge? Let's use some therapeutic strategies to prevent ACLF and not diagnose it when it's already there. So you have GI strategies such as periodontal therapy and non-selective beta blockers. You could have strategies enhancing interaction with the liver. And then you can have strategies that would interact with the mucosal barriers that can do it directly with probiotics, FMT, non-absorbable antibiotics such as rifaximin, and other investigational therapies that attack the bile duct. In this nice case study series done by Dr. Serin's group, they were able to find out with FMT in the steroid-resistant alcoholic hepatitis, which was the cry, which is still a place where we need to do work. Based on historical controls, there was improvement in survival that was actually also accompanied by change in the microbiota similarity with the donor. But we want to know whether we can actually use this 16S RNA PCR to characterize culture-negative infections. Now, what are culture-negative infections? Many patients who have ACLF, many patients who have acute and chronic liver failure due to things that we don't know what it's causing. There could be any kind of infection, but we just cannot capture it. In this series of studies, in places where it's even harder, such as multiple joint infections, arthroplasties, where these patients had multiple episodes of infections, they were able to capture next generation sequencing to find out what organism there was in these patients. So the hope is in the future to get liquid biopsies for infectious diseases with cell-free plasma to not only detect fungal diseases, but to also detect bacterial and viral diseases that we are not able to currently detect, or the patient has received multiple doses of antibiotics. What about the metabolites? We talked about what the microbes are, but we also want to talk about what the microbes are doing. On the left-hand side is a study from the Eclf consortium. They took 181 patients who had already developed ACLF, 650 patients with acute decompensation, compensated patients and healthy compensated patients. In their serum, they were able to study metabolomic changes. And not surprisingly, the metabolomic changes that were most significantly different were those related to energy metabolism, because as you remember, patients with ACLF have failure of organs, which are associated with big changes in energy. However, there were some changes in microbial products as well. We, on the other hand, wanted to capture this a step further, step before. We wanted on admission in patients who had never developed ACLF on admission to see who develops ACLF and who doesn't, and to see if these microbial products or these serum products can actually predict who does. And we found that with the 602 patients that we had with patients with cirrhosis who were admitted to the hospitals across 12 centers across North America, the serum signature, and most of them were actually products made by the bacteria and only by the bacteria, were independently able to predict who develops ACLF and who doesn't. So it's important for us to morph from places where we are already diagnosing ACLF and quibbling about this is my ACLF, that is your ACLF, but to actually figure out ways in which we can predict this from actually happening. Because if you remember, the microbiome is already impaired on the day of admission. Now we are telling you the microbiome and the metabolome is already different in the day of admission. So we have to do two things here. We not only have to make sure that we diagnose it quickly and appropriately and predict it, also we have to shift the series, our scene, towards the outpatient setting so that we can make things better for our patients and not just diagnose them when they're halfway in the grave. So what are the future directions? Need to work more with outpatients to predict and prevent hospitalization, protocolized assessments of gut microbiota in inpatients as close to admission as possible and focusing on function, developing point-of-care testing for prognostication and replacing or complementing cultures, finessing the role of saliva and fluids other than stool, as well as detecting viral and fungal interaction with bacteria are important. So in conclusion, identification of patients who will develop poor outcomes can be performed in single and multi-center studies. Analysis using microbial composition of stool and saliva and blood can predict those who develop negative outcomes. Fungi and viruses are emerging major players in ACLF and cirrhosis. They can often add to clinical biomarkers that are currently underused. Further studies are needed to standardize these across populations and again to develop these point-of-care testing. Thank you so much for your time.
Thank you, Professor. So I request our panelist, Professor Dhiman, please, Professor Dhiman, sir, please.
Yeah. Yes. Hi, Jess. I think it's a very good and very informative also, and you have reviewed everything. And we have our experience also with the FMT in patient with the hepatitis, and we have demonstrated the complication rate is less, as well as the survival is higher also. So I totally agree whatever you have said. That's all from my side.
Thank you.
So if no more discussions, we can.
I had one question for Jazz.
Yeah,
it's Jacob here. Jazz, I had just one question for you. I mean, you see all of these changes, and with your FMT therapy, maybe they've got some pathogenic role. I guess at the clinic, I mean, the question is it just associations? How much of it is associations? And the second question is, in terms of, if you're thinking of treatment, etc., and you're saying, diagnosing it early or finding these changes early, what's the turnaround time for these tests? I mean, very few centers will have it.
Yes, so right now what we are coming up with is a way to actually operationalize it to few bugs and the ratio of those bugs. Then you can have kind of PCR strips. Right now we are trying to make sure that we have actually sent feelers out to many places around the world to actually get samples from there to actually standardize, quote unquote, a universal thing that would actually And the good news is then when people are sick, that microbes are similarly kind of bad. So what we are trying to figure out, it's easier to standardize the metabolites, the serum, because that can come back quicker than it is to actually standardize the stool, which is part one. Face it, most people don't like to collect stool. It takes longer to actually process it. And it will not come back in time to help an inpatient. So what we are trying to do is to add, but it's clear that CRP and our current inflammation things are not enough. And so what the hope here is to actually get people who are decompensated but have not in the hospital yet to actually figure what happens in those patients so that we have some luxury of time. It's not absolutely critical. The patient is not being intubated in the next 24 hours. So we are working towards that to actually make it more point of care at this point.
So if you can diagnose it, what's the next step? I mean, is it FMT or what is it? Yes, you have to treat the underlying liver disease.
Yeah, you clearly, again, I'm really can't stress this enough. You have to treat the underlying alcohol use disorder. You treat all the other stuff that is making that person, because unless and until you do that, you can shove all kinds of probiotics up or down the patient and it's still not going to work. In fact, I've seen patients with lactobacillus SBP after they were taking too many probiotics in these patients. So you want to make sure that you are actually treating the liver disease itself. What is particularly concerning to me is the antibiotic resistance rate, not just in India or other places where we had the global study really highlighted, but in actually everywhere in patients with cirrhosis, they're at the forefront and they bear the brunt of that. Studies in patients without cirrhosis have clearly shown that once you give an FMT, even one FMT, their antibiotic resistance genes go down quite dramatically. And what we did was a post hoc analysis of our 2 trials in FMT that I did not present because they were not directly related to alcohol, was in patients with hepatic encephalopathy. When you gave a healthy donor, almost all antibiotic resistance genes were quenched in those patients. So it's important to me, that is one achievable step that clearly draws a line between not just bugs being abnormal, but the bad bugs with the genes that are being produced in a patient population that can hardly tolerate it and is going to come back again and again, being exposed to multiple antibiotics outside, inside, as well as multiple instrumentations. That would be one easily achievable step, is to reduce the antibiotic resistance gene burden in these patient populations. Then that can subsequently stop this downward spiral that these patients actually come to. They come in, they're already on antibiotics, you can't diagnose it, you give them antibiotics that do not cover the current organism, and then so on and so forth. By the time you reach to the current organisms, 3 of their organs have already failed, and that's it.
Okay, thank you, Professor Jaswan. So now I think we'll go to next. Thank you, Professor Jas. Now we'll go to next sessions. I know it is a late night for you, but if you can stay, it will be good for us. But I don't want that it should be like whole nights. So we'll go to the next interesting area, that is monocyte macrophage and neutrophil functions and their implications. So now I am handing over to Professor Jean Huahu from Beijing and Professor Anup Sarai, New Delhi. Esteemed chairpersons, please proceed.
Hello, good afternoon. This is Dr. Fushen Wang, and thank you, Chairman. Dear my friends in different areas of the world, maybe you are good afternoon or good morning or good evening. How are you? My presentation, the title is The Function and Implication of Neutrophil and Macrophage in Acl liver disease associated with the ACAF. Well, in the next 10 minutes, I would like to address the 4 aspects. First is the pandemic of alcohol liver diseases. The second, I will address the immunopathogenesis in alcohol liver diseases. The third, I would like to address the neutrophils function and dysfunction in the diseases. Finally, I would give some slides to highlight the progress in the treatment of the diseases. Well, as we know, the definition of alcohol liver diseases as well as the acute or chronic liver disease is almost almost clearly identified. And then in my assumption, in my presentation, I would address the excessive alcohol assumption and alcohol hepatitis and bacterial infections are considered the most frequent events that precipitate the development of acute or chronic liver failure in patients with ALD. As we know, this slide just shows us the landscape of liver diseases in Asia Pacific region. As we know, the proportion of overall death related to the liver diseases is different around the Asia Pacific region. For example, among all the death, the alcohol-related death almost occupies more than 20%, like in countries including New Zealand, Vietnam, and then Thailand, and then Cambodia, some countries. And also in the progress or in the development of Aclf, we can see that both the immunocyte or the innate immunocyte or adaptive immunocytes, their function become poor and poor. However, there is an increase in systemic inflammation, and also there is a lot of release of cytokines like IL-6, IL-10, IL-6, IL-5, IL-8. Because of the immune disorder, the patient receives the steroid treatment. This kind of treatment can increase their risk of bacterial infection as well as opportunistic infection. In this cartoon, it shows us in a patient with alcohol liver disease, there is an immune disorder, and both innate immunocytes as well as adaptive immunocytes, there is an imbalance in these patients. Also, there is a paralysis or immune paralysis is the main feature in a patient with ALD associated with AClf. And in general, bacterial infection and excessive alcohol consumption have been shown to be the top two frequent events that precipitate the development of AClf. And then also, as we know, both innate and adaptive immunity are defected in these patients. Especially the neutrophil to lymphocyte ratio can be used to predicate the disease's outcome or prognosis. This factor is independent of mild and cirrhosis stage. This slide just shows us the two phases of neutrophils in a patient with liver diseases. Professor Yongizabo comprehensively wrote this review. We can see neutrophils actively participate in the immune resolution and restore the homeostatic conditions in the physiological conditions or in healthy conditions. However, in the diseases, neutrophils are defected. The neutrophils dysfunction are often acquired from the environment under the certain diseases states. Also, in the previous our previous studies reported that the microkinetin by neutrophils is impaired, and then macrophage phagocytosis is also reduced. Therefore, the neutrophil dysfunction are linked to the persistent inflammation stimulation, which is also with the increased resting respiratory burst. Our previous study also shows there is a dysfunction of neutrophils in a patient with Acl, especially compared to the patient with chronic hepatitis B or cirrhosis. The dysfunction of neutrophils in this disease can be used to predicate the poor outcome. As we know, the function of innate immunocytes are often affected by the abnormal immune environment. Therefore, the high resting oxidative burst of neutrophils is reversible by passage of plasma over an exotoxin removal column or following incubation with the anti-CD14 antibodies. The removal of endotoxin from plasma was shown to restore the neutrophil function. And then in some studies, they also shows the steroid therapy alone or combination with the petroxyphilin in combination together. This kind of therapy was associated with the reduction in 28-day mortality. However, when conducting the longitudinal investigation until to 90 days or 1 year, the survival rate has not been improved from the 28 days. Also, some studies indicated that the 13-3 ST2 pathway is defective in neutrophils in a patient with severe alcoholic hepatitis, which is highly associated with the risk of infection. Because the defect in this pathway in neutrophils is responsible for the lower migration capacities. Therefore, treatment with the recombinant IL-33 can restore, at least in part, the migration capability of this neutrophil. It means this kind of IL-33 therapy can promote the function of neutrophils. Also, this study from the Professor Sharon's group, they also showed, in addition to the conventional therapy to the patient with Acl, they use the G-CSF therapy. This G-CSF can restore the neutrophils function, and then to reduce the neutrophils dysfunction. In this way, the patient received the G-CSF, the survival rate can be, we can see, can be improved. This is a very nice study. And also in some studies show that autologous bone marrow derived mesenchymal stem cells transplantation can be used to treat a patient with alcoholic cirrhosis. This is a phase 2 study. In this study, they compare the liver tissue damage before and after treatment. We can see when the patient received 1 round MSC therapy or 2 rounds of MSC transplantation, both only 1 time or 2 times can significantly reduce the collagen synthesis. Also, this is our study almost finished 10 years ago. We used the human umbilical cord derived mesenchymal stem cells to transfusion to treat the patient with acute or chronic liver failure patients. We found, especially in the early stage or medium stage of ACF patients, this kind of MSC transfusion can improve the survival rate compared to the controls. Well, this is a brief summary of our study. Almost 7 years ago, we summarized in the patient with liver failure and liver cirrhosis, when they received the mesenchymal stem cell therapy, This kind of mesenchymal stem cells, MSC, can modulate the abnormal immune responses and then reduce their inflammation and consequently reduce their collagen synthesis. Simultaneously, MSC can release some growth factors, especially the hepatocyte growth factors, can promote the regeneration of liver stem cells. Also, some studies in shows that the MSC can promote the macrophage from M1 to M2 phase, and then suppress the inflammatory cytokines and reduce the apoptosis of hepatocyte. Therefore, this MSC can be used in a treatment. Well, this is a very brief summary. First, there is a significant impairment of innate immunity in a patient with ALD associated with Aclf. The second, improvement of inflammation environment can contribute to the recovery of innate immunity, further reducing the risk of liver failure in ALD patients. Many thanks. This is my colleagues in this photo. Also, I appreciate Dr. Roland Xu and Dr. Liu Kai. They helped me to prepare this slide and also to conduct the clinical trials in my center. Many thanks. I finished.
So, thanks, Professor Wang. So now, I request both the chairpersons, Professor Saraya and Professor Jean Wahu. Professor Jean Wahu, I have seen. Please, any input from your side?
In fact,
also, thank you.
I'm Dr. Saraya this side. It's excellent presentation.
For, yeah,
but
for his excellent.
I'll say one thing that I think someone else is there.
Yeah, Professor Saraya, please. Then Professor Wahu.
Yes. Oh. Yes, I'm ready.
Oh. So, yes, Dr. Wong, it's an excellent presentation, I must say, and beautiful work which you have done so far in this area. And we know that innate immunity is impaired, especially in alcoholic liver disease. And there are certain markers that can be used, immune markers as well as cytokine markers, which can be used as targets for therapy. And there is data emerging, especially type 2 and means phase 2B type studies are available with many of these targets which have been used for therapeutic purpose. And I think few lines can be added on those things also in the summary, because there are certain that we can give at least in the discussion part of the document which we prepare for the consensus statement, because there are certain targets when we talk of neutrophils like NGAL and when monocyte MERTK, and then on macrophage, especially the soluble CD163. These are the important targets which are emerging as a possible therapeutic targets. And it's same way in the immune interleukins also, especially interleukin 22 and 23 and IFN gamma, that TNF alpha also. All these are emerging targets which have been studied in various trials. So we can add something in the discussion part, not exactly in the consensus statement, but at least in the discussion part we can add.
Yes, I agree with you, Professor Saraya. Yes, many thanks for your wonderful comments. And in the future, probably I think the future study should highlight on the landscape of immunocytes in vivo, as well the cytokines or some parameters, and put them together can be formulated there and landscape or scenario of the changes in immune systems as well. I fully agree with you for your nice comments. Thanks.
Yeah, Professor Hu, please.
Thank you, Professor Wang, giving us excellent presentation. And congratulations, Professor Wang and his team. They have done a lot of work on this in this field. I also believe that the overactivation of neutrophil and its infiltration in liver tissues seems very important in pathogenesis of ALD, chronic liver disease, especially in liver cirrhosis. But it remains unclear whether the neutrophil whether there is further or specific changes in neutrophils during ACLF. This is the first question. And also, Professor Wang, I also noticed you haven't mentioned about the monocyte and the macrophage cells in your presentation. Some research, they think the monocyte may or the recruit macrophage may play a more and more important role in the ACLF. How do you think? What do you think?
Okay. Thank you for your questions. It's a professional question. As we know, actually in the clinic we use the neutrophils to lymphocyte ratio to predict the outcome, but actually we didn't know much the mechanisms, the pathogenesis, what reason lead to that, or right now we cannot figure out the cause and cause and effect, the rule between them. Probably is a kind of association. I hope not. The second question, as you mentioned, in addition to the neutrophils, but also monocyte, macrophages, or even other innate immunocytes are also involved in the disease progression or in the development of ACLF. Frankly to say, there are lack of some solid data. Some groups are using the single cell RNA to hope in the near future to figure out the landscape of immune changes, and probably also find some helpful or very useful parameters for predict the diseases. Thanks.
Thank you.
Professor Wang, we just request some few bulleted points as a concise statement from you. Thank you. We have received the draft, and if you could, after the discussion also, you can share us a few concise statements. That will be great.
Excuse me, pardon?
We need some consensus statements.
Yes.
Bulleted consensus statements from you.
Oh yeah. For the for the consensus statement, I think it's just in one word, the neutrophils to lymphocyte ratio can be used to predict the outcome of the ACLF. For others, I think we need to do more studies to identify them. Thank you very much, Professor Sharon and your colleagues. Thank you.
Thank you very much. Maybe now take the next session is to be chaired by Professor Saeed Hamid, one of our very senior hepatologists in Asia, Professor Jin Jun Chen, a very eminent scientist and clinical researcher, and Dr. Gulnara to chair this session, which will have Professor Chin Neng from Wuhan, who is an outstanding researcher and also heads the AARC China, to kindly deliver her talk. Over to our chairpersons.
Thank you, Professor Sarin. It's a great pleasure to be in this meeting. So far the presentations have been wonderful. So without wasting time, we'll just go to Professor Kinning's presentation. Professor Chin, I think, doesn't need any introduction. She is the eminent hepatologist, infectious disease person in Wuhan, has been in the news recently for a lot of her work with COVID, of course, and the liver. And today she's talking about reprogramming the liver injury cascade in ACLF. Is Professor Ning on? And is she ready?
Hello.
Hello.
Hi. Hi, everybody.
Are you ready?
Hello. Yeah. Thanks, Professor Serene and Professor Hewitt. Good morning, good afternoon, good evening, everybody. I had a pre-recording video for this presentation. I prefer the organization could run the video since it's really stable from the the issue of
Good morning, ladies and gentlemen. I'm Professor Chen Lim from the Department of Infectious Disease, Tongji Hospital, Wuhan, China. I'm presenting entitled Reprogramming the Liver Injury Cascade in Acute on Chronic Liver Failure. According to the World Health Organization, ALD is responsible for 50% of cases of cirrhosis worldwide. However, compared with liver disease of other etiologies, alcoholic-related liver disease is rarely detected at the early stage. These results indicated that alcoholic liver disease is by far the disease that is detected at a later stage when patients require hospitalization due to liver-related complications, even ALD, Aclf. Alcohol was the main cofactor in patients with double etiologies and increased the chances patients were referred to the hospital at advanced stages. This slide is busy, but it clearly shows the pathophysiological of alcoholic hepatitis and novel therapeutic targets in current clinical trials. Alcohol ingestion results in liver injury through multiple effects and pathways, including number one, its toxic effect on the gut, with increase in permeability resulting in translocations by bacteria and leading to LPS translocation. That leads to IL-1 beta production from hepatic macrophages. Number two, its direct toxic effect of alcohol on hepatocytes, producing acetaldehyde with consequent oxidative stress and apoptosis. Inflammation perpetuates through cytokines with other liver cells such as recruited PMN, HSCs, and endothelial cells, with the development of portal hypertension and fibrosis. The novel agents, including currently ongoing clinical trials, mainly targeted A, the gut-liver axis, including such as LPS, antibiotics, and fecal transplantations or FMT. Secondly, inflammatory signaling, including IL-1 receptor and IL-22. Thirdly, apoptosis, oxidative stress, and hepatic regeneration, including IL-22 and others, such as GCSF and kinase inhibitors. As we all know that hepatitis B virus infection is one of the main etiologies in Asian countries for chronic liver disease. In our center, we studied the HBV expression syngenically increased cholesterol deposition in the setting of alcoholic fatty liver. The increase of intrahepatic cholesterol was scoped to metabolic alteration in cholesterol metabolism, including increased cholesterol synthesis, decreased cholesterol degradation, and impaired cholesterol uptake. Ectopic expression of HBV components, hepatitis B virus core protein, but not other such as S or X proteins, selectively promoted hepatocellular cholesterol level. This table listed the knowns and unknowns of the treatment of alcoholic hepatitis. The main target towards the mechanisms, including liver regeneration, as shown in this table, including the IL-22, the antioxidant. There are many clinical studies undergoing. Majority of this study were run at phase 2 to phase 4. And some were single-center studies, some were multi-centers. Some have some preliminary data, which I will show you in later part of this presentation. The other mechanisms including the following: synthetically modifying bioacids, and others including small molecules that regulated and moderated the activities of nucleate receptors, signaling or regulating the cellular functions, such as the DUR-928 agent. Others including anti-inflammations such as IL-1 receptor agonist. So there are lots of these clinical trials undergoing. Due to the time limitation, I picked up a few which have already had preliminary data. One of these including the open-label dose escalation studies to assess the safety and efficacy of IL-22 agonist, F652, in patients with alcohol-associated hepatitis. As we can see in that 64 patients were eligible for assessment. 80 patients were randomized into 3 groups with different doses of treatment, including 10 microgram, 30 microgram, and 45 microgram. And at the end, 6 patients in each group were analyzed. This slide shows you the results. As we can see, the MELD scores in the total group and subgroup of the patients were analyzed. It seemed that there was a significant reduction in the MELD scores in the composition group, as well as in the subgroups divided according to the disease severity, as seen in B and C, indicated MELD score 11 to 20 or 21 to 28. Next, the analysis, the clinical parameters at follow-up. As we can see that at day 0, 28, and 42 of the follow-up, there were significantly improvement in the total bilirubin as shown in panel A, the CRP level as shown in panel B, and ALT/AST shown in the C, panel C, and panel D. Next, they show the Lilly scores responder at day 7 for all the cohorts. Panel A shown that F652 treatment cohort had 82% of subjects who responded to the therapy, as evidenced, as shown that the Lilly score is 0.045 or even less than this cutoff level. A prospective histological comparison study showing that only 12% had response, as shown in panel B. A retrospective histological alcoholic hepatitis cohort showed only 6% of responder in comparison, and in panel D showed 56% of these patients when they received steroid treatment. Of course, this is a prospective comparison of this treatment study group. Next, there is another study showing the territorial endpoints that studied the extracellular vesicles reduction post-treatment. The EV counts here act as a surrogate endpoints for improvement in inflammation associated with alcoholic hepatitis. Similarly, an improvement post-treatment is shown by decline of cytokines and chemokines, including IL-8, MCP-1, CRP, IL-6, and increase of the growth factors representing the liver regeneration, including angioprotein-2, FGF-B, FGF-beta, PDGF-AA, and BB. Now we moved on to another clinical study, which also representing the reversible of the liver injury in alcohol-induced chronic liver disease. This study is to evaluate the safety and tolerability and efficacy of another agent named DUR-928 in AH patients. The DUR-928 is an endogenous small molecule with good safety profile in multiple phase 1 trials, as reported by the literatures, which genetically regulates metabolism, inflammation, cell survival, and tissue regeneration. The main findings in this study including there were no serious adverse effects were related to the study drug as declared by the company. 100% of all treated patients survived the 28-day follow-up. 89% of all treated patients responded, including 100% of patients who received the 30 to 90 milligram of the doses. MELD scores were significantly reduced from baseline on day 28. Significantly earlier reduction of bilirubin from baseline on day 7 was observed, especially in patients with baseline greater than 8 milligrams per dl. Another study investigated the safety and efficacy of combination of recombinant human interleukin-1 receptor agonist and filin, PTX for short, and zinc in patients with AH. They targeted the critical pathogenic elements of AH, including inflammation, protection from cellular injury, and gut thickness. They found that a combination of the IL-1 beta agonist, PTX, and zinc provides comparable short-term and may provide long-term survival benefits compared to the currently used FRED therapy in severe alcoholic hepatitis. Initial MELD score is an important predictor of the survival at day 30, 90, and 180. Therefore, ladies and gentlemen, in summary, alcoholic liver disease is responsible for around 50% of cases of cirrhosis worldwide, and is commonly detected in later stage, even with some of these patients, ALD, Aclf, when they come to our clinic. Alcohol ingestion results in liver injury through multiple effects and pathways, such as its toxic effects, including LPS, leaking, IL-1 beta, oxidative stress and apoptosis, inflammation, HSC activation, and endothelial cells involvement. The novel agents in currently ongoing clinical trials includes the gut-liver axis, inflammation signaling, oxidative stress, and hepatic regeneration. None of these were quite promising. Therefore, more additional studies were needed, especially for large-scale clinical studies. Multicenter, open-labeled, or even randomized control studies are needed to further identify its effectiveness, safety. And I thank you very much for your attention.
Thank you, Professor Ning. This is open to discussion. May I request our co-chairs, Professor Chen and Professor Gulnara, to please come in with their comments.
Okay. Greetings to all. And in my mind, I want to thank Professor Ning for very interesting presentation. And in my mind, it is very important point is gut microbiota, as Professor Bajaj told us in his talk too, and management of apoptosis, oxidative stress, and hepatic regeneration. And maybe we should join our efforts for multi-center trials for adding new results to our update of our consensus. And the next, on the another side, it's very important point is prophylaxis of complications in this disease, alcoholic disease, as Professor Szabo told. And I hope that we should make a future research in this direction too. And prophylaxis, one of the way of prophylaxis, maybe for prevention of complications, they are vaccination against the viral infections such as flu, usual flu, and now actual COVID infection. And that's all my thoughts. And thank you very much, Professor Ning, again. And that's all. Thank you.
Professor Chen, do you have any comments?
Thank you. This is very important comments.
Professor Chen, go ahead.
Yeah. Hello. My comment is that Professor Ning's talk is comprehensive about how to reprogram liver injury. But I know, the evidence, support the steroid and the GCSF, used in these patients. So we need to, highlight these two treatments in the consensus. The second, I agree with the previous professor that infection or systematic inflammation status in these patients is important. So how about the endotoxin clearance? It's any space for it to, stay, left in the statement. The final thought is that just like Professor Wang mentioned before, the stem cell, mesenchymal stem cell transfusion may be useful to reprogram the liver injury in acute hepatitis or in some subtypes of Aclf. So the third thought is that how about the stem cell transfusion? In the future, maybe can be highlighted in the statement. So that's all. Thanks.
Thank you.
May I ask questions for the Professor Lin Qing?
Sure.
Yeah, for the conduct of studies, those alcohol-related liver failure, how can you control the alcohol consumption? Any criteria behind the patients have been drinking, and how can you standardize the alcohol consumptions? And you stop everything, or can you do that in real life? And because this will bring in a lot of inconsistency with the outcome of any clinical trials. So is there any consensus statements that which can be put into the guidance for any future research in this direction?
Thank you. Thanks very much for this very important question. In fact, I think for reality it's quite difficult to approach to the stage of restricted entirely the consumption of alcohol. Strategy is to especially for the prevention of alcohol-related Aclf, is to restrict the alcohol consumption. However, in the experience of our hands, that we actually have a very limited cases of alcohol consumption center. Due to the main reasons that in mainland of China that we do see much more of HPV-related Aclf. So for the purpose of these presentations that we had in Aclf, that due to alcoholic-related, etiology, and in fact we found less than 50 patients that hospitalized in our center for the past 3 years. So I do not have much experience about the alcohol consumption in our outpatients, leading to which the patients.
Yeah, Professor Sarin is also
Yes.
here. In fact, I really want to hear the wisdom, because this is guidelines we will have consensus and so on, whether we should initiate, try to attempt of how we can standardize this impact on the studies of alcohol-related liver diseases. Because there are people who drink less, there are people who can abstain, and there are people who will continue. And how are we going to measure this heterogeneity and take into considerations into clinical trials? So otherwise, there will be a lot of conflicting data related to the patient's behavior. whether we can have some way to measure.
Thank you, Professor Lau.
Yes,
And, sorry, and a very important point which was missing in the program is the guidance on alcohol restriction and abuse. And I think your point is well taken. It should be included into a guidance statement. We have to look into the data based on what is available in different parts of Asia, and we certainly will get this incorporated. Thank you, and I want Dr. Hamid to conclude this session in the interest of time.
Thank you very much. I just have a quick question with from Dr. Ning. Dr. Ning, we know that cytokine manipulation is a double-edged sword in many, many instances, right? It has upsides and downsides. Reading the literature that you have, can you make consensus recommendations for the use of some of these compounds that you have highlighted for the future? Because many of these compounds, as I said, can go both ways. So what is your reading of the literature up till now?
Thanks, Professor Himit. This is another important point. Yes. So as I shown in my presentation, there are many undergoing clinical trials. Some of the results seems quite effective. So due to the immune pathological as presented by other previous speakers, so I would think such as IL-22, IL-1 beta, GCSF, these cytokines have been achieved on the clinical trials, and some of them have results already. So I would suggest we may target some of these inflammatory cytokines. Yeah.
Okay, well, thank you very much. I think we will need to conclude the session now and move on to the next one. So back to Dr. Ashok and Professor Saeed.
I would like the question which Dr. Saeed Hamid raised to, I think we can draw a diagram with the help of the speaker, Professor Ning, and the chairpersons on the cytokines, good and bad, and a dynamic diagram depicting in different stages of alcohol. I think one can attempt, this can't be a consensus, but can be a good background picture to be inserted into the consensus. So I think it's a very good session, very useful for thinking, and we can, if everyone thinks properly, a future target areas for therapies based on what we have. Thank you all of the chairs and the speaker. May we move now to the next session, which will be chaired by Professor Eppen, Professor Hasmik, and Professor Kin Mong Wing. And the elegant speaker is none other but Professor Ashwini Singhal. I hand over to the chair, please. And thank you, Professor Ning.
Good morning, everyone. Let me invite the co-chairs, Professor Hasmik and Professor Kin Mawing. And I think we can probably move on to the speaker. So may I request Dr. Ashwini Singhal to talk on liver biopsy feasibility and need in alcoholic ACLF.
Recorded video because of the late night. So, Izumi, please start the video.
Well, at the outset, I would like to thank the organizers, especially Dr. Sareen, for this opportunity. And of the disclosures listed here on this slide, none of these is related to the presentation. So over the next 10 minutes or so, we will talk about what is the need and feasibility of liver biopsy in alcohol-associated ACLF and how we can use liver biopsy in this group of patients in predicting prognosis. So we all know that Aclf in ALD patients can be due to alcoholic hepatitis and also due to non-AH related precipitants. And this is the data from the Eclf consortium, where they compared patients who had worsening of their liver disease due to alcohol from alcoholic hepatitis, shown on the right, and due to non-alcoholic hepatitis, shown in the middle column. As you can see, the Aclf is much more common when the alcoholic hepatitis is a precipitant, about 43%, compared to 32% in a non-AH induced Aclf in ALD patients. The AH-related Aclf also differs from non-AH due to its younger age and relatively more advanced and severe liver disease with a higher bilirubin and MELD score, and also presence of inflammatory markers such as elevated white count and a CRP levels in these patients. And one of the other reasons for making a differentiation of alcoholic hepatitis as a cause of Aclf in ALD patients is that especially the severe disease is more applicable to treatment with corticosteroids with a benefit of survival at short term at 30 days by about 50%, recognizing that there will be a group of about 30 to 40% of these patients who would be ineligible for receiving corticosteroids at a given point of time. So this is the algorithm and the management of alcoholic hepatitis, as we all know, and I'm not going to go over the details on this algorithm, but just to point out that apart from giving steroids in eligible patients, and that is the group where we would like to know whether underlying precipitant is alcoholic hepatitis, you may also like to make that diagnosis when you are enrolling patients in clinical trials, both for steroid eligible patients as well as those who are ineligible for corticosteroids. And I want to point out here on the right hand side is a group of patients with moderate alcoholic hepatitis, which kind of got ignored in the past. However, this group of patients still has a mortality of about 10% in 3 months from the presentation. And hepatologists recognize this, and in the last 4 or 5 years, this group of patients is also being enrolled in clinical trials, and you may like to confirm the diagnosis even in this group of patients, especially before including them in clinical trials. So that brings us to the first recommendation, that among patients with alcohol-related liver disease and Aclf who present with jaundice, alcoholic hepatitis as a precipitant should be determined, especially if you are considering corticosteroid therapy or enrollment into clinical trials. So once you make a decision to diagnose alcoholic hepatitis, typically biopsy is the gold standard. However, biopsy cannot be performed in every patient due to these patients being sick, and this biopsy is invasive and potential for complications. And the NIAAA funded consortia in the US about 5 years ago came up with this definition and criteria listed over here to make a clinical diagnosis of alcoholic hepatitis. And the accuracy of this clinical diagnosis is somewhere between 80 to 90%, as you can see in studies listed over here. However, this accuracy can be increased if you have a cutoff of bilirubin about 4.7 milligram per deciliter. In a systematic review, the accuracy was about 96%. And then if you further increase your severity of liver disease to MELD over 25, and if the biopsy is obtained before corticosteroid use, in this group of patients, the accuracy is almost 10%. In a less severe disease, you can increase the accuracy of the diagnosis using some of the other markers which are simply available, or they are simple to use, such as white cell count and the nodularity of liver on the imaging, and using that combination along with the clinical criteria I showed you in the previous slide, the accuracy can be increased. Once we make a group of patients, those 5 to 10% when we will need liver biopsy in making a diagnosis of alcoholic hepatitis, a transjugular approach is recommended. And this is data from about 7,500 odd patients from 64 studies in a pooled fashion where the success rate in obtaining a tissue and making a histological diagnosis is over 95%. And I want to point out here a group of patients who would need to be diagnosed when you have a suspicion of autoimmune hepatitis, especially seronegative autoimmune hepatitis, and there is a conundrum of the diagnosis with alcoholic hepatitis in the clinical presentation. Biopsy is helpful. This is a safe procedure. Major complications extremely rare, mortality very, very rare. And also this study showed that if you use a true cut needle of 18 gauge or higher, it provides a much higher chances of obtaining adequate tissue in a non-fragmented tissue and in a safe fashion with very low rate of complications. Up to 3 passes using that approach, if it is obtained, the liver tissue is very adequate to make a diagnosis. Another thing which came up with this study is that the outcomes on safety as well as on success of transjugular liver biopsy is much higher if the biopsy is obtained at a center of expertise with more than experience of 100 transjugular biopsies. So once the biopsy is obtained, you are examining the tissue for lobular infiltration and ballooning of the hepatocytes, especially with neutrophilic infiltration in the lobules. Cholestasis, especially in the ductules and canaliculi. Evidence of steatosis in the background, and another marker of inflammation, Mallory-Denk bodies within the hepatocytes. And the megamitochondria, especially in the areas of ballooned hepatocytes, is another hallmark feature of alcoholic hepatitis. And finally, varying degrees of fibrosis, especially the chicken wire pericellular fibrosis, which is typical of a severe variety of alcoholic hepatitis. What about the accuracy on the diagnosis and inter-observer agreement between the pathologists? Unfortunately, on liver histology, for some of the unique features of alcoholic hepatitis, such as hepatocyte ballooning and megamitochondria, the kappa statistics on inter-observer agreement between pathologists is very poor. It is fair to moderate for the other features of alcoholic hepatitis as shown by these 4 different studies you can see across the bar. One of the study also examined the kappa statistics when the GI pathologist obtained and reviewed the liver biopsies. And compared to 3 dedicated hepatopathologists, as you can see, most of the features of alcoholic hepatitis, the kappa statistics was better when the liver pathologist examined the tissue, especially on some of the diagnostic features of alcoholic hepatitis. So that brings us to the 2 recommendations listed here, second and third recommendations, that a liver biopsy should be obtained whenever the diagnosis is uncertain, after you have a clinical evaluation, serology, and a liver imaging. And then once you decide to do a liver biopsy, it should be obtained using a transjugular approach. And the liver tissue should be examined by an expert who is, has an experience in evaluating patients, not only with liver disease, but also particularly with histological findings of alcoholic hepatitis. Now changing gears here and moving on to a role of liver biopsy in predicting prognosis. And on the left-hand side, you see, and this is the initial study about 7 years ago, which brought up 4 criteria to come up with the alcoholic hepatitis histologic score. 2 of the variables, which is fibrosis stage and bilirubin stasis or cholestasis. As the score moves up, the severity of the disease moves up. And 2 of the other variables, which is neutrophilic infiltration and megamitochondria, as the score moves up, the disease severity moves down. So they're more or less protective for a severe disease, if you can say that. And this particular study stratified patients into 3 different categories for a alcoholic hepatitis histologic score of maximum of 9 points at a cutoff of 3 and 5 to a mild, intermediate, and severe degree, where the survival at 90 days translated into, based on the severity of the liver disease, the area under the curve being 0.77. However, two later studies published recently, one in 105 patients and the other one in about 160 patients from the STOPA study, did not find that confirmation or validate these findings. The one study at 90 days and the other one at 6 months of survival. As you can see, the p-values were not significant based on the severity assessed by histology. One of the difference between these two studies and the previous studies, the disease severity, as you can see, that these two studies had a relatively more advanced and severe disease with a MELD score of 22 to 24 in one and over 21 in about 84% of the patients in the other, whereas the MELD score on an average was 18 in the initial seminal study. Another marker on histology is the diagnostic features of histological markers of alcoholic hepatitis on biopsy. And if it is combined with systemic inflammatory response syndrome features, it is quite accurate in that study on about 68 patients for a severe disease and a bad outcome. What about predicting corticosteroid response? There is a study from ILBS here from Dr. Sarin's group, fairly advanced liver disease with an average MELD score of about 25. And using Mallory-Denk bodies and ballooning of hepatocyte, they developed a score and a score of more than 5. They came up with this corticosteroid response prediction with an area under the curve of 0.73. However, another study from Altamirano from Spain did not find use of liver biopsy in predicting corticosteroid response. So that brings us to the last. I put this slide over there because this is a clinical unmet need, I think, of using biomarkers in a non-invasive fashion, not only for diagnosis of alcoholic hepatitis, but I think also more importantly for predicting prognosis in severe disease, but I think more importantly in patients who have moderate disease and moderate alcoholic hepatitis. And this is a study from UK almost 10 years ago, where they showed on liver histology loss of cytokeratin marker, which is K818, and not only it correlated with the diagnosis, but also with the severe disease. As you can see, there is more loss of this marker on the biopsy in the upper section, which is a severe disease patients, compared to much less loss of this marker in a less severe disease or a moderate alcoholic hepatitis shown in the lower section. And then there are some other markers which have come in the last 5 years or so, which have evolved using some of the inflammatory cytokines and chemokines based on hepatic inflammation, based on gut-liver axis, also macrophage phenotype, and in the monocyte oxidative stress and bioenergetic function, and genetic polymorphisms, to name a few. However, none of these is ready for prime time for use in clinical practice, and we certainly use and need more data before these can be used in clinics. So that brings us to our last two set of recommendations, that among patients with Aclf due to alcoholic hepatitis, clinical scores as of today determine the prognosis, whether you use Madrid discriminant function score or MELD score or a Lilith score for assessing response to corticosteroids. And liver biopsy for this purpose is not recommended. And we certainly need more prospective multi-center large studies to establish not only the role of liver biopsy, but also deriving simple, accurate, and reliable non-invasive biomarkers, especially for patients with moderate alcoholic hepatitis. And I once again thank you all for your patient listening, and I'll be happy to take questions.
The chair, Professor Eppen, please.
Thank you, Dr. Singhal, for your very detailed talk. May I request Professor Hashmik for any comments if she has?
Good morning, everyone. First of all, I would like to thank to Professor Ashwa for the very informative talk. Of course, liver biopsy was and remains gold standard for the diagnosis of liver disease. And the professor mentioned two indications of liver biopsy. First, for diagnosis, even with the proposed algorithm on the liver biopsy for diagnosis of alcohol-associated hepatitis in patients with Aclf, and second indication of liver biopsy for the predictive prognosis. So I totally agree with all recommendations, especially with last one, prospective multi-center studies to establish the role of liver biopsy and to deliver non-invasive biomarkers in patients with alcoholic hepatitis, especially in patients with so-called, again, Aclf. Thank you so much.
Thank you, Professor Hashmik. May I invite any comments from Professor Kin Wong-Wing? The other chair? Is Professor Win here? If they're not, I'll just add on my comment. I was thinking that the recommendation of between 1 and 4 seems a bit, well, highlights the challenge of the need for biopsy in Aclf due to alcohol. So the statement 4 says that biopsy is not recommended in alcoholic hepatitis precipitating Aclf, while statement 1 says that in alcoholic Aclf presenting with jaundice, if you were to give steroids or any other clinical trial, we would recommend biopsy. I think this is our challenge now. In Aclf, is biopsy needed? Answer will be, I guess, in the next round of a year from now, we probably will have data clarifying it further, and that probably is the challenge right now. Thank you.
Thank you, Professor Eppen. This was exactly my concern because the NIAAA 2016 paper says definite means histology is needed. Probable is on clinical. So based on that, everyone is asking for biopsy as a must. And therefore, I think I would rather go with the statement 4 among patients with Aclf due to alcoholic hepatitis, when other causes are not there. I think liver biopsy should be optional. We can say whether it is recommended or not, but I think diagnosis of alcoholic hepatitis can be made without biopsy if all the clinical criteria are met and there is no other evident non-alcohol cause in that patient. Part 2 is, do we need to do a biopsy for corticosteroid therapy? Also remains a challenge because such patients may be very sick. So I think both these statements, since Dr. Singhal is not here, can be re-looked at in the face of the current available data and the needs. Other than that, I have no additional comments.
Thank you. There is a question from a comment from the audience that transjugular biopsy may not be available everywhere. That is also a very valid point here. If at all, it is transjugular and not a percutaneous biopsy. I think I will hand back to Dr. Ashok Chowdhury for the next session. I would like to thank Dr. Singhal for an excellent talk highlighting the challenges in this area. Thank you.
Dr. Amna, you remain the rapporteur. I do hope you have justifiably added all the comments. Should we move on? Yeah. So we'll
Yes,
move on to the
Professor.
next.
Yeah, I've noted all comments and definitely we'll look into that. Thank you.
So we may invite the chairperson for the next session, Dr. Simon Stresser, Dr. Lespana, and Dr. Huntau. So I'm handing the session to the chairpersons, please.
Thank you. Thank you for this opportunity to do so. I would now, I'm not sure Professor Lesmana is here or not. Professor Lesmana, are you available? Or I might be going solo here. No problem. I would therefore like to introduce our next series of talks. Really, it's now we're moving very much to the clinical sphere and looking at complications and management of alcohol-related liver disease, ACLF. And the first talk is by Professor Minglung Yu regarding management of a severe alcoholic hepatitis with high bilirubin and cholestasis. And Professor Yu is the chair professor from the College of Medicine and Kaohsiung Medical University and Kaohsiung Medical University Hospital. I invite him to deliver his talk now. Thank you. Again, please.
Good morning, ladies and gentlemen. I'm Minlong Yu from Kaohsiung Medical University, Kaohsiung, Taiwan. This is my disclosure. For patients with alcoholic hepatitis, 2/3 had cholestasis and 1/4 had bile inductures. The bilirubinostasis. It correlated with the development of bacterial infection. Around half a patient with canicular, with or without hepatocellular bilirubinostasis, will develop bacterial hepatitis infection, which was correlated to a poorer prognosis in alcoholic hepatitis. The intraparenchymal cholestasis was also positively correlated to the serum bilirubin level and more frequent in non-survivors compared to survival. Total and conjugated bile acids are significantly increased and correlate positively with serum fibroblast growth factor 19 and with disease stability in patients with alcoholic hepatitis. The non-invasive marker of cholestasis, alkaline phosphatase, of 1.5 times upper limit of normal range could serve as a predictive marker of the poor 90-day survival in severe alcoholic hepatitis patients. Therefore, it is very important to find out the patient at high risk of mortality and treat this patient as early as possible. The most widely used non-invasive score to predict the short-term mortality is the modified monthly discriminant function, the MDF, with a car value of 32. In the absence of treatment, the 1 month mortality was 50% in patients with MDF of 32 or more, but less than 10% in those with MDF less than 32. The other score is the Glasgow Alcoholic Hepatitis Severity Score, GAHS. With GAHS at 9 points or more, we can characterize severe alcoholic hepatitis. The 1 month survival in patients with GAHS less than 9 was 87%, compared to only 46% in those with score of 9 or more. And recently, the AARC Aclf score, derived from the Apostle Aclf consortium, identifies the patient with high mortality as a short term. With the score of 11 or more, the patient had a 28-day cumulative mortality of 86%. And how to treat the patient who are at high risk of short-term mortality? There are 3 pharmacological options and one interventional option. The first choice of, in the treatment of severe alcoholic hepatitis is the prednisolone. In this large-scale randomized clinical trial, more than 1,100 patients of alcoholic hepatitis were randomized to receive either prednisolone or pentaciphyline or both, compared to the placebo. And as you can see, the prednisolone was associated with a reduction in 28-day mortality from 80% to 14% with borderline significance, but having no improvement in the outcome at 90 days and 1 year. For patients with receiving pentaciphyline, there are no any improvement in the outcome at 28 days, 90 days, and 1 year. And another randomized clinical trial tried to evaluate whether adding acetylcysteine to prednisolone could improve the treatment outcome for patients with severe alcoholic hepatitis. 174 patients were randomized to receive either an acetylcysteine plus prednisolone or prednisolone only for 4 weeks. As you can see, the mortality was significantly low in prednisolone plus an acetylcysteine than in the prednisolone alone at 1 month, 8% versus 24%, but not at 3 months and at 6 months. Therefore, prednisolone plus an acetylcysteine could increase the 1 month survival among patients with severe acute alcoholic hepatitis. The granulocyte colony stimulating factor, GCSF, can help in hepatic regeneration by mobilizing the bone marrow-derived CD34 positive cells, which significantly reduced the development of sepsis and subsequent multi-organ failure. In the trial conducted by Dr. Guy and his colleagues, 47 patients with acute and cognitive failure, and more than half of these patients had underlying alcoholic hepatitis, were randomized to receive either GCSF plus standard medical therapy or placebo plus standard medical therapy. As you can see, the probability of survival at day 6 was 66% in the patient receiving GCSF versus 26% in the patient receiving placebo along with standard medical therapy. Another clinical trial conducted by Dr. Singh and his colleagues include 46 patients with severe alcoholic hepatitis to receive GCSF plus standard medical therapy or standard medical therapy alone. And again, they observed a marked improvement in survival at the 90 days for the patients receiving GCSF compared to the patients without GCSF, 78% versus 30%, indicating GCSF is safe and improves liver function as well as survival in patients with severe alcoholic hepatitis. But not all of the patients respond to the standard to the steroid very well. So this it is very important to identify the patient of steroid non-response as early as possible. The most used model is the layer score, including age, renal function, albumin, prothrombin time, bilirubin level at the baseline and the day 7 of steroid therapy. With a score of 0.45, we can predict a 6 months survival of 25%. With a score of less than 0.45, the 6 months survival was 85%. So indicating patients with large score more than 0.45 have a very poor prognosis at the 6 months. So after identifying the steroid non-responder, how can we treat these patients? The first choice is liver transplantation, and the alternatively is the GCSF. the liver transplantations is the most effective therapeutic option for patients with liver failure of all etiologies. However, in the clinical trial conducted by the Ponya and his colleague demonstrated the survival benefit to the liver transplantations was only observed among the patients with advanced decompensations for patients with alcoholic-related cirrhosis, the CHAPA-C patient. Only minimum effect for the patient with CHAPA-B and almost no effect for the patient with CHAPA-A. And the post-transplantation prognosis is largely depend on the whether the patient have excessive alcohol consumption or more or not after liver transplantation, because excessive alcohol consumption will have a negative impact on the long-term survival of this patient population after the transplantation. Therefore, it is very important to introduce multidisciplinary support before and after liver transplantation to help the patient to prevent recidivism. And in the recent study published in Hepatitis 2019 by Dr. Chesri and his colleague, randomized the 33 so-called steroid non-response severe alcoholic hepatitis patients to receive either GCSF for 28 days or placebo for 28 days. The steroid non-response was defined as patient had a light score of 0.45 on day 7 of steroid. And the result demonstrated the 28-day mortality did not differ between the two groups. However, for patients who received GCSF, the 90-day mortality was significantly low in this patient population, 36% compared to the placebo, 71%. Along with the low infection rate and the significant decrease in mean score for the patient receiving the GCSF. So this data demonstrating GCSF could be an alternative rescue therapy for the patient with severe alcoholic hepatitis who do not respond to a steroid and have no transplant options. So ladies and gentlemen, assessment disease severity is recommended in alcoholic hepatitis patients with high bilirubin and cholestasis due to high risk of bacterial infections and poor prognosis, level 1 grade A. Severe alcoholic hepatitis patients with MDF of 32 or more, GHS of 9 or more, AARC, Aclf score of 11 or more, have a high short-term mortality and should be treated immediately, level 1 grade A. Corticosteroid is recommended for severe alcoholic hepatitis patients without active infection to reduce short-term mortality, level 1 grade A. N-acetylcysteine for 5 days intravenously may be combined with corticosteroid in severe alcoholic hepatitis patients, level 2 grade B. GCSF for 5 days with standard medical therapy may be an alternative therapy for severe alcoholic hepatitis, especially for those contraindicated to corticosteroid, level 2 grade B. Early corticosteroid non-response at day 7 should be identified, such as by using the Lea score, level 1 grade A. Selective use of early liver transplantation can be life-saving for corticosteroid ineligible or corticosteroid non-response severe alcoholic hepatitis patients, especially for those with advanced decompensation, CHAPA-C and or mean score of 15 or more, level 1 grade A. Liver transplantation should be reserved for severe alcoholic hepatitis patients with low risk of recidivism as assessed by a formal psychosocial evaluation, level 1 grade A. GCSF may be an rescue therapy in severe alcoholic hepatitis patients who are corticosteroid non-responders and have no transplant options. Thank you for your attention.
Thank you very much, Professor Yu. I wonder if we could bring back up the consensus statements. Thank you. So they split across two screens here, I think. And again, I'm not sure Professor Lesmana has had the opportunity to join us. Professor Lesmana Senior, I mean. So I would invite, I can make some comments, but the issue, there's 9 consensus recommendations here, but they're going to overlap significantly with some of the other sessions that we're yet to hear. So I think they'll obviously have to be harmonized with those. And I'd like to invite if anyone has any particular comments around any of the recommendations that have been made on the back of an excellent overview, particularly of the therapies that should be evaluated and recommended in alcoholic hepatitis. Are there any comments from anybody?
I just want to add one point is N-acetylcysteine. This is just the one New England Journal paper in 2011, but subsequently there was no added advantage. So I am not sure. Other than this, I think it's a wonderful job done by Professor Yu, except I have some reservations on the N-acetylcysteine. So I would like you to comment and maybe the speaker.
Yes, I think it could certainly be covered in the text, but perhaps not strong enough for a recommendation. I'd agree with that.
May I make a comment?
Yes, Professor Singh.
Yeah, this is regarding the N-acetylcysteine. We conducted a study in which we had a combination of the G-CSF and the N-acetylcysteine in patients with a severe alcoholic hepatitis, and this is the paper published in Clinical Gastroenterology and the last issue only. And in that, there was no added advantage of the N-acetylcysteine.
So I guess the jury's still out on the role of N-acetylcysteine. It's interesting, could be considered, but probably not strong enough for recommendation. The other comment I'd make is around, and Professor Rayla is going to talk about liver transplantation later, but I guess the focus of this consensus is around specifically around alcoholic hepatitis with Aclf, and there probably should be a specific statement around liver transplantation in that context, because at the moment all guidelines have comments about liver transplantation in severe alcoholic hepatitis not responding to steroids, but whether the Aclf group is different to the non-Aclf group in there is something to be discussed, I guess. Any other comment?
Yeah, can I make a comment?
Yeah.
Professor Maywell, yes.
Dear Professor Strasser.
No, I'll ask you to talk.
Dr. Han. Yes.
Okay.
Thank you, Professor Xu. Excellent talk. I agree your the recommendation in your slide, but I have some suggestion. First, NAC combined with corticosteroid, you recommended, but I think so. This should be more data as a regular before recommendation routine examination used. I think so. Should be either increase the survival of the short-term survival or long-term survival, but should be added. I should be comments in your recommendation. I think so, including G-CSF. I think so. Another suggestion. I think so. Severe alcoholic hepatitis or alcoholic related disease Aclf is very high mortality. I think so. This patient should be immediately intervention. In Acsl ACF consensus recommendation 2019, we recommended plus exchange single or combination artificial liver support system appear to be a promising and effective bridge therapy in ACLF patients for liver transplantation. I think so. Plasma exchange or single or combination therapy should be recommended in these patients. Although we have no strong evidence. Thank you.
Thank you, Professor Han. Professor Maywell also had a comment.
Yeah, I just wanted to add on one more point that if we can include, this was a wonderful consensus and the talk about identification of non-responders to corticosteroids early. So we have from our center, the baseline data itself can tell us, and now there is emerging data on calculation of Lille score at day 4. So you need to identify non-responders early on for consideration of alternative therapeutic strategies. That could be also included as a low-grade consensus or a recommendation.
Yeah, just also to continue with Dr. Tauhan's comment, just yesterday the paper has come on the clinical gastro and hepatology, that plasma exchange, and that's also Dr. Maiwal's paper, that plasma exchange may be helpful in ACLF patients. So I think it would be worthwhile to at least say there is a promising encouraging result, and it can be tried. I think it can be reworded by Professor Yu in consultation. That is my suggestion to the chair.
Yeah, but one suggestion for this section of consensus is that how to manage with the high bilirubin and with cholestasis. So we have not covered in the consensus. That is one important. I think we should add this point also. Cholestasis is a poor predictor for the response to therapy. And this is not coming.
There is one paper which has just come by Raman Batalar, I think a few days ago, where they have divided this high bilirubin into fellers, rapid fellers, non-fellers, and risers. Very common terms. When the bilirubin automatically come down, bilirubin does not come down from the entry point, and bilirubin keeps rising. I think Ashok's point is very valid. We need to add also the relevance of bilirubin alone, whether it is good or not, into the consensus. So maybe Professor, you have, and the chairs have additional tasks.
Professor Yu, would you like to comment about having a recommendation around the dynamics of bilirubin?
Yeah, thank you. Thank you for all your great comments. I think I make some minor revision, especially from the evidence of the NRCCS16 and the benefit of NRCCS16 and the GCS in the middle 10, 16, and 19 days of survival. And I added the recommendation of plasma exchange as a bridging therapy between the for the extension to for the patient to liver transplantation. And also I will added the Professor Staley's comments, try to integrate the recent publication about the bilirubin level changing in the prediction of the tumor outcome. Thank you very much.
Thank you, Professor.
Dr. Liu, just a comments for the statement side. I think Dr. Virendra Singh is also there. The GSF dose should be 12 hourly or 24 hourly.
For
GCSF.
GCSF 12 hourly is very convenient. 24 hours we cannot give it.
We can look into all the data based on available information, whether 12 or, but broad statement can be maintained, dosages can be looked into patient-wise.
Okay.
So we can remove the duration, we can keep GSS. Yeah.
I think there needs to be a discussion around whether the plasma exchange is to the level of a recommendation or embedded in the text at the moment, as it's still under development. So if there are no other comments, then I think we'll close and move on to the next session. Thank you.
Thank you. Thank you, Trust. Thank you all.
Thank you, Professor Lee. And we'll move into the next session. So I request chairpersons Professor Mamun and Professor Anil Arora to take the session, please. Professor Mamun, please. So Professor Anil. Okay. So Professor Virendra Singh, I think everyone very well know about him that he's having tremendous work on ascites. So Professor Virendra Singh, please.
Yeah, I have already uploaded the lecture. Can you just start it?
Izumi, please share this.
Thank you, Mr. Chairman. In the next 10 minutes, I'll be speaking on the recommendations for the management of ascites in ALD-ACLF. This is brief review of AARC Aclf data on ascites in ALD-ACLF. There were 1639 patients with the acute alcohol etiology. And number of patients with the ascites at presentation was 96%. Grade of ascites at presentation was grade 1 in 26%, grade 2 in 63%, and grade 3 in 10%. AKI at presentation in 34%, HE at presentation in 13%, and variceal hemorrhage at presentation in 9.3%. Mean MELD was 30, mean MAP was 84, and serum sodium less than 130 was seen in 48%. Serum potassium hypokalemia was seen in about 12.3%. This is regarding the diagnostic paracentesis in ALD-ACLF. The diagnostic paracentesis is recommended in all patients with a new onset grade 2 or 3 ascites, or in those hospitalized for worsening of ascites or any associated complications, that is HE, AKI or variceal hemorrhage with presence of grade 2 or 3 ascites. Early paracentesis, that is within 24 hours, should be performed in hospitalized patients. Initial assessment of ascitic fluid should include neutrophil count, SAG, protein concentration, and the culture. Cytology should be performed to differentiate malignancy related from the non-malignant ascites in cases with the clinical suspicion. Ultrasound guidance should be considered when available during diagnostic paracentesis and LVP. The routine measurement of the prothrombin time and platelet count before therapeutic or diagnostic paracentesis and infusion of blood products are not recommended. However, caution should be exercised in patients with high MELD, that is more than 25, renal dysfunction, hypofibrogenemia. Early paracentesis in high-risk hospitalized patients. This is a patient cohort created from the New York, Florida and the Washington State inpatient database between 2009 and 2013. And in this, only 58% of inpatients with the ascites received the paracentesis within 24 hours, and early paracentesis is associated with reduced inpatient and SBP related mortality and 30-day. This is a study in which they looked at the hemorrhagic complications following abdominal paracentesis in acute and chronic liver failure, a propensity score analysis. Here they found that ACLF patients with a MELD more than 25 and fibrinogen level less than 0.7 have a higher probability of hemorrhagic events with a positive predictive value of 36.5%. In this another study, they looked at the various factors which were associated with the bleeding, and they looked at AKI, refractory ascites, sepsis, volume of the paracentesis removed, then the chronic kidney disease, and they found that AKI prior to the paracentesis is the only independent predictor of post-paracentesis hemoperitoneum. This is regarding the dietary salt intake in patients with the ALD-ACLF. A diet with the moderate sodium content, that is 80 to 120 millimoles per day, corresponding to 4.6 to 6.9 grams of salt, is recommended in ACLF patients with the ascites. Patients should undergo adequate nutritional education and counseling on how to manage dietary sodium while maintaining adequate nutritional intake. This is regarding the initiation and the titration of diuretics in ALD ACLF. This is on the usual pattern, and there is nothing different as we manage patients with the outcomes and mortality of grade 1 ascites and recurrent ascites in patients with the cirrhosis. This is a post-hoc analysis of data from 547 outpatients with the cirrhosis, in which there were 259 without ascites, 54 patients with grade 1 ascites, 234 with grade 2 or 3 ascites, and 26 patients without ascites, and 7 patients with grade 1 ascites developed overt ascites during follow-up of 6 months. 60-month development of overt ascites was also not different in patients without ascites and patients with ascites. The presence of grade 1 ascites was not found to be an independent predictor of overt ascites. Natural history of grade 1 ascites in patients with liver cirrhosis. There is no data on the ACLF, but we can extrapolate from this. The retrospective study of 100 consecutive patients with the grade 1 ascites. Diuretics initiated in 58 patients with the grade 1 ascites at baseline by attending physician. At the end of follow-up, 29 patients had no ascites, 33 patients had grade 1, 17 patients had grade 2, and 21 patients had grade 3 ascites. Advanced age and HCC were the only factors related to ascites outcome. Treatment with diuretics at baseline or during follow-up was not correlated with regression of ascites. Now, these are the complications and titration of the diuretics in ALD ACLF in patients presenting with the GI hemorrhage, AKI, HE, hyponatremia or hypo or hyperkalemia. Correction of abnormalities should be made before starting diuretic therapy. Additionally, in these subgroup, cautious initiation of diuretic therapy and frequent clinical and biochemical assessments should be performed. Diuretics should be stopped in cases of severe hyponatremia, AKI, worsening hepatic encephalopathy, or incapacitating muscle cramps. Loop diuretics should be stopped in cases with severe hypokalemia, and anti-mineralocorticoids should be stopped in cases with hyperkalemia. This is regarding LVP in ALD ACLF. LVP is the first line therapy in patients with the large ascites, which should be completely removed in a single session. In patients undergoing LVP of greater than 5 liters of ascites, plasma volume expansion should be performed by infusing albumin in the routine doses. The risk of PICD is high in ACLF, even in patients undergoing LVP of less than 5 liters of ascites. Usage of albumin may be recommended in such cases to prevent the development of PICD. Day 3 plasma renin activity of 25.15 nanogram per ml per hour may be used as a predictor of the development of PICD on day 6. Once LVP is done, patients should be started on the minimum dose of diuretics necessary to prevent reaccumulation of ascites. When needed, LVP should also be performed in patients with AKI or. This is the study in which they looked at the PICD with the modest volume paracentesis, and these were two groups. In one, they gave albumin. In the other group, they did not give albumin, and they looked at the PICD. The PICD was much more commoner in the group in which albumin was not given. PRA was again raised in the group where the albumin was not given, and the ROC curve on day 3 PRA value of 25.15 was 0.77. This is regarding the additional therapy in ALD ACLF. Non-selective beta blockers may be used in patients with ACLF and ascites and has been shown to be associated with a lower incidence of SBP and AKI at 28 days. Midodin may improve tolerability of diuretics and decrease the requirement of paracentesis in. This is a study again from the ILBS. Treatment with the carvedilol improved survival of patients with acute on chronic liver failure. There were 70% of patients had alcohol as etiology. Carvedilol dose in the dose of 3.125 milligram twice daily was titrated on the weekly basis by monitoring the heart rate and the systolic BP. The median carvedilol dose was 12.5 milligram. 100% patients had ascites at presentation. The development of SBP was significantly less in the carvedilol group within 28 days. This is another study in which they use the midodrine in patients with the Aclf. For the ascites, 45 patients with the Aclf in this study, and they divided into two groups. In one, they gave midodrine, in the other, they did not. And the dose of midodrine was 22.5 milligram per day for about a month. And midodrine significantly improved the MAP and urinary sodium excretion. 33.3% of patients required paracentesis in Group A compared to 62.5% in Group B. Group A patients tolerated a higher dose of diuretics than Group B. Diuretic-related complications developed in 54.2% of patients in Group B compared to only 23.8% in Group A. 14% in Group A developed side effects to midodrine and required dose modification. Mortality at day 30 was similar in both. Now we can have questions or the comments.
Thank you,
Dr. Virendra, can I ask a question?
Yeah.
Yeah. What do you think is the basic difference in the ALD-related Aclf vis-a-vis etiologies related to viral hepatitis or drug in terms of differences in recommendations for management of ascites?
I don't think there is much difference, but since I was asked to prepare the recommendations with regard to the ALD Aclf, that is why I presented this on.
Okay.
Any other comment? I think it was very nice. We can read the recommendations, and if there is any comment on this, I think one of the issues which Professor Arora has raised is about the etiology. I think it may be worthwhile that we look into all the data based on Aclf with different etiologies as far as ascites is concerned. So I think we have only data analyzed in AARC for Aclf, alcohol, and ascites. But if we analyze all the data, maybe we can have some more information. And secondly, my thinking, this is not evidence-based, that alcohol with Aclf is probably much more severe and may have higher incidence of SBP and infections. But this is only assumption. I cannot. Your comments.
Sir, can I say something about it, sir?
Yes,
alcohol
please.
has pleiotropic effects starting from the GI tract in terms of suppression of claudin, affecting the intercell permeability, changing the bacterial flora. All that will contribute further to portal hypertension, in addition to have direct toxicity on the liver. So maybe Aclf induced ascites and the complication are more likely to be severe than those which are not related to, like viral hepatitis B will not affect the GI tract directly as much as alcohol. Will that contribute to differences?
This may be one of the reasons, but I was trying to look at the different etiologies and the presence of ascites and the different complications, but the data was incomplete in the AARC data. So probably there may be a difference between the two groups, the alcohol and the non-alcohol etiology. We can have a relook at the data of AARC.
If we can stabilize, if you can look at confounding factors like MELD score or ARC score, then I think it is important to look at the etiology, which may have a confounding factor.
Yeah, maybe.
Sir, as suggested in the consensus number 4, cytology should be done routinely, sir.
See, this is we will not get many of the patients positive for the malignant cytology, but as a routine, we should do a malignant cytology, because you never know, there may be a cause of ascites may be different.
Yeah, I think one more point I want to ask Dr. Virendra Singh and other colleagues is that normally when you do an LVP and you give albumin, in the cirrhotic decompensation, albumin is tolerated, but in Aclf, high dose of albumin has recently been recommended up to 1.5 gram per liter might lead to some overload. So I think we may add a statement albumin usage should be judicious, or maybe to monitor more closely for volume overload. Something, if you like, and can advise us.
Yeah, we have to be a little careful when we are giving albumin, especially in Aclf patients, but there is no data on this.
Yeah.
Sir, we are coming over the data, ACL data.
Yeah, but Abhi, right now we don't have published data. So,
yeah.
Can I just, last point, sir? Can I just make?
Yeah.
Sir, would you like to add sepsis in where you are addressing caution on bleeding complications, high MELD, renal dysfunction, sepsis? So
Yes, of course. Yeah, we can add that.
Okay, thank you, sir.
And the only thing which I am having a little difference from the standard guidelines of ascites, that as I pointed out, that the grade 1 ascites in cirrhotics may not require the use of diuretics. But here, this is totally a different group. The grade 1 ascites, because all these patients undergo the ultrasound, so we can very well detect it. And if there is a grade 1 ascites, there is a high chance that these patients will go into grade 2 and grade 3 ascites. So rather than not using diuretics, the diuretic should be used in these patients, even with the grade 1 ascites.
Can I ask a question to Dr. Singh?
Yeah.
That now, routinely in patients with decompensated cirrhosis and ascites, it is almost a routine to give them intravenous albumin. And we know in Aclf is an advanced stage of liver failure. So why do we say that up to 5 liters it may be safe? I think it should be mandatory that all ascites in Aclf which is being tapped has to be supplemented with albumin. There is no exception.
Yes, we'll have to.
And that is what
we will have to see. See, the problem is that if we are following that rule of the more than 5 liters only, then we supplement it with the albumin. That is probably, to my mind, is incorrect. We are befueling the body. See, if we are taking out 4 liters daily and then we are avoiding giving albumin, that is wrong. These patients may not present with the frank PICD, but there is some hyponatremia, maybe all those changes, or the low MAP, the renal dysfunction may ultimately develop. So they are prone to develop even at a lower level of the therapeutic paracentesis. So these patients should have albumin even when you are taking out less than 5 liters of the acidic fluid, as has been shown in the modest volume of the paracentesis. In that, they have shown that we can take out the less than 5 liters.
Okay. We need to, I think, sorry, conclude, Dr. Arora, we're running late. And I think recommendations can be relooked at by the chairs and the other members. May I request now, and thank you, Professor Viren Singh, for very elegant talk. Ashok, can we move forward, please? Yeah. Thank you, Dr. Anil.
Thanks, Professor Singh and our esteemed panelists. We'll go to next interesting area, that is AKI in alcoholic hepatitis leading to ACLF. So, Professor George Lau from Hong Kong, Professor Akka Sukla and Professor Samit Saha are the chairpersons. So now I'm hand over the sessions to them. Professor Lau, please.
Please, I mean that this should be a very important topic with acute kidney injury, and without any undue delay, would you please start your presentations?
Thank you for inviting me. Are my slides up, or do I just share it, or? Does the committee have, you don't have my slides yet, do you?
Resume, please play the slides.
If not, I can, let me see if I can share. Oh, there it is. Okay, well, thank you for inviting me. Hopefully I can finish the talk without falling asleep. It's close to midnight here. How does this go forward? It's not letting me share.
Yes, sir, you can do that. Share it.
We can see your slides, but I think
oh yeah,
moving now. Perfect.
Okay, this disclosures. No, but it's not. Okay, let me just see here. Okay, so as all of you are aware, and I'm not going to go through the history, but prior to 2010, there really was no real definition for AKI in patients with liver disease, and it was all around whether a patient had hepatorenal syndrome or not. And some studies would put this cutoff of 1.5 as an AKI, but really a lot of patients were eliminated from many of the studies because there was no true definition. And in 2010, the ACl had a consensus meeting with some of the members of the International Club of Ascites. And what we proposed at that time was this staging of AKI to be based on the Aiken criteria, which at that time existed. And it was basically, the definition would have been an increase in serum creatinine by 50%. And at that time, what we proposed was that HRS1 to be a type of AKI, and maybe HRS2, which is more slowly kind of lingering, to be a form of CKD. This was ultimately kind of taken and slightly modified by the International Club of Ascites in 2015, and by then the KDIGO criteria had come out, and it's very similar to the Aiken, except it puts a time point of 7 days. And also they added this baseline serum creatinine, which is debatable for many patients. They may not have a serum creatinine coming in, and what to define it. So this became the basis of how to define AKI, and it was mainly really only on the serum creatinine. And urine output at that time was not included in any of these recommendations, because there really was no study out. And this is really the largest and only study out in liver patients with looking at urine output, the criteria for urine output based on KDIGO, and this is from Pittsburgh by Dr. Kellerman. You can see here patients and this is from 8 ICUs in Pittsburgh, patients who had no AKI based on serum creatinine criteria, but they had it based on just urine output criteria. They had a 22% mortality rate. And that's even more than if they had no urine output criteria, but a stage 3 serum creatinine. And if both of them existed, it was close to 50% mortality rate. And these numbers are very similar to the general ICU patients that Dr. Kellerman has published in the past. And this is, again, something kind of set forth by myself and Paulo and Lupe Garcia and Chirag, is whether or not to kind of get away from this classification of HRS 1 versus 2, and look at more whether this HRS-AKI, and this would include not only serum creatinine but urine output, but more these patients who get renal, like the refractory ascites patients who develop AKI, then they get better, but then again another bout of AKI, and they just kind of slowly get worse, and whether those should be called AKD, which is basically a patient who doesn't fit the criteria for AKI, or CKD, and it's in between that, or if they have underlying CKD, to call it HRS-CKD. Now, what about the patients with alcoholic hepatitis and AKI? Well, again, this is a study from Perez group, and again, very similar to what we see on all patient populations. Patients who develop AKI tend to have a worse prognosis. Their survival is quite bad. And here you can see in patients with acute alcoholic hepatitis, again, those who did not develop AKI, they actually did quite well with a survival of 93%, versus those who developed it was 35%. And looking at factors that influence this development of AKI, what they found on multivariate was really the presence of SIRS was very strong in determining whether or not these patients develop AKI. And then the serum bilirubin and INR, which again, from a nephrologist standpoint, there's kind of you add the creatinine, that's kind of the variables for the MELD. So the sicker they are, the worse they do. But really this presence of SIRS is quite strong with an odds ratio of 18. And this is from Professor Sarin's group, looking at, as a prospective study, severe alcoholic hepatitis. And these were patients who did not have AKI, and they followed them during their hospital course to see how they progressed. 60% had SIRS, and from that, 40% about did not have, was associated with bacterial infection, which is very interesting that 60% did not have any positive cultures. But about a third of these patients developed AKI, and from that third, about 40% of them did progress throughout their hospital course. And again, looking at the multivariate, the variables that cause them to develop AKI and multivariable adjustment, the MELD, the hepatic encephalopathy, and again, this SIRS keeps coming up as a predictor of development of AKI. But regarding progression, it was just the MELD score which determined their progression throughout their hospital course. And so, again, this is multi-center looking at whether you can come up with some scoring system to predict who will develop AKI, because in a way it kind of helps you not only to classify patients, but maybe be a little bit more attentive or preventive measures for these patients. So this multi-center, quite large, and very nicely done with 390 patients, and then they validated another 380 patients. And again, a third, very similar to the previous study, a third of them developed AKI. And the 90%, the 90-day survival, again, was worse, which we see in even non-alcoholic patients. They tend to do worse if they develop AKI. And so based on their multivariate, they found hepatic encephalopathy and SIRS and MELD score. And when they categorize it into these various scoring systems, those that scored the lowest actually did quite well with 88% survival at 90 days. And those who had higher scores did quite poorly with 50% survival. So what about management? Again, I'm not going to go through, all of you are experts in this, just to say that for any patient, whether it's alcoholic hepatitis, for any cause of AKI, we kind of have this general algorithm that we follow, but we always get stuck, whether we're nephrologists or hepatologists. Once it gets to this ATN HRS, we can use whatever, we try to use the clinical, how the patient clinical presents. We can look at urine indices, but at the end, a lot of times it becomes very difficult. It's the flip of a coin, whether you want to say it's HRS or ATN. It's not as easy as we'd like to. There's now studies slowly coming out regarding the use of biomarkers with NGAL, and this is Perez group again, looking at day 1 and day 3, and the NGAL actually performed well, there was still a lot of overlap between the HRS and ATN group, but it performed quite well at a cutoff point of 220. Again, these are, at least in the US, the NGAL that's used is different, so the cutoff is going to be very different from what is being published in the Barcelona group. But it could be a tool in the future to help at least be able to identify between these two patients. But how do these patients even, presents with ACLF compared to acute decompensation? From a nephrologist standpoint, we used to think, and maybe the hepatologists in the past, that these are all the same. And now we're starting to see, no, these ACLF patients are quite sick compared to the decompensated patients. And again, this is from Professor Sarin's group with looking at patients ACLF and acute decompensated. And quite a number of them, about 60% of these patients in both cohorts had alcoholic hepatitis. And you can see the ACLF patient cohort tended to have more ATN compared to the acute decompensation, which were more a pre-renal state. But what was interesting is that the number of HRS was similar, yet the outcome of the patients who had ACLF did much worse in terms of ACLF, or even if they developed AKI. And predictor of mortality, these were variables, but again, if they progressed, if their AKI progressed, they tended to do worse. So again, we all, knowing that, these patients, if they develop AKI, or if they progress, get worse, well, the best thing is if we can try to prevent it. And, sometimes it's possible, sometimes it isn't, but these preventive methods not only prevent AKI, but even if they do develop AKI, a lot of these management issues, if we follow these strategies, can even prevent it from progression. So you'll develop AKI, but it won't be as severe. And again, it's avoiding nephrotoxic agents, radio contrast, and hemodynamic instability. Regarding the beta blocker, I know just the previous Professor Singh had presented the beta blockers helping in this at least study in the severe alcoholics hepatitis. Those patients who did get a beta blocker actually tended to do worse in terms of also developing worse, more AKI. This is again, retrospective study, not too, 139 patients, which I guess is pretty large for alcoholic hepatitis. 60% developed AKI compared to the other studies, which was about 30%. Overall mortality was the same, but the patients who were on this non-specific beta blocker tended to develop a higher incidence of AKI. As far as terlipressin, as all of you are aware, in the US it's not available. There's been two, now this third study, two published studies. The third one is still not published, but it was presented as late-breaking abstract. The first two were negative, and not negative studies, but they didn't meet their primary endpoint, and therefore FDA had not approved of it. This third study, they did reach their primary endpoint, and what was interesting is that they found that there was a higher incidence of reversal and a lower incidence of requiring dialysis in those patients with alcoholic hepatitis, with those patients with SIRS or the MAP less than 70. Unfortunately, they had a higher rate of adverse events, especially respiratory, which is thought to be, and this was again the discussion with the speaker before me, with the use of albumin, and this could have been one of the reasons really why these patients did worse. So they had a 90-day death from respiratory was 11% the terlipressin group versus placebo, and the risk for developing this complication was higher in these patients with ACLF grade 3, higher mild encephalopathy, and previous history. But like previous days of terlipressin, if you started earlier where the creatinine is less than 5, the patients tended to respond higher. But again, this is concerning to the FDA. For now, they have not approved of it, and the company is trying to figure out whether or not they can get approval with maybe excluding patient populations who are too sick to get it. What about dialysis? We're constantly, I remember when I started working about close to 2 decades ago, you know, if you had HRS, people would just say, and you're not a transplant candidate, just let them die. Well, things have changed since 20 years ago. And this is a study very nicely showing that it really doesn't matter if you're HRS or ATN, your mortality will be high, but it's no different. And even if you're not transplanted, you're no different from someone who has ATN. If you are listed for transplant, again, the mortality is about 40 to 50%, but no different regarding the etiology of that. And so again, this is from our own center. Once they do get transplanted, however, those patients who do have hepatorenal syndrome tend to do better in terms of survival outcome and kidney disease. So my personal feeling, again, it's as a nephrologist, I offer dialysis to patients who, regardless of whether or not they're transplant candidates, if I feel like that patient can leave the hospital. Futility is a big thing that we all talk about. Again, this is UNOS database that we looked at. It's 65,000 patients. And even though the UNOS data, we can't pull out Aclf per se patients, but the acuity of them, you would imagine a lot of them did have probably Aclf, but you can see about 25%. And these are patients whose MELD is over 40. So even though in the US it's capped, we uncapped it. And you can see here 50% on dialysis, 40% on ICU and ventilators. So a lot of these patients probably had Aclf. And you can see here their survival as the MELD goes up on the wait list is horrific. However, and this was another speaker showed, their outcome, once they get to transplant, they actually do quite well. So even though they may be very, very sick, if they do get to transplant, they actually do well. And and it's a disservice to keep them on the wait list, because as the MELD goes up, if you uncap it, patients tend to do extremely poorly, and there's an actual survival benefit. And I think these Aclf patients are the same. We see it a lot in our center in California. We're in a region where a MELD 40 has to wait 4 weeks. And I see that these patients who are Aclf very quickly decompensate, very quickly go downhill. But if they get transplanted, they actually do much better than these slow kind of going up MELDs. And I'm going to final with 2 more slides, and this is from the Acsl Consortium. And again, it goes to, and this is my own thought as a nephrologist, it's not really whether or not a patient's a transplant candidate or not. I really pay attention to their, organ dysfunction. If it's getting better, this is Aclf. All of you know that the patient presented with even a Aclf 3, which is very, very sick. But if by day 3 to 7, if they're getting better and now they're like Aclf, no Aclf or Aclf 1, they actually do quite well. So to not offer them dialysis, I think, is a mistake. And I think every patient should be treated such that they are going to be recovering. And then by day 3 or 7, you can individualize your decision. And if it's the Aclf 1 that becomes a 3, you may have a family discussion there. But I think the problem is starting too late on these patients. And this is from a consensus meeting that was a couple of years ago with several hepatologists, several from the International Club. And our recommendation, there's now 4 not in liver patients, but there in the last 3 years, there's been 4 large randomized controlled trials looking at early versus late dialysis in critically ill patient. And they all basically have concluded you go by clinical grounds. If a patient needs dialysis by clinical, nothing very, very early, but clinically in a liver patient, if it's worsening renal function, worsening volume overloaded, which a lot of these patients develop, especially if they have Aclf, especially the alcoholic hepatitis, they become very, very sick very quickly. Acidosis, these should be reasons for starting someone on renal replacement therapy. And again, the discussion was fluid overload. The best is to avoid it, but if they do become fluid overloaded, to initiate it before the consequences of fluid overload and the patients deteriorate. I just put some recommendation. The majority of this is from, I reviewed your recommendations from previous years, and I didn't want to copy all of that. I, agreed with all of that. There hasn't been much change in the kidney world, and specifically to alcoholic hepatitis or ACLF. What I would change would be, I think your previous recommendation was mainly an ACIN criteria and just the serum creatinine with the suggestion of a urine output. But my recommendation would be, since it's now KDIGO, to diagnose and stage AKI for whether it's alcoholic hepatitis or ACLF, based on the KDIGO, not only serum creatinine, which there's a lot of data in your liver world, but urine output criteria. There's that one large study, so I gave it a level C, but it really should be a recommendation. This is just from serum creatinine. And I added this, that all attempts should be made to prevent development of AKI based on KDIGO and other relevant guidelines. And this can be specified from, hepatology societies, whether it's Acsl, Acsl, ASLD. All of you have all these guidelines, and using those guidelines specific to liver, plus the KDIGO guideline, which is just general kind of, specific to any general population, that it should be, every attempt should be made for that. And once AKI is diagnosed, really to try to figure out what the cause is. For alcoholic, hepatitis, the majority of these patients will have either hepatorenal very quickly because of just how sick, or ATN from sepsis. And again, the biomarkers, it's not available, at least in the US, but it's some hopeful thing. And again, the terlipressin is nothing new to any of you. So again, the recommendations I read the last 3 years, just a few minor, just to change the KDIGO criteria. Thank you.
Well, thank you,
Dr.
Yeah, maybe I just have questions for you. I'm a hepatologist, and very glad to see a nephrologist to come in. I always have arguments with my nephrologist in the ICU.
We do that too.
Yeah. I just want to know, what is your preference of renal replacement therapy? Nowadays, we have various formats, CRRT, hemodialysis, and so on and so forth.
Well, if in our institution, we have the luxury of having CRT machines. We have the luxury of the nursing, at least in our institution, because it's one-to-one nursing. So a lot of institutions can't do it. I personally prefer, again, because the majority of these patients are borderline blood pressure. Mm-hmm. If I'm trying to protect that kidney, because they're only going to get a liver transplant, mm-hmm. Every insult to that kidney with a drop in blood pressure, and even though we think, okay, a cirrhotic can tolerate a MAP of 55, but still every time they go on the dialysis machine, for the first 15 minutes, it can drop very quickly. And so that's adding an insult to an injury. So if their blood pressure is borderline, or if they have anasarca, which we sometimes see, especially in these alcoholic hepatitis patients, because, they've been sitting at home, they don't come, they were drinking, and then by the time they come, they're either in shock, they get so much fluid, and then in 3 days, it's fluid over. Where you have to take a lot of fluid off, then I prefer CRT. If they are, often we have patients who, they're initially hypertensive, but whoever, and all of you know better than me, if you have a hypertensive patient who's a liver patient, that patient probably is fluid overloaded, because the majority of patients have to be hypotensive. So initially we do CRT. The minute the patient is no longer a candidate, then we start quickly trying to transition the patient so that we can get them out of the ICU and home, whether it's home or home hospice, but we try to quickly transition them. But again, we have this, luxury of having that. It is better tolerated for these patients. And again, it will kind of protect the kidney initially from the drops in blood pressure.
Yeah, the reason I put up these questions is the cost is different.
Exactly. So that's why I said we have the luxury Has any study ever been proven, even in the non-liver patients, that there's a difference? No. Even outside of cirrhotic patients, no one has been able to show the difference. The problem is that all the studies are very biased because the people who are sick who can't get dialysis have been excluded from trials.
Right.
So, but yes, that's why I said we have the luxury of doing that, but it's very costly. So if a patient is not going to get transplanted for 4 weeks, we don't keep them in the ICU for 4 weeks. Usually we try to do it if we know that the patient is going to be quickly listed and hopefully transplanted within like 2 weeks. Otherwise, it's very expensive.
I mean, that's usually the hard arguments because we do not have recommendation of which form of therapy is being used. It's sometimes difficult.
Yeah, the KDIGO guidelines is very general that if you're hemodynamically unstable to do CRT. Now the question is, what's your threshold for that?
Right.
And even KDIGO doesn't put a threshold.
No. Yeah. Well, we have this debate many times. Shiv or Shulka, you want to join in for the discussions?
Thank you, Professor Nadeem. It was really amazing. Two quick questions, basically. One is regarding the dilemma of using albumin in patients with ACLF. We are now becoming more and more wary, both with the evidence coming up as well as our own clinical experiences. How do we really put it in the recommendations? Because I didn't find it in our recommendations at any stage, especially knowing that there may be a difference in those who have a very early AKI versus those who have established AKI, and it takes take into account the volume status of the patient.
I think I can't remember if it was Professor Singh or Professor Saran who mentioned this. A comment to say judicious use or cautious use of albumin in patients who have AKI and or fluid overload state. So you kind of want to give it, but you want to be aware of it. Unlike in the past, it was just I see our residents or fellows, they just they order it and they forget to put a stop date to the albumin. And they don't look at the patient where, the oxygen level is going down. So I think a statement, yes, we can add that, in patients with AKI or fluid overload, there should be cautious use of albumin to avoid fluid overload state. But yeah, you're right, there's no study, but unfortunately, terlipressin, the third trial, is in trouble because of that problem. I think it was just too much albumin, probably in ACLF patients, has tipped them over, and now they're trying to get FDA approval. So we can definitely put a statement like that. It'll be it'll be expert opinion, but all of you are experts.
I fully agree with Dr. Mitra regarding the use of albumin. We have to be very careful. These are very sick patients. And just one question to Dr. Mitra, to you. See, the AKI criteria, we have narrowed down at 2.3, but you think this should be same for the decompensated cirrhosis and patients with ACLF?
Good question. There's no data really to compare these two. I think for now, it should be, because if you don't put it, then people will just ignore it. And in a patient with liver disease, a lot of them may not double or triple their creatinine, and people may miss it. It doesn't mean that when it goes from 0.3 and you're thinking of hepatorenal, for example, it doesn't mean to jump to terlipressin, but it means that something's happening, and be aware and start cutting down on antibiotics. Like if it's vancomycin, you get adjusted. And all of you know that if it's hepatorenal, it's just going to go. It's going to go so fast that it's going to go beyond 0.3. But I think the 0.3 should be there to bring people's awareness. There's something wrong with this kidney. Be careful if you're going to, if you're going to give certain drugs, if you're going to send them, a lot of times when we're doing quick workups, they have to get CT scan with contrast. This is an awareness, so I think it should stay there. But again, it's the treatment is you look for fluid, you look for volume depletion. The majority will be, as the study I showed from Professor Sarin's group, if it's acute decompensation, it's usually volume depletion versus the Aclf. Probably they're getting sick and they're going in the wrong direction, and it's going to be hepatorenal or ATN.
Professor Mitra, just to compliment you, to have a nephrologist is a great pleasure and privilege for us.
Chief, can I make a comment?
Where are you? I couldn't see. Okay, Samit, please.
Yeah. So, Professor Mitra, this is the first time I'm agreeing with a nephrologist, and as Shiv said, we would love to have you in our team.
Well, you know, they don't call me a nephrologist here. They call me a hepatologist who knows a little bit about the kidney, because I'm more of a hepatologist than a nephrologist.
So I think it is extremely crucial when we are writing the discussion to be clear on the need for renal replacement therapy, especially in encephalopathic patients with Aclf who have non-oliguric AKI.
Exactly. And again,
I think this is where nephrologists don't agree, and we need this in print so that we can show it to our nephrologist.
I start any patient who I give the hepatologist 24, 48 hours with their lactulose. If the patient doesn't wake up, they go on the CRT machine, and we've woken up people. You know, we put them on the machine and they just wake up. So I agree with you that there is, and I think they shouldn't be forgotten as, oh, you're Aclf, you're going to die, you're an alcoholic. A lot of them can actually get better. So yeah, we will put all that in there in the recommendations.
Lovely.
Professor Chen has a comment. Yes, Professor Chen. You need to unmute yourself. Please unmute yourself. And okay, while he unmutes, there's a good question from Professor Chandan Kedari Shetty. He has asked, if a patient of Aclf is on CRRT for more than a week and is still anuric, would you consider him for a simultaneous liver kidney transplant or only liver transplant?
Well, in the US, we have, it's policy now. We have the policy, we can't, you know, you can't go against that policy. And for now, the policy, at least in the US, is you have to be, if you just had AKI for 6 weeks, it has to be 6 weeks of AKI, which they define as a GFR of less than 25. And that can be combined with dialysis. So you can either have 3 weeks of dialysis and 3 weeks of less than GFR of 25. But that it has to be 6 weeks of dialysis. Our study that we did in our retrospective, the patients who had hepatorenal, they actually did quite well, even if they were on renal replacement therapy for over a month. The people who did ATN, and it was probably because post-op, they were just lingering for a long time. 1 week is too short of a time for a liver kidney. They'll probably recover. If they had normal, whatever normal means really in a liver patient, that's very, you know, a difficult thing to determine because a lot of them have a creatinine that doesn't reflect their renal function. But those patients, usually, you know, you need still 4 weeks of not so much dialysis, just poor renal failure, because sometimes their GFR can be low and you're not starting dialysis. So a GFR 25, but I think if, you know, the problem with the US policy is they don't incorporate, you know, if you have a history of diabetes, if you have a history of hypertension, a lot of them may have intrinsic kidney disease, but the US guidelines doesn't include any of that. It's just a cutoff of 6 weeks, GFR less than 25, you can get a kidney.
Okay.
One quick question.
I have to now just intervene, Professor Mitra, due to interest of time, but just 2 comments from my side. One is cholemic nephropathy is an important part with high bilirubin. we may discuss amongst you and the chairpersons about the high levels of bilirubin and bile acids. And second is the risk with CRRT that it can remove many of the complements and other bradykinins and kinins which decrease the blood pressure. But these are all part of the background. I have to thank you for your time, and Professor Lau, Professor Shukla, and Professor Shah, an outstanding session. Thank you very much. Please.
Thank you very much.
Sure. Yeah. So we'll coming to the next session. So the reporter from our side will be Cesar Yagi. He's from Beirut. And the first session, I invite Professor Tokart from Turkey and Dr. Kawada from the Japan. Sunam's Albert Jan is, he told that it's some emergency.
No, he's
not. Okay. Okay. So now I request Professor Tokart and Kawada to take over the session, please.
Yeah. Hi, everybody. You hear me?
Yes.
Yeah. Now our speaker, Mohammed Rela, is he online? Mohammed?
I'm here. I'm here.
Okay, perfect. Good morning, Mohammed.
Good morning.
Good afternoon to you all anyway. So I think I don't have to introduce you. You introduce yourself better than anybody else till now. So everybody knows you. Well done, Mohammed, for all your effort. And now you will gonna take the stage and we will make the comments after you.
Now, is my screen shared?
Yeah.
Okay. Now, the topic given to me is about steroids in ACLF due to alcohol and decision to transplantation. There is a little mix-up from the earlier talks. I think the organizers have to take into account, because when there was a talk on managing alcoholic hepatitis, high bilirubin and cholestasis, there was a lot of discussion on transplantation and steroids as well. So there is quite a bit of overlap, and if they can actually look at those overlaps, because the first part is very much like that. Now, what I'm going to talk about is only about steroids and indications for transplantation. So we are talking about severe alcoholic hepatitis. By definition, you have to have a MADRI discriminatory score of greater than 32 are the patients we are talking about. And obviously, the nutritional assessment comes first, and then we had discussions about the role of liver biopsy itself, and that is a separate recommendation. And if biopsy is done or not, the question is about whether you treat with steroids or not. Everybody is aware that alcoholic hepatitis is a condition which is marked by inflammatory liver injury predominantly, and therefore steroids have been a recommendation in most of the studies. They are considered to be the first-line option for patients with severe alcoholic hepatitis, provided there are no contraindications. But if you look at the patient population itself, a huge number of patients have associated contraindications, like presence of infections, GI bleed, diabetes, and there are many contraindications, and renal failure have also been quoted as a contraindication for starting steroid therapy. Now, what is the evidence for steroids? I think it's very clear that it definitely improves survival in the first 28 days survival. That is a significant improvement. There is a p-value here in this study of 0.005, but it's not been as good as this in the other studies. So this is the seminal paper in New England Journal 2015, where you see an improvement, a trend towards actually here, an improvement for 28-day mortality for steroid therapy alone. They have also compared it with, this is the Stoper study, really, steroid versus pentoxifylline or placebo in management of acute alcoholic hepatitis. There is no improvement with placebo, with pentoxifylline, whereas with steroids, there is an improvement in the 28-day mortality. But when it comes to 90-day and 1-year mortality, really,
the advantage of steroids disappears. And that is again very clearly shown in the meta-analysis of almost 11 studies done here, a prospective study done here. When it comes to assessing 28-day mortality, the treatment efficacy, steroids is performing very well. But when it comes to 6 months mortality, even 3-month mortality, the advantage of steroids disappears. So I just came up with these recommendations. Corticosteroids is the only pharmacological intervention shown to have a short-term efficacy, 28-day survival for treating severe alcoholic hepatitis unless contraindicated. And 4-week course of prednisolone, this is the recommendations, 40 milligrams per day, or methylprednisolone 32 milligrams per day is recommended, followed by discontinuation or 2 weeks of taper. The advantage of steroid treatment is not sustained in the medium and in the long term due to the increased risk of infection. So the mortality is not improved beyond really 4 weeks. I think it's important to remember that when we are considering liver transplantation for these patients. Now, the harmful effects of steroids, in fact, when it doesn't work, is continued, in fact. Now, this study again very clearly shows that even though there is an improved survival, hello, can you, even though there's an improved survival.
Excuse me, Mohammed.
Yeah.
Can you mute your microphone? Some people are talking with their microphone on. So would you please mute your microphones?
You want my yeah, okay. Yeah,
no, yours. No, it's okay now. Mohammed, you can continue. Thank you.
Thank you. So even after stopping steroids, actually the harmful effects of steroids is continued in these patients, either before transplant when they're being managed or after transplant. So it's not just the harmful effect of steroids is there during treatment with steroids and then you stop them and it becomes better is not an option. And also in the post-transplant period, patients who have been treated with steroids pre-transplant have a higher incidence. Even that the first paper which came in New England Journal on the early liver transplantation for severe alcoholic liver disease, even in that paper it was clear that both bacterial and invasive fungal infection rates were much higher in patients who have been treated pre-operatively with steroids. So it's very clear that there is an increased incidence of steroids. And one then needs to know that there is very clearly an advantage with steroids for 28 days survival. And therefore, we are recommending that we should use steroids. But when do we assess that steroids is not going to be useful for these patients? And everybody knows that the Lille score is very useful for that. And now there is very clear evidence that even on day 4, you may be able to assess who these steroids non-responders are. And therefore, there is no point in continuing steroids after the day 4 if they're not responding to steroid treatment, so that you can actually reduce exposure to steroids in these patients, either whether they are being managed with transplant or without transplant. So I came up with these recommendations. Prednisolone therapy may increase the risk of development of infection even after steroid therapy is completed, and it may be an independent risk factor for mortality. There is an increased incidence of post-transplant bacterial and invasive fungal infections in corticosteroid treated patients. And finally, corticosteroid treatment without clinical benefit beyond day 4 or 7 should be terminated. So that's about really the pre-transplant use of steroids. Now, when we come to really recommendations for liver transplantation, and when you look at the publications, I think it's very important to look at this French Belgium paper, which has been the most important paper, which made people to think about liver transplantation. And this came out in 2011. Now, it very clearly showed a survival advantage for patients with alcoholic hepatitis with transplantation. The numbers may be very small, but they used very strict criteria for transplantation. It has to be the first liver decompensation event. There has to be a supportive family. There has to be no psychiatric illnesses and family support and all of that. And when you apply these criteria for transplantation, I mean, this is not about, I mean, their criteria is not talking about the medical indications on how you would choose. They've more looked into really the psychosocial elements in selecting these patients for transplantation. and only 2.9% or only about 2% of all transplants were 2% of severe alcoholic hepatitis were considered, and they said this only constituted about 3% of the liver transplant number, because in the early days there was a huge argument about the use of cadaver liver transplant for this group of patients. So therefore they felt that the burden itself is not very high. But the criteria is only selecting out 2% of alcoholic hepatitis patients. So if you relax that criteria and include more patients, you will find that in a disease donor setting, you might inundate the waiting list with a lot of severe alcoholic liver disease patients. First, let's look at the outcome itself. I think we need to be convinced that the outcome is good, because in the early days of transplantation, we were very worried about transplanting acute on chronic liver failure. And the work done here with Acsl and others have shown that acute on chronic liver failure is no more a contraindication. In the very early days when we started, even in King's, we were very reluctant to transplant acute on chronic liver failure. That thought process has changed now. And now we know that the outcome is very important. And when you look at the three studies, the key studies, which is, they're not very old studies, but the numbers are still not very high, because probably there is a reluctance to transplant these patients or give priority for these patients. If you purely look at the outcome, I think the outcome is extremely good. The 6-month survival in these three studies is 77, 89, and 100%. Even though the numbers are small. So it's very, very clearly established fact is that these patients will do well with transplantation. But when do you transplant and how do you transplant? Now, when you look at the modality of how they have chosen the patients, been very similar to the French studies, that they have chosen patients with absence of psychiatric disorder. There has to be a first decompensation. You look, the selection criteria for all of the three studies have been very, very similar, except that the percentage of patients chosen maybe in the second study is slightly more, about 9 or 10%. But in terms of the number of patients that they've chosen who were admitted with alcoholic hepatitis is only 2% and 2.3%. So it's still, if you apply these criteria, the burden of really patients being listed for transplantation is still quite limited, unless you look at other ways, as in living donor liver transplantation, where the organ allocation is not a problem, you might be listing more patients. And also we saw earlier on, and maybe I've not included this in the recommendation, perhaps we should look at it. The recidivism rate for acute alcoholic hepatitis is not any higher than in patients transplanted for chronic liver disease. And at 1 year, this is a consortium of early patients transplanted. This is 12 centers, UNOS region. You very clearly see a 1 year use of alcohol at 10%, and at 3 years it's at 17%. I think that is a very reasonable outcome, and this is again probably because of the strict selection criteria that they have for alcoholic liver disease patients. So the recommendation I have is liver transplant is the only rescue treatment which can potentially provide long-term benefit for patients who failed medical therapy. That's something we can talk about, whether it has to be only patients who fail medical therapy, or one should be considering straightforward transplant in very, very sick patients without sepsis. And the second point is early liver transplantation has shown survival advantage if performed in a selected group of patients with acute alcoholic. Now, coming to timing of transplant, I mean, it's been written everywhere that there is a window of opportunity for patients with acute on chronic liver failure. This is not purely pertaining to patients with alcoholic liver disease. In general, acute on chronic liver failure, I think timing is important. And there is now increasing publications on using the first week as a window, really, a transplant window to assess these patients, because medical management or observing them during the first week will tell us who are probably the right patients who should be offered transplantation, or whether there is sepsis which sets in during the first week and makes patients ineligible, or if there is actually sepsis earlier on, whether this 1 week of treatment will improve their sepsis and make them better candidates for liver transplantation. So now everybody agrees about this 1 week, and this is again the Acsl group's data, where it's very clearly shown that sepsis within the first week of admission has an extremely adverse effect on patients with acute alcoholic hepatitis. Now, coming to really, we saw mainly the criteria applied by the French and the American papers talking mainly about the psychosocial selection criteria for patients with acute alcoholic hepatitis. We've really not come up with when will you transplant them. Otherwise, I think the inclusion which they've come up with, one is they have to have a Maddrey score of greater than 32 to really define them as severe acute alcoholic hepatitis. They should be non-responders to steroids, but then what happens after 28 days is something we need to, because the 6 months mortality is not improved by steroids, so they will ultimately come for transplantation. And if you have the option to transplant them early, whether you would actually consider them for immediate transplantation, the LDLT setting is something we need to discuss. They have to be first liver decompensation. And all of these are what has been discussed before, and exclusion criteria are uncontrolled sepsis. And a number of this has come up as an Acsl recommendation, has been published as for acute on chronic liver failure, but not pertaining to alcohol by itself. I just want you to consider whether we should actually incorporate the algorithm that was used for acute on chronic liver failure in general to alcohol, and then combine the two, perhaps put the Maddrey score and the Lyle score within it, and then come up with a different algorithm for acute alcoholic hepatitis. So, because in none of the previous recommendation, the AARC score comes into the picture, whether you want to, once the AARC score is more than 11, I think it's equivalent to, if I'm right, if it's equivalent to Acsl, it's equivalent to Aclf3. Whether you want to consider them for steroid treatment and then offer them treatment, or you manage them medically the first week and see how they are, and if sepsis is actually controlled, whether they should be candidates for liver transplantation. All of that, I think we need to probably discuss here and come. So I think the recommendations are simple. I think transplantation, if not clear initially, is best reassessed at the end of first week. There is evidence for that. AARC score of greater than 10 can be used as an indication for urgent listing and transplantation in this group of patients. And then eligible grade 2, I think I'm combining the Aclf recommendation here. We discussed this in October. Grade 2 Aclf with no improvement or worsening with medical management on day 7 should be counseled for liver transplantation as recommendation for transplantation. And there are contraindications, obviously, for Aclf. I mean, these recommendations we came up for Aclf, I think they hold good for alcoholic hepatitis as well, really, sepsis and multi-organ failure, and serum creatinine of greater than 4 or 300% increase from baseline, respiratory failure with PF ratio of less than 150. So all of this can also be part of the recommendation. The general recommendation for Aclf can be improved here. So I want to summarize, or I don't know if you want to discuss this individually. I just put all of them in 2 slides, or all the recommendations, and then we can have a discussion. Or do you want me to, Professor Serin, do you want me to, or Yaman, do you want me to read through the final recommendation and people can remember?
I think we can continue on reading the recommendations and we can discuss on those.
There are 10, 11. So corticosteroids, the only pharmacological intervention shown to have short-term efficacy, that is 28-day survival for treating severe alcoholic hepatitis. 4-week course of prednisolone or methylprednisolone is recommended, followed by discontinuation. The advantage of steroid therapy is not sustained in the medium and the long term due to the increased risk of infection, and steroids may increase the risk of even after discontinuation of the treatment. There is an increased risk of steroids, and it's a risk factor for mortality. There is an increased incidence of early post-transplant bacterial and fungal infections in corticosteroid patients after transplantation. Corticosteroids without clinical benefit should be discontinued either on the 4th day or the 7th day using the Lyle score. And liver transplant is the only rescue treatment which can provide long-term benefit for patients who fail medical therapy. I just want to discuss this alone, whether there is an option actually to offer transplantation for patients who have actually ACLF3, whether they should be, if living donor is an option, whether treatment with steroids should be considered at all or not. Early treatment has shown survival advantage if performed in selected group of patients. Again, timing of transplantation. Here I would like, if Professor Nadeem is still there from California, in her talk, she put MEL score capping for listing patients or offering organs for transplantation. She said that MELD of greater than 40 patients have to wait for more than 1 month to get an organ, and she felt that within 2 weeks they should be transplanted. I mean, that may be a possibility. We need a recommendation for deceased donors as well, whether certain MELD or whether there should be a cap of MELD for these patients, or an ARC score, if we are coming up with our own criteria, whether they should be considered as a priority for transplantation. And finally, I've put the ARC score of greater than 10 can be used as an indication for early transplantation and eligible. This is from the previous recommendations that we produce. Eligible grade 2 ACLF patients with no improvement or worsening of medical management should be counseled for liver transplantation. These are my recommendations. And Yaman, you can take over now.
Yeah, thank you, Mohammed. I think we can open this talk and the recommendations to discussions, because, you know, in our part of the world, we have most living donors, and these recommendations are based on the deceased donors. So my question starts with, I think a couple of attendees asked the same question. Should we add some recommendations for living donors, as you said, or should we strictly do the same as disease donors? What's your opinion?
I think we should have separate recommendation for disease donors, because the timing of transplant in disease donors is not in our hands or anybody's hands. It's in the system. If we make recommendations, at least for Asia, they can change the system to give them some priority. At the moment, the priority is only for acute liver failure, and then all chronic liver disease, including ACLF, is graded as single, because we don't even have, I think UNOS at least has MELD to prioritize patients. Yeah. In most part of the world, even MELD is not used for prioritizing patients. I think Dr. Nadeem was a co-author in that paper. That's why I wanted to know if she's got some ideas to what she would propose to UNOS as to how to prioritize these patients. Because ideally, if there is a failure of steroid treatment, if there is no improvement, they should be transplanted within 2 weeks, actually, or within 28 days. I mean, within 28 days is only when they are on steroids. I mean, there is a review that I read which came out recently where they're even questioning whether we should be actually giving these patients steroids if there is an offer of liver transplantation available. So even though it's well recognized that steroids is the best, the effect of steroids are even seen post-transplant setting, that there is an increased risk of fungal and bacterial infection. So we need to discuss that. It's not even the indication of steroids is not so sound as we think it is.
Dr. Kawada, is he there from Japan? The co-chair with Professor Toket. Is Dr. Kawada there?
I can't see him. Where is he?
No. Dr. Kawada is from Tokyo, from Japan, and one of the leaders in hepatology, but I don't see him possibly. He has a lot of good work on this. I will just first compliment Professor Rella for this outstanding talk, and I would like, Yaman, your own opinion. You are one of the finest, well-known, respected LDLT plus DDLT surgeon, and we have 2 surgeons in our team, you know, like you need to guide us. Tell us what should we do?
I totally agree with Mohammed, because if you have a living donor, I don't think we should wait for 28 days, or if we have even, we should be questioning to start the corticosteroid treatment, because when you start waiting, people will get used to the situation and the donation rates lower down, and at a point we lose the window of period that we have to transplant. most of our patients, we don't see much acute alcoholic hepatitis, but we see a lot of acute and chronic liver failures. But for acute alcoholics, after 7 days, they are losing their chance for transplantation, even on corticosteroids or without corticosteroids. I think if you have a living donor, you should continue on doing the liver transplantation. This is my idea. I think Mohammed thinks the same.
Can I put this? There are so many of you hepatologists who are here in this group. Okay, I'm going to show you. Go back and share a slide and show you the slide. Every one of you, I know would treat a steroid eligible patient with steroids, won't you? Every one of you would treat, unless there is a contraindication or obviously there is no improvement. And everybody says that there is a clear improvement at 28 days. And you want to start a treated with some patients with steroids because of 28-day benefit in their survival. And the same group of patients followed up at 6 months do not have the benefit. Shall I share this slide and just go back to that?
No, I think that is all right. We don't need to. That is stop a study. And also at 28 day, it was a modest 0.06. It was not true.
Yeah, absolutely. It's only a trend towards improvement.
Yeah, there was no clarity, and our own experience is also that after 7 days, even if there is a response, bilirubin comes down, the infections come up by week 3 and 4. So I totally agree with both the transplant experts that I think day 4 or latest day 7 should be the day to decide, number 1. Number 2, that if you can make separate recommendations for LDLT versus DDLT, it will be helpful. Number 3, the prioritization, whether you take ARC above 11 or MELD above 35 or 40, whether that helps could be added into the recommendations. 4th, those who are steroid ineligible from the beginning have sepsis, A, B, C, D, but are transplant eligible, should be listed as straight for transplant. These are 4 reasons for us. And lastly, yes, please.
Maybe there is some data that you can pull out. If a patient is steroid ineligible, and if he has a transplant, and if a patient is eligible for transplant and has eligible for steroids and has steroid treatment and then has transplant, do we have data which of this is better? I mean, patients ineligible because of various morbidity or various reasons and then has a transplant, and if that patient will survive better than an eligible steroid patient who has treatment with steroids and then has transplant, and if those patients don't do so well, we should abandon
very good question and thing. I can only give you brief data of 2012 to 14. We had 400. Yes, 1 second. We had 428 patients. Of them, 78% were steroid ineligible. Only 22%, 1 in 5 was steroid eligible. This is published. Now, another study.
Groups, who's done better?
We don't have the data who did better. We have no. The question you raised is very pertinent. We don't have data, and in fact, I had requested Yaman to take a lead on the Acsl work, and you are ILT as president. I think there is a need to develop these for futuristic prospective data if we can. But right now there is none. But if we have an ARC, Ashok, we can take out that data. Those who are eligible and transplanted, those who are ineligible and transplanted, is there any difference? But in the interest of time, I would like to ask our chair to finally conclude and then way forward. Yaman.
So sorry to say one more request, sir. The transplant data in our court is very less. So I request Professor Tokar and Professor Rella to take a lead as far as this Acsl SLF is concerned. The data of transplant is very much limited with us.
Okay.
All right.
Yeah, I think that we need a study, but in our country, at least, we don't see much acute alcoholic hepatitis. So I don't know how many people we can gather, but if it's study that everybody get inside with a puzzle and ILTS, then we can really make a number that we can answer Mohammed's question.
All right. Many thanks to both of you. And,
okay. May I speak?
Thank you. Yes.
Yeah. Thank you very much, Mohammed, for your excellent speech. Hello, Yaman. Actually, I would like to point out that timing for liver transplantation for those patients, especially for the severe alcoholic hepatitis, is very important because sometimes if we pass a golden window, then we cannot do anything. That's why living donor transplantation is very important for those cases. And I think we have to separate recommendation for the living donor transplantation.
Yes. I think Dr. Rella had already said this, that the APSL guideline of 2019, some of that, we should need to modify them and add algorithm for alcohol. I think the revised guidelines and the discussion points will be sent for your consideration and approval, and then we go ahead in that.
Yeah.
Okay, many thanks.
Thank you.
Sure.
Thank you.
So thanks the speaker as well as the panelists for the excellent discussion. So now we are moving to the next session. So now I request KW Wang. I think Professor Wang is not visible. If you are there, sir, please join. And along with this, Professor Tan. So now the session is handed over to the chairpersons. Professor Tan, please.
Thank you, Professor Sarin, for inviting me. The next topic follow very nicely after Professor Rella's talk about liver transplant in alcoholic hepatitis is by Professor Lee from Singapore and NUS. Address steroid resistance. Only about 40% of patients respond to steroid, and respond prediction, and what to do if they are not responding to steroid and there is no liver transplant. Professor Lee, over to you.
Thank you. Good afternoon and good morning, I think, for our colleagues in America. Professor Sarin, Professor Chaudhary, Professor Tan, and fellow members of the AARC. I'm very honored to be invited to discuss the subject of steroid-resistant alcoholic hepatitis, response prediction, and the therapy for non-responders. I'm keenly aware that we are more than an hour behind time, and many of the the materials that I'm going to cover has some overlap with the previous speakers, so I will skip over a few. And I have no conflict of interest for this subject. Okay, good. All right. I think everyone is familiar with this definition for severe alcoholic hepatitis, and also the workflow for Lille score that is used to assess the prognosis and identifying non-responders and guide treatment for steroids after 7 days. Besides, all of you are also very familiar that there are many prognostic scoring systems that's been developed and validated for alcoholic hepatitis. And there is also the Glasgow alcoholic hepatitis score that widely used in UK, the EPIC score, and the alcohol hepatitis histological score if liver biopsy is available. Unlike the rest that are actually assessed pre-therapy, the Lille score specifically is designed to be applied 7 days after commencement of corticosteroid therapy and is highly predictive of death at 6 months and futility of further therapy if the patient has a score of more than 0.45, as mentioned earlier. The AARC is also superior to all other models at this time point. The alcoholic hepatitis histologic score gives pathologists a more objective system for reporting and is complementary to the other non-invasive scoring systems. The ABIC and MELT score being shown here to improve survival prediction. And here is something that was also briefly mentioned, and I think it's important. These are the two new methods that are published by our colleagues from ILBS that predicts non-response to steroids before actually starting treatment. This first one is based on histologic activity score on the baseline liver biopsy. As you can see, in both the derivation and validation cohort, the score actually the score actually derived using the balloon degeneration and mammillary dank bodies can actually help to identify non-response to corticosteroids and help to stratify patients prior to the introduction of therapy. The other method is based on flow cytometry evaluation of microvesicles in the peripheral blood and blood sampled from hepatic veins. The authors found that if the hemopoietic stem cells bearing the surface marker CD34 and hepatocytes bearing the ASGPR markers express high microvesicles, the risk of non-response to corticosteroid therapy is higher and has a very impressive AUROC of 0.94. Now, this is a European study, specifically from Belgium, which looks at a group of biopsy-proven alcoholic hepatitis patients. 48% of these patients already had Aclf based on the Eclf criteria at the time of diagnosis. And in the process of follow-up, a further 17.5% will develop Aclf shortly after. So there is a significant overlap of alcoholic hepatitis patients who did then develop Aclf. And this study, which also showed that this study was after they developed Aclf, when they applied the canonic criteria and the grading system, the prognosis actually mirrors the organ failure predictions. Furthermore, the authors are able to demonstrate that with increasing number of organs that fail, the patients become less responsive to corticosteroid therapy. I would like to draw the parallel to our ARC database. Alcohol has now emerged as the most common etiology for acute insult, up to 49%, as well as for underlying chronic liver disease. So we can expect that many of these patients would actually contain alcoholic hepatitis patients, although admittedly we don't biopsy as often. And therefore, I think the application of ARC score for prognosticating these patients is very valid. And obviously, we have also shown in the past that there is a significant advantage, at least for patients from the Asian cohorts. And with that, I'll go over skip over to therapy for severe alcoholic hepatitis. And I think everyone is familiar with this workflow. As nutrition will be covered by the next speaker, I will just skip over that. And there's also no question that stopping of alcohol as part of the initial treatment is a no-brainer. Now, and liver transplantation has been very elegantly covered by Professor Rella. So I'm going to talk only about the pharmacological options. Now, everyone believes that prednisolone as the gold standard therapy for alcoholic hepatitis, of which I'm kind of a non-believer. There has been many trials, they are done, some with positive results, some with negative results. And this is one of the latest RCTs on New England Journal on this subject, where the STOP AH trial, which was also mentioned briefly earlier. In this study, they were able to demonstrate that there is absolutely no benefit for having pentoxifylline. And as for prednisolone, you'll see that at 28 days, there is a trend towards a survival benefit, but it is really relatively small, and actually the confidence interval crossover 1. This is, if one study is not to be believed, this is a Cochrane review looking at 15 better quality clinical trials on this subject. And surprisingly, and I think, or maybe not, that in fact, there is really not much advantage of applying glucocorticoid compared to placebos in patients with alcoholic hepatitis. Although I think most of us will tend to attribute this to suboptimal patient selection. And this is also very briefly discussed earlier about combination therapy on another New England Journal publication where glucocorticoids was combined with N-acetylcysteine. And then this definitely has reached survival benefit at 1 month, but it should be noted that the primary outcome for this study is meant to be 6 months. So technically speaking, it is also a negative study, but there is an apparent initial advantage for the first month. And that could be related to the fact that hepatorenal syndrome is actually less frequent in the group with N-acetylcysteine. And I think as many of the other members has mentioned earlier, this is one study that has not yet been repeated and shown to be consistent. And GCSF has came out a few times as well. This study by another colleague of ours, Professor Singh, has shown survival benefits of applying GCSF 5 microgram per kg for 5 days on top of the standard medical therapy. Obviously, a very impressive result, although the number of patients is relatively small, 23 per arm. And the same researchers actually repeated the study a few years later with the addition of additional group where GCSF was combined with N-acetylcysteine. And as Professor Singh mentioned just now, the addition of N-acetylcysteine did not derive any benefit for this group. And but I think one can still see a separation between the those patients who receive GCSF and the control patients. This is a very recent meta-analysis looking at 7 trials on GCSF for alcoholic hepatitis. If you look at graph, take the forest plot at A, one can see that the net results of the pool estimates is showing a survival advantage as it's for in the favoring GCSF. However, the authors has also do another analysis looking at geographical sites. The 5 Asian studies show strongly survival advantage for the GCSF group, whereas the 2 European studies actually showed no advantage. In fact, with a trend towards favoring controls. So I think there is some questions still remaining in regards to what application of this therapy. So this is a summary. At present, the recommended treatment for alcoholic hepatitis is still corticosteroids. And if it fails, we would then have to look at additional measures. Of course, liver transplantation is the one that is definitive in terms of survival benefits beyond 1 year. And for those that require further studies, I think the role of N-acetylcysteine has yet to be defined. GCSF appears to have promising results amongst Asians, but not so clear about the Europeans. And then fecal microbiota transplantation, which is a very interesting subject. This slide very briefly summarizes the role of gut-liver axis in the pathogenesis of alcoholic hepatitis, for which FMT is thought to play a role in the inflammatory arm of the pathogenesis. And on that basis, many studies has been done. Many of them are randomized controlled studies or open label studies. This is summarized here. The unfortunate part is that all these studies are very heterogeneous, with different regimen of FMTs being used, different inclusion criteria, different outcome measurements, but mostly they seem to report positive results. Okay, and then there are other candidates for steroid-resistant patients. The ELAD, rifaximin, I think antibiotics, probiotics, and they are all currently under trial. I think verdict is not out yet. And for the rest, there are some smaller studies that actually show no survival benefit and should be dropped. I think this is already mentioned, beta blockers associated with acute kidney injury. So we may want to think about instead for patients who has actually reached severe acute hepatitis to withdraw certain medications. I'm aware of the data on carvedilol and Aclf, but those are not specific to alcohol. I have taken the liberty of looking through our 2019 Aclf guideline, and many of on the lines that are recommendations that are related to alcohol. I think most of it is still very relevant, and I don't think there's need recommendation for changes. These are about liver transplantation, which again is not, it's probably still stood, but we can be improved as suggested by the earlier speaker. And finally, additional recommendations, which I think need some debate. Clearly, this belongs to the ground where the data is far from complete and needs actually further study. I believe there's only a single plasma exchange being done on alcoholic hepatitis, which is a very low quality study with only 30-something patients retrospectively measured, and the outcome is actually didn't show any advantage of plasma exchange. And I think we as a group can do better on that. So with that, I thank you for your kind attention, and I think over to you, Professor Tan.
Hi, thank you, Professor Lee. Thank you for an excellent overview. Can I see your slide on the recommendation, the one before you talk about FMT? You were doing some recommendation.
Yes. Allow me to share slide again. Sorry about that.
Dr. Tan, I have shared the slides here.
Do you intend to use that as recommendations?
Okay.
Here we can take the opinion from other panelists also, or anyone in the extreme panel also who can. If there are any comments, Dr. Tan, you can go through the consensus and give your inputs.
Right. We always have been using the Lille score of 0.45. I just wonder, what about the another study, a meta-analysis published in GAT 2011? They look at 5 randomized clinical trials. Actually, 2 cutoffs. Plus, we are talking about steroid resistant, and there is no option for liver transplant in this section. So there's a higher cutoff of 0.56. When it's higher than that, it's actually a good indication to stop steroid because it causes more harm. But if it's slightly lower than that, but higher than 0.45, in the setting of there is no option for liver transplant, maybe we need to clarify.
Yeah, Dr. Tan, sorry to interrupt in between. I think we can go by consensus wise so that we can save some time. So Dr. Tan and as well as Professor Lee, you can see these past 3 statements. I think it is getting repeated also. So we may take these into the previous sections, not here, I think. Because alcohol as the commonest etiology, it will come in the first sessions, I think. Then already we discussed about the steroids. And regarding biopsy also we have discussed in previous session. So here we need debate on steroid eligible patients. It is okay. So this is very much you have told me about the recidivism which is addressed that way. And okay. So and this much are the consensus statements for this session. So now I request the next session. Thank you, Professor Lee and Dr. Tan, for the nice sessions. We'll move to the next session, which is on. So here I invite Professor Sombat, Professor Jiddu Seja, and Professor Tauchen. Yeah. So now the session is to be handed over by you. So please.
Hi, thank you. Thank you, Professor Sarin, for inviting me to join this consensus meeting. I would like to introduce the next speaker, which is Professor Sekham Abbas. Professor Abbas is a president of Pakistan Society Study of the Liver Diseases. And he is also a professor and head of Department of Hepatogastroenterology of Science University, Pakistan. So please welcome Professor Abbas for the next topic is nutrition, goal, prescription, and implication on outcome. Professor, please.
Thank you very much. Azumi, could you please share your screen? I had sent okay. I am thankful to the organizers for inviting me to speak on this important topic. Patients with alcohol-associated liver disease and Aclf require supportive care for nutrition and alcohol abstinence. Many patients with severe alcoholic hepatitis are malnourished and require supportive care. Patients with severe alcohol abuse and severe alcoholic hepatitis have a higher resting energy expenditure than healthy controls. 3 months of abstinence from alcohol could represent the minimum time necessary to obtain a normalization of metabolic variables. Sarcopenia is an important issue in these patients, and patients with sarcopenia have more severe alcoholic hepatitis, longer hospital stay, higher chances of developing pneumonia, sepsis, and hepatic encephalopathy. Low protein intake is associated with worsening hepatic encephalopathy, while the high protein intake correlates with improvement in hepatic encephalopathy in these patients. So, protein restriction should be avoided. A meta-analysis of nutritional supplements for the management of hospitalized alcohol hepatitis patient concluded that nutritional supplementation provides no mortality benefit in patients with ALD. However, hepatic encephalopathy was significantly improved, ameliorated, so nutritional supplements should be encouraged. These patients should receive 1.2 to 1.5 gram of protein per kilogram body weight per day and 35 to 40 kcal per kilogram to improve nitrogen balance. They may have poor intake if patients cannot maintain adequate oral intake, and enteral feeding is generally preferred over the intravenous nutrition. They may be selective individual micronutrient deficiencies in these patients. So the goal of the nutritional support is to provide adequate calories and proteins, provide vitamins including A, D, E, thiamine, niacin, folate, and pyridoxine, and trace elements including zinc, phosphate, magnesium, and selenium. Zinc deficiency is important and it may increase gut permeability, ultimately leading to endotoxemia and systemic inflammation and progressive liver disease. The ingestion of late evening snacks can improve the nutritional metabolism in patients with Aclf. Nutritional support in Aclf patients can improve the outcome and gastrointestinal barrier function and leaky gut syndrome in these patients and improve the survival. Branch chain amino acids role is unclear, but they may improve hepatic encephalopathy. So these branch chain amino acids may be helpful. Late evening snacks with branch chain amino acids improve the Fisher ratio in patients with liver cirrhosis. So these branch chain amino acids should be encouraged. Efficacy of nutritional therapy with and without steroids in severe alcoholic hepatitis has been evaluated in multiple clinical trials. Most trials have demonstrated improvement in liver function and histology, but without a consistent reduction in mortality. One study found no difference in mortality in 75 patients with severe alcoholic hepatitis who are randomized to prednisolone or enteral nutrition alone for 28 days. In another randomized trial of patients with severe alcoholic hepatitis who are treated with steroids, intensive enteral nutrition did not increase survival compared to the conventional nutrition. However, low daily energy intake was associated with greater mortality, so adequate nutritional intake should be the main goal for treatment. Proper hydration is also important, as some of these patients prior to presentation may be dehydrated and having pre-renal azotemia, which should be corrected. Overhydration should be avoided since it may increase the degree of ascites and lower the plasma sodium concentration. Alcohol abstinence is another important issue in these patients. All patients with alcoholic hepatitis should abstain from alcohol, since many of these patients have a long history of excessive alcohol intake. They are at risk of alcohol withdrawal symptoms. The prevention and treatment of alcohol withdrawal is an important part of patients' management, and pharmacotherapy may also aid in the abstinence. Integrated care to treat AUD and ALD should be encouraged. Abstinence promoting behavior and pharmacotherapies are part of therapeutic foundation for alcohol use disorders and alcohol associated liver disease. There may be shortcomings in the training and experience and awareness of hepatologists on AUD treatment. So there is need for educating us on this aspect also. It is also to be known that there might be a slow resolution of or normalization of LFTs, a marked elevation in serum bilirubin and aminotransferases may be seen for many months following an episode of alcoholic hepatitis, even in patients who abstain from alcohol. Thus, the presence of persistently abnormal serum aminotransferases does not necessarily indicate that patient is still taking alcohol. So, in a series of about 87 patients with alcoholic hepatitis who survived their index hospitalization, the estimated 5-year survival rate was overall 32% survival. In abstinence, in patients who observed abstinence, the survival was 75% as compared to continued drinkers, in which case it was 21%. So for survival, it is very important for better outcome that one should refrain from taking alcohol, and there is a dose relationship between alcohol consumption and long-term mortality after initiation of corticosteroid treatment. Patients who respond to the corticosteroid treatment and do not relapse, they have the minimum risk of death. The patients who do not respond to the steroid therapy, but they keep on observing alcohol abstinence, they remain at a substantial risk of relapse, and there is very high risk of relapse. If there is alcohol relapse, and if there is if there was poor response to the steroids before, the risk of death is substantially increased if there is alcohol relapse and the patient did not respond to steroids initially. So there is need for the complete abstinence which should be advised to these patients. Even if the patient abstain from alcohol, they remain at risk for progressive liver disorders. So enrollment in the alcohol rehabilitation program within 30 days of discharge can improve outcome by reducing readmission and death in patients with alcoholic hepatitis. It is important that we should know about the diagnosis of alcohol use disorders and NIAAA. There is a simple question, how many times in the past year have you had 5 or more drinks in a day? If the answer is yes, then these patients should be administered audit tool, which includes 10 questions on consumption, dependence symptoms, and alcohol-associated problems. There is another tool which is concentrating on consumption only. This is Audit C tool. How often do you have a drink containing alcohol? How many drinks containing alcohol do you have on a typical day? When you are drinking, how often do you have 6 or more drinks on one occasion? Refer to the treatment should be offered to patients engaged in hazardous drinking. Integrated AUT treatment providers alongside medical providers in the clinic produces better abstinence rates than usual care. So the treatment of AUT include counseling sessions. Within counseling sessions, various modality treatment are available that target different mechanisms of behavior change. These include cognitive behavior therapy, motivational interviewing, motivational enhancement therapy, cognitive contingency management, 12-step facilitation, network therapy, and counseling for family counseling. A systematic review of 13 studies concluded that integrated therapy with cognitive behavior therapy and comprehensive Medicare can reduce the risk of recidivism. However, included in this systematic review, there were some randomized trials also. 5 randomized trials were reported, 3 of which enrolled patients with alcohol-associated cirrhosis exclusively, and only 1 of them showed statistically significant benefit with the integrated intervention combining AUT treatment with Medicare. Still, the integrated multidisciplinary care remains the best option for the management of advanced ALT and AUD. To prevent relapse, there are medications also, and these medications include naltrexone, acamprosate, gabapentin, baclofen, and topiramate. Acamprosate may be considered in patients with AUD and alcoholic hepatitis because drug is excreted unchanged by the kidney and it is not metabolized by the liver. Acamprosate may be started only once the abstinence is achieved. This mechanism of action is related to ameliorating some symptoms associated with abstinence, and therefore patients may notice less of a desire to return to drinking in that circumstances. Baclofen is another drug that may be used in the setting of alcohol liver disease. 2 placebo-controlled diets favor that baclofen may be an effective treatment option, while a third double-blind placebo-controlled trial concluded that baclofen did not appear to be superior to placebo. So concluding my talk, there are few recommendations that patients with ACLF require supportive care for nutrition and alcohol abstinence. Nutrition therapy improves survival, infection rate, liver function, and resolution of encephalopathy. Patients should receive 1.5 gram of protein per kilogram per day and 35 to 40 kcal per kg to improve nutrition balance. Enteral therapy is preferred over the parenteral therapy when patient cannot meet their caloric requirement through the oral intake. The nutritional supplement should include adequate vitamins and minerals. Protein intake should not be restricted. The use of branch-chain amino acids and late evening supplements may be helpful. All patients with the Aclf should observe complete abstinence from alcohol. Integrated care is needed to treat AUD with ALT dual pathology. Pharmacologic therapy with acamprosate and baclofen may aid with abstinence. Modalities of treatment that target different mechanisms of counseling and behavior change to promote abstinence should be tried. Thank you very much.
Persons to please.
Yeah. No, Dr. Abbas, I think that was a wonderful, presentation covering almost all the aspects. I just have 2 points to make before other chairpersons, take over. The first point is, I think alcohol Aclf patients obviously would be very, very sick. Majority of them may be in the ICU. So we only can presume that, and we know that the presence of malnutrition and sarcopenia would be kind of, universal in them. Because we know they're very, decompensated cirrhotic data, we know Aclf data also. So I think we have not touched anything about the, assessment of malnutrition in them. Do we need to add something regarding that, which would be a difficult, option in doing that, because they may not be fit for BIA, DEXA, BMI would not be a good option. They may not be fit for CT or MRI. So I think a little bit on that, I thought if the assessment of malnutrition and sarcopenia in Aclf, I thought could be one. And again, we have been discussing about steroids and liver transplantation in these patients. Does the presence of malnutrition and sarcopenia, we know, does affect the outcome of liver transplantation, but it is not a contraindication for transplantation. So something on that, the relationship between malnutrition, sarcopenia, and the outcome of liver transplantation, I thought would be a very, very pertinent issue. And the last comment is about the, the drugs which you said to be used for abstinence, for example, baclofen or acamprosate. Whatever data is available, they are all in alcoholic cirrhotic, and that also very few small studies. There is no data of the use of baclofen, for example, in alcohol Aclf. So I think we probably need to generate that data also, and our recommendations and statements should be based on the available data. Thank you.
Yes, nice comments. I fully agree with you regarding, I think these two things, one is the nutritional aspect and second is the psychosocial aspect. These are the important issues that are more pertinent to alcohol related liver disease as far as we are considering liver transplant also. So we know the outcome is poor in patients who have got the sarcopenia, for example. And this is a universal truth for all the patients who undergo liver transplant. As you have very well said, that this is very difficult to assess in the patients who are in the ICU. There are simple tests also, but this is known that this is a very recent paper that has been published about sarcopenia in severe alcoholic hepatitis that I have given the reference, a very new paper. So this is a problem, and this we should keep this in our mind that these are nutritionally depleted patients, and we have to look after properly nutritional aspects of these patients as well. And then is another problem is that if you transplant these patients and they go back to alcohol relapse, so proper psychological assessment by the team is also important, because you have to decide all these things in the first week or so. So this is a teamwork when you're putting these patients on the transplant list. these two aspects should also be taken into account for choosing these. If the patient goes back to recidivism after transplant, then in our setting where it is only liver transplant, then the sacrifice made by the donor would be no more there, and there will be no use of getting these patients transplanted.
Dr. Duseja, I have
yeah, please go on, please.
Sorry, can I take?
Yeah, go on, please.
Professor Abbas, thank you for the wonderful talk. I just wanted your comment on a study which has been published from our center on omega-3 fatty acid lipid emulsions in patients with acute and chronic liver failure. This was not in particularly in context of alcoholic hepatitis related ACLF, but therein it was shown that the reduction in inflammation and critically ill patients were taken in the study. So your comment, or if you would like to include that in the consensus somewhere?
Yes, I think this study should also be included, because when I was preparing this presentation few days back, I missed some of these studies because I could not put other areas, other etiologies of ACLF in the literature search. So I think that is a good study and should also be included in this.
May I?
Yes.
Can I have a? Yeah.
Please,
Okay.
please.
Thank you. Thank you very much for the excellent presentation. I have just would like to raise two suggestions. The first one is I noticed the exact calorie of daily diet has been provided. However, the distribution of daily diet, such as the proportion of carbohydrates, protein, or fat, has not been absent. The previous study have shown that the ACF patients with high fat diet would should a much higher mortality than those with relatively less fat diet. So I just suggest the composition of daily diet needs to be provided in the recommendation. The second point is I would also notice a certain proportion of patients with ACF shows very sick, such as losing appetite or vomit or cannot even eat. So the enteral nutrition support may be not work very well in the ACF patients. So I would like to suggest some recommendations of application of enteral nutrition in alcohol liver disease associated ACF.
Yes, your points are well taken. If you see the recommendations that have been projected, and in the presentation, I also mentioned that these patients may not be taking adequate calories, and we should encourage enteral nutrition in these patients. If the enteral nutrition is not possible for one reason or so, then parenteral nutrition may be as a supplement may be recommended. But we should not give all the things parenterally, because enteral nutrition is very important. It prevents the leaky gut syndrome and prevents the increasing permeability. So we should encourage more enteral nutrition in all the ACLF patients rather than parenteral nutrition. But you are right about your comment about the fatty acids and the composition of the calories that we take, about that we have to. I have mentioned that, but I have not subdivided whether this should be carbohydrate or fat. So this is a good point. I think we should look into that aspect and incorporate in our recommendations.
Okay, thank you.
Professor Abbas, I'm Dr. Sambat. May I suggest you to add some recommendation? I totally agree with your recommendation. But if you can add some point of the risk assessment of malnutrition in patient with alcoholic liver disease is recommended, and you can add some to that practical for general practitioners such as body weight, BMI, or anthropometry. So if you can add that one, it may be more completed.
Actually, proper assessment in ACLF sighting when the patient is in the ICU, when you want to assess the nutritional status, that becomes very difficult because there are many of these tests, they are CT scan based or they are based on the active participation. Like you have if you want to check the hand grip or other things that is not possible in the patient who is in encephalopathy. So this can only be assessed later on when the patient recovers. So this becomes very difficult in ACLF patient who are in hepatic encephalopathy and do the CT scan or MRI or other things to assess the sarcopenia and other nutritional status.
Currently, there is a lot of use of indirect calorimetry. We can put that into the background, which can be used in critical care settings. Not that as a recommendation, but can be used for assessment. And just one more point I have is about the saying it is a supplement. We should say it is a therapy. Somewhere we must say that nutrition is not supplement, it is a therapy. And lastly, as Dr. Rakhi said, this paper came in Liver International a few days ago about the omega-3 as a immune modulator, not merely a therapy. So nutrition can be an immune modulator as well as a therapy. I think you may consider along with the chairs these points. And Ashok has something to ask.
So in my presentation, I have mentioned that people have compared nutritional therapy in a randomized way with a steroid therapy, and they have shown the equal results. So nutrition may be an effective therapy into these patients as well. So this in my description of the recommendation, I have mentioned that.
Yes, sir. Thanks, sir. So I also suggested two things. One is nutrition therapy, as rightly said. Then we should mention only calorie and proteins. And we should add also about the fat content because now fat is coming as an oral supplement. Also, particularly saturated fatty acid is good for alcoholic hepatitis. So this, because already published data is there, we can think of that way. And then we should ensure the nutritional supplement if oral intake is poor by enzyme feeding or anything as a therapy or a nutritional support. So these 2 or 3 points from my side, and I think rest of things are okay. So thanks, Professor Jaigam, for your excellent talk and nice discussion. So we'll proceed to the next session. So for the next session, a reporter is Professor Mohammad Fazal Karim, and the next session chairperson being Professor Anand Seshta. He texted that he may not be there, but it is okay. Then we can see him. Dr. Mohammad Abel Livasani, Dr. Neeraj Saraf. So now the session is transferred to our chairpersons. Please take over. Thank you.
Thank you. Thank you, Doctor.
Yeah.
Yes.
Yeah, please go ahead. Sorry.
Okay, thank you, Dr. Professor Sareen, Professor Ashok for their kind invitation. And now we have to introduce Dr. Chai Zalong, founder, chair of Chinese Portal Hypertension Alliance, Chief of Institute of Portal Hypertension, the first hospital of Lazio University, China. And his topic will be about artificial intelligence and management decision.
Okay.
Please, Doctor.
Can you see the slides?
Yes.
Okay, thank you. Dear colleagues and friends, dear Dr. Sareen and Dr. Ashok, my name is Xiaolong Qi from the First Hospital of Lanzhou University. And I would like to share this topic, the artificial intelligence in the ALD and Aclf. So many speakers has mentioned the natural history of the ALD and Aclf. So I just skip these slides. I think the current challenges in the management of this disease, including the following part. The first is the accurate assessment of prevalence of ALD, particularly those at the early stage, and non-invasive assessment of disease, like including the fibrosis, cirrhosis, and portal hypertension. And also the unreading the pathophysiology mechanisms, and also optimization of organ allocations. Many speakers has mentioned about the liver transplantations. So could AI, the artificial intelligence, do any favor in these areas? Many of we divide the artificial the intelligence refer to the ability of a computer to perform a task associated with intelligent beings. So AI is just a very, very general concept. And most of us use it start from 1950 years and start from 1980s with another technique called the machine learning, which is computer-based method for analyzing the data and learning the descriptive for predictive models. And very recently, in the last decades, we developed deep learning, which is the specific technology of machine learning based on the complex architectures of artificial neural networks. So various types of AI could be applied in the liver disease, and many publications has published before, and really recommend a very the comprehensive review in the hepatology last year. They summarized this area, and actually various sources of data that could be used and could be the raw data for the AI analysis, including the routine clinical and laboratory data. I think the most of the data, we all of us have these data, and also the radiologist-based image data, including the CT, MRI, or some ultrasound imaging, and also the pathology-based imaging recognition data. And very recently, we use a multi-omics like the metabolics, or the radiomics, and genomics, etc. And for the technology, we use a natural language post-processing for some electronic health records. So even just a patient, some data sheet, some patient records could be used as the raw data for the AI analysis. And some real-time valve monitoring. It's a very the equipment can be applied in this area. So I would like to expand a little bit about how to use this the various data for the AI analysis. The first is the routine clinical lab data. And last year, a paper published in Gastroenterology. Okay, they use the patient's the clinical and the biomarker serum data to predict that the UGIB is upper gastrointestinal bleeding, and they do some clinical routine assessments and do some laboratory tests and use a machine learning method. Do the algorithms can predict the patient who can be discharged or who can be admitted to the hospital. And this is the very interesting data, including a multi-center around 800 patients in this study. But the problem is they do the up GI bleeding, but not focus on the cirrhosis bleeding. So from our chest group, very recently we published a paper in the Lancet Regional Health. We developed the detectable strain. It's a special novel technique based on the anoscopy for the detect the varices bleeding in compensating cirrhosis. And in this work, we have some the anoscopic images, which was detected by the specialized the anoscopy called the magnetic controlled capsule anoscopy, which we can compare with the regular UGD anoscopy. And currently, we do AI to detect the risk of varices bleeding based on this the anoscopy image data. And also, very years before, another paper in Journal Health, they use some patient routine clinical data. They use ANN, which is also the specific technology of the deep learning to optimize the prognosis of liver transplantation. They developed an algorithm they call the CCR models, which show the best performance compared to the other score, like a soft or the mild or demild, some the other the routine scores before. And for the imaging data, I think this is a very helpful the resources, and we can use this data to a lot of things. And in the first trial in our CHEST group, we use the CT imaging of cirrhosis patients, do some 3D construction and do the commutative hemodynamics analysis. And with HVPG as a reference standard, we develop a model to be used. We call the 2 HVPG for this analysis. And our next trial in 2017, we use based on the routine CT imaging. We including 2 ROI region of interest. One is the liver, and another is the spleen. And we extract the text feature and non-text feature. It's more than 1,000 features just from the routine CT images, and we do some analysis. And a total of 385 patients that were included in this study, and we developed a radial mix model. We call the RHVPG, radial mix HVPG, for predicting the clinical significant portal hypertension, which was defined as the HVPG more than 10. Okay, and this the paper in Eval Medicine, just the start. And based on this technique, we try to translate this technique into a product. We call the CHEST intelligent workstation, which just a post-processing workstation, which can be used to analyze the CT image, no matter it's a GE, Philips, or Siemens, or some the versus the brand. It doesn't matter. We just use the CT raw data in the Decomp format for the post-analysis the processing. And you can see in our prototype the workstation, we have a tool which was established for the port pressure measurement, and then we can give the reports to the patient based on the radial mix models to show if the patient is a CSPH or not, based on our previous cohort. So we are trying to get the approval of the Chinese FDA, and then we can use this technique in the routine practice in China. And very recently, we published a paper in the Journal of Gastrohepatology, and we still use that CT imaging data based on the liver and spleen, but we predict the endoscopy results, which is GGV and HRV, high risk cirrhosis. And this is a multi-center study, and we show we can use the CT imaging to predict if the patient has a cirrhosis or not, or if the patient has a high risk cirrhosis or the low risk cirrhosis. Okay, so a total of the 133 patients compensating cirrhosis in 20 and another 30 patients in validation cohort. And last year, we also have the study we call CHEST 1802. We use a deep CNN, which is one of the technique of the machine learning curvature neural network to aid detection of portal hypertension in patients with cirrhosis. This is an international collaboration. We collaborate with Dr. Necati Omachi from Turkey for this international study. And we do use CNN technology for the CT imaging and the MRI imaging. It's based on our 2 previous cohorts. And we develop a CT based CNN model and MRI CNN model. You can see even in the validation data set, the results is very good, more than 0.9. So we are trying to translate this technique into our product, which also could be potentially could be approved by the Chinese FDA to apply in the routine practice. And omics data, I think this paper has been mentioned by the Bajaj in this morning, and we use some metabolic analysis data to predict the survival of AClf and AD. And they also show some the phenols, the post-wave pathways, which could be also analyzed by the the artificial intelligence. And also omics, the paper which was included the patient with acute decompensation as a patient with Aclf and something else, the controls, and they do the follow-up, and they use some the AI technology to emphasize this database to predict as a biomarkers and the therapeutics matters for the for this patient. And lastly, I would like to summarize. We also have a ongoing consensus, which was led by Dr. Ring, to summarize some AI technology in this specialized the topic in portal hypertension. And last but not least, I would like to summarize my recommendations in this topic. The first is AI is promising to improve the management of liver disease, including ARD. Although we have a very limited data, which was only specifically for the ARD, but we have versus data focused on the liver disease, some the advanced chronic liver disease. So I give the A1 recommendations. And AI has shown advantages over conventional method in many aspects of the ARD management, including the identification of a CSPH, predicting HR high risk versus, or the UpGI, the bleeding. More data needed from ARD, these specific populations. I give the B1. And the third recommendation is the application of AI could improve the allocation of a liver transplantation with better prognosis. I think only one paper published currently, so I give the B2. And lastly, the omics data followed by the AI analysis is a promising way to unravel mechanisms of ARD or ARD, ACRF. It's a B1. I would like to acknowledge the team members from CHEST group, especially for the Dr. Qin Xie's group and Dr. Zhu Juncao from Shanghai Regional Hospital. Thank you very much.
Thanks, Professor Jalan. So now I request our esteemed panelists and chairpersons, please give their inputs.
Yeah, thank you, Professor, for a wonderful talk on artificial intelligence in various aspects of liver disease, and especially for acute and chronic liver failure. So I think the recommendations which have been made look reasonable, and I think allocation of liver transplant.
Sorry to interrupt, yeah. Yeah, question is, we'll go to the recommendation one by one. The first recommendation, Professor Jalan, it can be A1. AI as a promising tool for improving management of liver disease.
No.
Yes, ma'am.
I think it's still very premature to label it as E1.
Yeah, A is the best label. So either B1 or B2, maybe we can get this input from our panelists.
Maybe also we need some studies to suggest, because alcoholic liver disease, the data is limited.
Yes,
so we can put it as a future perspective. Yes, this is an evolving area, rather than giving any recommendation to this.
So, yes, ma'am, you want to assess for all the suggestions, yeah, for the any particular? So we should not recommend them anything.
So
as of now, it's very premature to make recommendations, I guess.
Go ahead, please.
Yeah, I think it's still very premature to make any recommendations given the paucity of data. Okay. So I think it just can be labeled as a future prospect.
Okay. So all the recommendations will go as a future prospect without having any evidence and recommendations.
True.
Okay. Thanks. Okay. Then. So if there is no input from any speakers or panelists, or they don't have any questions also. So thanks, Professor Jayalang, for an excellent talk, and all esteemed chairpersons. So we'll move to the next session. So for the next session, we invite our panelist, Professor Madhuri Nirela from Colombo, Professor P.N. Rao from Hyderabad, India, and Professor Chen from Kuising. So now the session is to be managed by you.
Thank you.
Professor
Thank
Madhuri.
you very much, Professor Sareen and Dr. Ashok, for this exciting session. Since morning, we've been sitting and then talking about alcohol and the ACLF. And a lot of talks have been there on the pathogenesis, and a lot of discussions have happened on steroids and the transplant. Now, this session says that a way forward in the scope of ALD and then ACLF. And for this session, a very interesting topic, perhaps Ashok has kept it at the last, is going to be very interesting. The severe alcoholic hepatitis versus severe alcoholic hepatitis with ACLF. And for this, along with my co-chairs, Dr. Nirela from Colombo and Dr. Shen from Koshong, invite Rocky Mewal, the Rising Star awardee recently, to go on and then tell us about the SH and SH with ACLF. Over to you, Rocky.
Thank you, sir. And thank you, Professor Sareen and Ashok, for giving me an opportunity to take on this. Because before I got this topic, I was feeling actually that maybe I'll get nothing to speak on this, because severe alcoholic hepatitis, we know most of our ACLF are severe alcoholic hepatitis. So there is definitely an overlap, but we got some very interesting data. So I'll be very quick, and most of the review which I'll be covering has already been covered in the consensus. But basically, just to suggest that when we look at alcoholic liver disease, we may see different spectrum. So the patient may come to us with mild to moderate alcoholic hepatitis. Definition-wise, we can have severe alcoholic hepatitis, decompensated patient with chronic liver disease, ACLF. So there's a lot of variation when we see such patients. And alcoholic hepatitis is one of the most severe form of liver injury in these patients. Now, definition-wise, all of us know that alcoholic hepatitis is defined based on heavy alcohol usages. The abstinence period has to be less than 60 days before the onset of jaundice, and the patients mostly have a high bilirubin. The AST is high, but has to be less than 400. The AST-ALT ratio is more than 1.5, and we have to exclude out other etiologies. And severe alcoholic hepatitis, we know that it is defined with the discriminant function score, which includes bilirubin and INR, two variables which we also include for defining ACLF, and a discriminant function score of more than 32 is what classifies severe alcoholic hepatitis. And we also know about all these scores which have been proposed specifically for assessing patients for alcoholic hepatitis, and we see the prognostic value of MEL score, the Glasgow Alcoholic Hepatitis Score, ABIC, and the Lille score, apart from MDF, is what is more popular and is used. And each of these scores, we see that bilirubin and INR is part of most of these scores. Some include renal functions. The Glasgow and the ABIC score also include age. So these are the important factors which are important while we assess and prognosticate patients with alcoholic hepatitis. And the Lille score actually looks at the changes in the bilirubin, and it has been developed only for patients who are on corticosteroid treatment. Now, the STOPA trial has been discussed, but it just highlights that prednisolone may not be very effective, which is supposedly the recommended treatment, may not be very effective, and the effects are seen to wane off, and pentoxifylline was shown to be ineffective in the treatment of severe alcoholic hepatitis patients. Now, these are two interesting studies which actually combine the static scores that we know, the MELD, the Lille, the BIC score, and the MADRE score, which are all static scores, and they tell us about the information at one point. And if you combine it with the Lille score, the prognostic assessment is better. So if your patient has a high static score and the Lille score, which at day 7 is a higher value, their chances of dying are higher, 70%, as against a patient who has a low static score or who has a low static but has a decrease in the Lille score. So a combination is better than using just one score in these patients. And this is the data from the STOPA trial, again, where they actually looked at all the patients and they did an analysis of all these scores. And what was interesting in this study, again, they said that the discriminant function may not be a very good score in this set of patients, and they found that it was performing in a it was worse than the EBIC score, GHS, and MEL score when they compared the statistics of these patients to look at the 28-day and the 90-day outcomes. And what were the key findings here? That the static scores, that is, they assessed the MEL score, the EBIC score, and the Glasgow score was superior to DF. And they showed that instead, if you're not using LILs and you're just using these scores, the low static scores, which are persistently low at day 7, this gives a better predictive accuracy as against when you use a LILs model. So they were suggesting that you should combine your static scores with the dynamic scores to assess patients with severe alcoholic hepatitis. Now, coming quickly to acute and chronic liver failure, and this audience knows about the distinctions that are there when we compare the Aclf definition given by the Acsl as compared to the Acsl. And this is the only paper which actually looked at the development of Aclf during the course of severe alcoholic hepatitis. So as is understood, the study showed that patients with Aclf were sicker. They used the Eclf definition. So this is not the Acsl definition. So they were having more infections, more renal dysfunction, and infection was shown to be a parameter which was leading to the development of Aclf. And they showed that MADRS score, the infection during follow-up, and the response to corticosteroids were important factors. Even though the response to corticosteroid was not an independent predictor of survival, it was seen that the severity of Aclf was guiding the treatment response, and the response was lower in patients who had higher grades of Aclf. Survival, as we can expect, the patients who had higher grades had worse survival. And this is a nice editorial by Professor Szabo, where she commented that severe alcoholic hepatitis will overlap with the definition of Aclf, and this is about the Western definition, but you can have Aclf in a patient who has alcoholic hepatitis. You may have other insults, and there could be mixed etiology of acute. You may have a background alcoholic liver disease. So Aclf and severe alcoholic hepatitis may show some overlap, but they are distinct disorders. Now, when we compare Aclf definition given by Acsl, we will expect that majority of these patients will have severe alcoholic hepatitis. And if we consider the Eclf definition, because this is based on the extrarenal organ involvement and infections, we know that there could be some overlap. However, all patients may not be having alcoholic hepatitis. So what I did here was, because the literature was not there, I tried to analyze the AARC data. And we just took out patients where we were not having too much of missing data. So total of 1,325 purely chosen acute and chronic insults being alcohol were taken for this analysis. And we can see here the spectrum of disease. So even in the AARC cohort, almost 10% of these patients had just mild to moderate alcoholic hepatitis. And the definition that we used was based on the MADRS discriminant function. Severe AH, but no Aclf, 6.2%, a very small proportion, and 83% of these patients with alcoholic hepatitis had Aclf. Now, the baseline characteristics, we can see here, between the 3 groups, there were significant differences. Patients with mild to moderate alcoholic hepatitis were older as compared to patients who had severe alcoholic hepatitis and Aclf. We can see here the parameters of inflammation, the C-reactive protein, the leukocyte count, lactate, and sepsis all was higher in patients with Aclf as compared to severe alcoholic hepatitis and mild to moderate disease. And the MELD and the MADRS discriminant function were also significantly higher in this set of patients. The number of organ failures, even in our set of patients, we found that patients with Aclf had more number of organ failures, and these organ failures were all defined based on the Eclf definition. Now, very interesting data that we found here was that mild renal dysfunction was not significantly different between the 3 groups. So all the 3 groups had some form of mild renal dysfunction, even though Aclf was having more renal involvement, but this was not statistically significant. However, when we analyzed high creatinine, stage 3 creatinine, serum creatinine, stage 3 AKI, and the need of dialysis, it was significantly higher in patients with Aclf, and it was not seen in patients with severe alcoholic hepatitis and mild to moderate alcoholic hepatitis. The survival curves can also show us the differences between the 3 groups, and the Aclf patients had the worst outcome. Now, interesting data. Now, this is the real world data of corticosteroids from the AARC consortium. We found that of the 1,300 patients, only 220 patients, that is just 16.6%, received corticosteroids. So either they were eligible, or even if they were eligible, many centers do not treat, considering the risk of infections and other problems. And of these treated patients, only 48.6% were steroid responders based on the day 7 Lills model. And again, very interesting, if we see non-severe AH who had Aclf, so 6 such patients who received corticosteroids, 80% response, as compared to 61% in severe AH, no Aclf, and severe AH with Aclf, a very low response of 45.8%. The responders had a definitely better survival as compared to non-responders. So therefore, patients who are given corticosteroids and have a response, they did well. And predictors of response to these patients. So we created 3 multivariate models. So I'm not showing you the univariate analysis. This is just the multivariate analysis. And what interesting data we found was age was one important factor. The mean arterial pressure, both these factors were significant in all the 3 models. And in 3 different models, we used the 3 different indices, which we used for assessing liver disease severity. So the MDF score of more than 72 was predictive of non-response. AARC grade 3 in the second model, and the MEL score cutoff of more than 30 was predicting non-response to corticosteroids in patients with severe alcoholic hepatitis and Aclf. In the AARC data, the prevalence and incidence of infections, also we can see here that it was variable. All the 3 sets of patients had infections, but Aclf was significantly higher incidence as well as prevalence of infection from day 1 to day 7. Corticosteroid non-response, so patients who had infection and subsequently got treated, in that set of patients also sepsis was higher in the non-responders, and at subsequent time points also sepsis was higher in the non-responder group. Then the predictors of 28-day mortality, we found sepsis, the AARC scoring, and in the second model, we found that lactate, arterial pressure, and hepatic encephalopathy were predicting the poor outcomes in patients with severe alcoholic hepatitis and Aclf. Now, this is something very interesting. We found that when we stratify these patients, so we are aware of the 32 cutoff, we are also aware of the 56 and other cutoffs which have been proposed from the Western cohort. This is our own data, and we found that there is a significant difference between 3 different DF cutoffs that we found, less than 72, 72 to 140, and more than 140. So clear differences in the survival rate, and more than 72 was also predictive of non-response to corticosteroids. And when we compared all the different scores, the static score and the AARC score, we found that the AARC was performing the best for both 28-day and 90-day mortality. This is the last part of the analysis. We found the data was missing. So whatever data we had, we found that in patients with severe alcoholic hepatitis, almost 18% were developing Aclf by day 7, and almost 78% remained in Aclf at day 7. So these are my consensus statements. Majority of patients with severe alcoholic hepatitis have acute and chronic liver failure at presentation. A subset of patients with mild to moderate alcoholic hepatitis may also have Aclf. The presence and development of sepsis is significantly higher in patients with Aclf as compared to severe alcoholic hepatitis and non-severe alcoholic hepatitis. The presence of mild renal dysfunction I've graded as C2 because this is unpublished and only from the AARC data. That mild renal dysfunction was not different. However, patients with Aclf had more severe renal involvement and requirement of dialysis. Then only a proportion of patients are either eligible or treated with corticosteroids in the Asia-Pacific region. The response to corticosteroids is an independent predictor of improved outcome. Sepsis is more common in steroid non-responders compared to responders and associated with higher mortality, and this substantiates the Western data also. Our data substantiates what is seen in the Western cohorts. And we found that higher age, which is also a part of most of these scores, the lower mean arterial pressure and liver disease severity were actually predictors of steroid non-response, and we found a cutoff DF of more than 72. And predictors of mortality, as I already showed. Thank you.
Thank you, Dr. Raki. And can I see my co-chairs, Dr. Nirella and Dr. Shen from Koishong, please? Do they have any comments before I could give my comments?
Yeah, just one comment in keeping with the sort of newer terminology. May I just suggest that we move away from using alcoholic to describe the disease entity and say alcohol or ethanol related hepatitis. The spectrum of disease related to alcohol is now preferentially sort of termed alcohol related liver disease. Can we do the same here?
Sure, sir. Thank you.
Thank you. Dr. Chen, are you there from Koishong?
Yeah.
Please
I have
go ahead.
one question. Because most of severe alcoholic liver disease have Aclf. So is alcohol-induced Aclf special from alcoholic liver disease or merely a clinical progression of severe alcoholic hepatitis?
Okay, thank you. I think this one pertains to the semantics probably. Should we be using SAH and SAH with the Aclf, because Dr. Raki has excellently shown the semantics of this particular issue and then overlap between these terms. The Eclf could do it very easily because theirs is SAH, and once organ damage develops, then it is Aclf 1 and 3, and obviously they have shown mortality increases and response to steroids also decreases as the Aclf grade increases. But if you take the Aclf definition, you can only say alcoholic Aclf, non-alcoholic Aclf, or you can say alcoholic hepatitis with Aclf, which almost relates to SAH. So this question, because rest of the statements which Raki has, of course, they're all appropriate, and there is an overlap between, and then Ashok can conglomerate everything and then put it into the right perspective. One can go on with the discussion about the semantics. Should we be using with SAH with Aclf or not is my question. Over to you.
So just to supplement here, nice suggestion from Professor Rao. Someone has presented also 2-3 sessions it as ALD Aclf. So is it good or SAH Aclf? So that we can think of ALD Aclf or SH Aclf.
Yeah, see, if you take the ARC data, you will not get information. You get information only up to what Raki is now presenting with the mild age and this one. One has to look at the data from the alcoholic point of view. All patients who are present with alcoholic hepatitis, how many will develop according to Aclf criteria prospectively? That will give us an answer. Indirectly, this given some answer here.
Yeah.
You can think about the semantics, but go ahead, please. Sorry.
Dr. Akhi, Mama, one suggestion to you. How can you differentiate between SH and SH Aclf? We should keep some statement regarding that in consensus, presence of ascites or any other thing.
In fact, that was my concern.
So patients with SAH or ACLF, so they have to meet the criteria which is required for the ACLF definition. That is what we used. And many patients they may have coagulopathy, which will not meet the criteria for, they may be deeply jaundiced but not coagulopathic. So they may meet the discriminant function, but they may not meet the criteria for ACLF or Acsl. So that's how the data, so very small proportion, 6% only in the data were actually SAH without ACLF. So most of our patients, because we are using the same criteria of jaundice and coagulation failure, most of them are having an overlap with the severe, but sorry, Ashok, I didn't get you.
Yeah, we can keep one statement, otherwise SAH. Yeah, we can keep one statement that severe alcoholic hepatitis fulfilling the criteria of Acsl should be considered as SH with ACLF. We can keep one like that. Or ascites or any other things, because
We can propose that
And
treating
second,
severe
also there is one
alcoholic.
debate about.
I think so. We can create our
Yeah,
own score based on DF and ARC score because they are performing very well, and we are having our own cutoffs from the data.
Yeah.
And we can propose an algorithm for how to treat these patients with alcohol-related ACLF and alcoholic hepatitis. Because even if patient is not meeting mild, they are in the criteria below 32, like Professor Ashmi Singhal was also suggesting. So even in that set of patients, if they meet criteria for ACLF, and you're treating corticosteroid, you're giving them corticosteroids, they are having a very good response of 80%. So it is about treating and catching patients early on for treatment rather than dealing.
Yes, ma'am, I can suggest that you can develop an algorithm so we can keep it in the consensus statement also, because that is the crux of this consensus statement also. That will be helpful.
Any other comments from the chairpersons, please?
Can I ask a question, sir?
Yes, please.
Yeah, Professor Aki, congratulations, excellent lecture, and I really enjoyed it. You have made a statement stating that although the mild renal dysfunction is equal in severe alcoholic hepatitis and SAH, ACLF, but the need for dialysis is much more in ACLF, SAH, ACLF. So, do you think this is more or less reflecting the, is it really that it is more of a dialysis need, or is it just reflecting the severity of the disease and more SIRS?
Yeah, you're absolutely right. It is like they are having more severe disease, more severe systemic inflammation, higher severity of AKI, and that's why the need of dialysis is coinciding with it. Basically, I wanted to say it is stage 3 AKI and dialysis, which was more common in this set of patients as compared to the other groups.
Yeah, I mean, so should it be there at all in the as a statement? That's
No, we can remove it also. It's that's what this is
Yeah,
unpublished.
we can keep it in the AKI section otherwise. We can move it to the AKI.
Any other comments from Professor P.N. Rao or Madhur?
Nothing. We just discussed about the semantics, for quite some time, about what to call a SAH, ACLF, or we just had a discussion.
So there is a discussion.
Okay. Thank you, Dr. Rakhi, for a very nice talk. I had to briefly step out. Thank you all and the chairpersons, and this brings us to the final task. We have not developed all these consensus statements as of now, but we will collate all the statements. I have to say a few things. One, many of these things are still in the evolving stage, but I can see the commitment of our colleagues, and there is an initiative which probably in this decade we will have a global study on the basis of ARC and others. I have taken this initiative because in the October we had the part 1, and this is part 2 of the APSL consensus, which should be hopefully ready in next 4 weeks. The consensus statement will be circulated to everyone for their comments. We would like this also, each of these talks, if the people are ready to be included as full manuscripts, we will have to get this peer reviewed, and also would like the speakers as well as the chairpersons to continuously guide. There is so much data every day. We would like ARC is everyone's, so we are hoping that each one of you will contribute more to the patients fully. Now there is a totally web-based simple performer, and we hope that all these slides with this symbol of ARC, the logo which was approved by everybody, will be included. We were very lucky that we have nearly 40 plus panelists, chairpersons, speakers, and many of them are from the West. I hope that within next 4 weeks we should be able to have a good compilation, and we move forward in this decade with greater speed. I would like to thank Ashok and his team for having put up this program. Ashok, you have something else to add? If not, thank you all for your contribution, and I hope we will have the next webinar coming soon for the AARC meeting, and we have done 50+ webinars. Thank you all.
Thank you so much,
Thank you.
Professor Sarin. Thank you all. Bye.
Bye.
Thank you very
Professor
much.
Sarin, thank you very much.
Thank you.
This was really excellent meeting. I enjoyed very much.
All our repetitors as well. Thank you. Sure.